Hello. Check this one two. Mic check. Hey, hey. Mm-hmm. Hello. 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 Check. Hello. 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 Check this one two. Mic check this one two. Check testing one two. Check this one two. Check testing. Hello. 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 Mic check. Mic check. Mic check. Mic check this one two. Hello. Hello. Mic check this one two. Hello. 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 Mic check this one two. Hello. Mic check this one two. Hello. 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 Mic check this one two. Hello. Check this one two. Hello. Check this one two. Hello. Hello. Check this one two. Mic check. Hello. Check this. Hello. Check this. Mic check this. Hello. Hello. Mic check this. Mic check this one two. Hello. Check. Hello. Check. Hello. Check. Hello. Check this one two. Mic check. Test. One two. Check test. Hello. Mic check. Test. One two. Hello. Check test. One two. Check. Kelle. Hello. Check test. One two. Mic check test. One two. Check testing. Hello. Check test. Mic check test. Hello. Check. Zoom. इथे लिहिलं नाही ना काय कसं कळेल. हॅलो चेक. हॅलो चेक. हॅलो 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 चेक. हॅलो चेक. हॅलो हॅलो चेक. लास्टचीच असेल रे. हॅलो चेक. हॅलो चेक. हॅलो हॅलो चेक. हॅलो चेक. हॅलो चेक. हॅलो चेक. हॅलो चेक. हॅलो चेक. हॅलो 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 चेक. हॅलो 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 चेक. हॅलो चेक. हॅलो हॅलो चेक. हॅलो चेक. हॅलो चेक. Hello check. Hello check. Hello check. Test. One two check testing. One two check testing. Hello check. इथे. Hello check. तू दिली इकडे. ईपी दिली का तू. बघ ही आहे का. त्याला मगाशीच बोललो नावली. हॅलो चेक. हां हां मिळाली. हां बघे. ह्याचा ऑक्स बंद ठेवला पाहिजे ना. है ना. हॅलो चेक टेस्ट. माइक चेक. हॅलो चेक टेस्ट. वन टू. अरे प्यारे दोस्तों. हॅलो चेक टेस्ट. म्युझिक कशी बंद झाली आपली.
Yeah. Today not possible, sir. Already full, sir. Where are you, sir?
हॅलो चेक टेस्ट चेक टेस्ट हॅलो चेक टेस्ट आणि हा तुझा कुठला माईक घेतोय ते बघा हॅलो चेक टेस्ट हॅलो चेक बघ हॅलो प्री 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 पोस्ट त्याला पडाय प्रियाने पोस्ट हॅलो चेक आता येते आवाज येतोय ना हॅलो चेक हॅलो चेक हॅलो चेक हॅलो चेक हां हां येतो एक मिनिट हॅलो चेक हॅलो चेक हॅलो चेक टेस्ट 1 2 माइक चेक टेस्ट 1 2 हॅलो 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 चेक टेस्ट हॅलो चेक हॅलो चेक हॅलो हॅलो चेक हॅलो चेक टेस्ट 1 2 माइक चेक हॅलो हां हां बोला ना एक मिनट
Check test, mic testing 1 2 3 4. Hello, check.
केलंय आता कुठे हा शेअर स्क्रीन ओके आलं कॅन यू सी पुट इट अप या हॅलो थँक यू फॉर इन्व्हाइटिंग मी टू दिस esteemed meeting. I am really sorry I couldn't make it because of an illness, but I'm sure we'll be able to discuss online. Okay. Okay. So you will send the link to Dr.
Check this. Hey, check 1 2 3 4.
check, 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 check. Hello. Check, check.
Hello, check test, mic testing, 1, 2, 3, 4. Hello, test, mic testing, check. Hey, check test. Okay.
Check, check, check. This, check, 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 check. Hello. Check. Hello. Check, check, check. Hello. Check, check. Hello. Check, check, check. Hello. Check, check,
Hello. So, good afternoon, everybody. It gives me a lot of pride and joy to be standing here to welcome you all for the AOC Symposium 2026. And we begin on time, and it has been our plus point that we have always stuck to the time. So we'll begin our proceedings, and we start with the inauguration. And I will invite all our faculty for the lamp lighting. We'll start with Dr. Pelajani, sir, our Emeritus Chairman. Dr. Satyavan Sharma, our Chairman, current. Dr. Akshay Mehta, our Vice Chairman. Dr. Ajit Desai, our Secretary. Who else? Dr. Bhagwat, Dr. Uday Jadhav, Dr. Milind Phadke, I don't see some of our council members. Okay, anyway. Hurry, Dr. Gupta is here, sir. Sir, please come. I was searching for you there. Come.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
I will request our founder and emeritus chairman, Dr. D.B. Pelajani, sir, to say a few words. Thank you.
Friends and colleagues, this is perhaps the 27th or 28th meeting of the Academy of Cardiology, which was established in 1997. And our main aim is to be present to or train the doctors who are practicing to pick up the scientific basis of their clinical practice. So basically it has been a combination of science and medical practice. I hope all these years when you attended, you have sort of imbibed what has been taught here. Particularly, I must say, my colleagues, Dr. Satyavan Sharma, Ajit Desai, Bhavesh, Akshay Mehta, Gupta ji, Uday, I think they've been the backbone of this society. And I would now request Satyavan to come and say a few words, who has taken up the reins of this society. It's a small society, but a very enlightened society. So as it's always said, small is beautiful. So I think we are a very close-knit group. Thank you very much.
Good afternoon, friends. I take this opportunity on behalf of Academy of Cardiology to welcome all of you to our annual meeting. For last couple of years, we have been doing meetings which have been theme-based, and this year's theme we chose was coronary artery disease in the young and sudden cardiac death, a very apt topic with the issues which we are facing in the society. Dr. Bhavesh Wazifdar and my other colleagues have put a lot of efforts in designing a very elaborate program. And we have been very lucky to have excellent faculty. We have one international guest, Dr. Sumit Chugh. We have a couple of friends who have come from out of Mumbai, from Delhi, from Chennai, from Bangalore, Hyderabad, and we have many guests, many friends from Mumbai. The topics have been chosen with great efforts, and I'm thankful to all our academic colleagues and also to Dr. Amit Vora, who gave me a lot of substantial information about choosing the topics on sudden cardiac death. The program has become extremely tight, and I'll request all the speakers to kindly be punctual and be in time so that we can.
Well, I'll be very brief. We have a lot of wonderful speakers in science. I just want to say how grateful I am and how privileged to be here today. Dr. Pelajani, whom we will be honoring soon, and to Dr. Satyavan Sharma, Dr. Desai, and all of the organizers. And I'm really looking forward to a wonderful meeting. Thank you very much.
So I think the lamp lighting has gone as per our tradition. We are sticking to time, and in fact we have still about 5 minutes ahead of schedule. But we can start with our first session. Milind, if it's okay. So I hand over the proceedings to Dr. Milind Phadke, who is going to be coordinating the scientific session. Come, Milind.
Good afternoon, respected seniors, colleagues in the audience. We are going to start, and as you know, they are going to be very tight, very packed sessions. So we have to be a little particular about the time limits. We have already told the same to the chairpersons. And I request all the speakers and all the discussants to please stick to the time limit. We'll be reminding from time to time. Please don't take us wrong if we at times have to be a little strict about the period time. So the first session is on CAD and SCD in the young, and I request the chairpersons, Dr. S.B. Gupta, Dr. Bharat Shivdasni, and Dr. Vinay Jaiswal, my dear friend from New Mumbai, to please chair the session.
Hello. Yeah. Good afternoon, friends. I think without wasting much time, the topic is CAD and SCD in young, and we have got very learned speakers for this session, Dr. Anil Dal, Dr. C.K. Ponde, and Dr. Pradeep. Only thing I would like to mention that we had a discussion amongst ourselves, and I think we suggested this topic of CAD in young, and then the sudden cardiac death also came into the picture, and we are going to have interesting sessions and interesting talks. So I'll ask Dr. Anil Dal to just come over and give his talk on risk factors. Does gender make a difference? Dr. Anil Dal, please.
Thank you, sir. It's wonderful to be here with teachers and friends. So it's a difficult topic to cover in 10 minutes, to cover gender differences in premature coronary artery disease and sudden cardiac death. Sudden cardiac death became very popular because the media made it popular. Raju Srivastav, Jiming, barely 500 meters as the crow flies from All India Institute, crashes, cannot be resuscitated, brought in dead. The nation watched as he died. KK, who sang Pal Do Pal, is holding a concert in Kolkata. He has chest discomfort. His staff actually takes him walking. He gets off the stage, takes him walking to his hotel. By the time he reaches the hospital, well and truly dead. Young people dying. But does gender also play a role? I just had Dr. Nathani tell me that last week he had 3 young ladies below 30 years of age who presented to their hospital with extensive anterior MI. Men do have a higher incidence, but among women, the diagnosis is usually missed and mortality therefore occurs. Now this topic is very extensive, so you'll have to pardon my brevity, and I'll only be pointing out a few things on the slide. But if you look at it, we all know 3 causes of cardiac arrest. Ventricular fibrillation, usually precipitated by a fast ventricular tachycardia. Second, being cardiac asystole, less common, pulseless electrical activity. But most of our focus is actually on whether it is coronary artery disease, whether it is structural non-ischemic disease, or there are some electrical problems which are causing it. Even if you look at global data, and we always confess that India doesn't have great data, but most of the SCD occurs without a real diagnosis. Even if we do autopsies and we do molecular autopsies, we still don't know the diagnosis. And no cause can be detected, even post-mortem. Males predominate. Females are less likely because most of them have presentations which are a little older in age, but I think the patterns are changing and gender may not be that important. If you take a closer look, women die at home during sleep, may have more pulseless electrical activity or asystole rather than VTVF, less likely to receive bystander CPR, less likely to survive, and most of the data is aggregated from what is in men. Because men smoke, women also smoke. They have more evident dyslipidemia. Genetics, everybody is bothered about the person who's the male of the house. But women have specific risk factors which relate to the hormonal changes in their lives, whether it is at the time of pregnancy-induced hypertension or gestational diabetes, whether it is polycystic ovarian disease, whether it is bad obstetric history, whether it is autoimmune diseases, whether it's pregnancy itself, which can be a cardiovascular stress test, or post-menopause when there's an acceleration in disease. But if we are to segment SCD causes, largely we think of women having non-ischemic causes. So in men, it is going to be coronary artery disease, maybe cardiomyopathy, ARVC, Brugada. Women would have specific CAD like SCAD, Minoca, postpartal, peripartal cardiomyopathy, and some channelopathies. So the mechanistic framework would be, ischemic would be either an atherosclerotic disease or a spasm, structural would be hypertrophy or arrhythmogenesis, and the electrical would be channelopathies. Young is not the same as low risk. A normal angiogram is not benign. Sex-aware cardiology saves lives, and males account for majority, but etiology does differ. Females have higher non-ischemic, non-atherosclerotic, structural cardiomyopathies and channelopathies dominate under 35. There are triggers and modifiers, exercise for men, QT prolonging drugs for women, stress, stimulants, and sleep deprivation is important. And if gender is important, what must change? We must recognize that young women and men have different diseases. We must integrate pregnancy history, oral contraceptive use, familial hypercholesterolemia and lipoprotein a. We should shift prevention beyond hospitals into homes, gyms, workplaces, communities, and we must modify phenotype, timing, as well as outcomes. Very elementary to think that men do have larger flow-limiting epicardial atherosclerotic plaques. large plaque burden, especially proximal LAD, though we have diffuse disease in our country. Women form a substantial portion of those who have ischemia with non-obstructive coronary arteries, but these are not benign conditions, and MINOCA does account for 5 to 15% of all MI, and their MACE rates are clearly non-trivial. SCAD, hormonal shifts, connective tissue disorders, fibromuscular dysplasia are important. We all see this every day, and we wonder about rupture and erosion phenotype. Men do have a higher incidence, plaque rupture dominates. Women have a lower incidence. Women smoking is increasing in our country more than men. More plaque erosions, more MINOCA, more microvascular dysfunction. And if you look at some of the risk factors, they are similar, but lipoprotein a appears to be stronger in women. Men are more likely to have obstructive epicardial disease, but there's going to be more shear stress in women who have smaller coronary artery disease. Their presentations, as we all know, may be atypical, and we know that there can be standard risk factors which are going to continue to be important, and more than 50% of the risk is going to be attributable to the 5 standard modifiable risk factor, and the cardiovascular prevention may lead to better benefit in women compared to men. And here is a comparison. Female smokers do worse. Females with metabolic syndrome do worse. So this is actually important. Looking at MINOCA, we know that you can have Takotsubo, you can have INOCA, MINOCA, or many of these conditions. You know, we need to understand the diagnostic pathways. SCAD, we understand SCAD. It is typically a women's disease. But the red flags in young MI, we should look at MI less than 45 with few or no conventional risk factors. If you do have eruptive xanthomas or tendon xanthomas or very high LDL, look for familial hypercholesterolemia. Look for a strong family history, and then look for lipoprotein a. And if you have a near normal coronary angiogram, don't dismiss it. Think of MINOCA, SCAD, and especially MIs in pregnancy or postpartum period. Hypertrophic cardiomyopathy, we understand, and there are several markers, especially if you are developing LV dysfunction, amount of fibrosis, apical aneurysms, specifically some genetics and an abnormal exercise BP response. So these are some things which, especially the sarcomeric variants. So we have sarcomeric and non-sarcomeric mutations. And if we are looking at some of the sarcomeric mutations, we understand that they are more in women, but usually women have more heart failure, whereas men have more sudden death. So if you look at the sarcomere positive variants, they have more ASH, they are younger age, higher prevalence in females, but overall higher mortalities from heart failure rather than sudden death. What about the athlete? We all think of people, everybody tells people to work out, and we cardiologists are not different, but we must not forget a guy called Philippides, after whom the marathon race was started, and this guy died after running from Marathon to Athens in 490 BC. Because the heart by these ultra athletes remodel, there is RARV dilatation, there are elevated cardiac markers, there is more fibrosis, there is more atrial fibrillation, and there can be chronic structural changes. These have been documented even on MR, because sometimes these athletic remodelings can be extreme, and fibrosis is not uncommon even in seemingly healthy athletes, and we must make a difference between non-hinge point fibrosis versus hinge point fibrosis, because non-hinge point fibrosis actually increases the potential for ventricular arrhythmias. So CMR is an important risk stratification in athlete heart syndrome. Scar patterns should be seen, and a normal CMR does not exclude pathology. ARVC certainly has a higher onset, earlier onset with a male predominance. Females usually present a little later, and they present with multiple tricuspid valve disease and RV failure. So if we are really looking at channelopathies, it's a very complex relationship with genetics, epigenetic factors, genomic relations, hormone regular influences, and exogenous factors. And I don't want to take you through the action potential duration, but Brugada certainly has a male predominance. And we know women present later because the testosterone enhances the ITO and reduces the ICAL, promoting male predominance. Now, I put this ECG because I like it. It's an ECG I put in many exams because there is T-wave alternance, which is a sign of long QT syndrome. And again, female susceptibility, there are specific drug triggers. I would like you to concentrate here because estrogen is pro-arrhythmic, decreases the IKR. Progesterone is QT shortening. And testosterone also leads to QT shortening. So therefore, the hormonal milestones also translate into low risk during pregnancy, but higher risk in the postpartum, increased risk in perimenopausal, and there are individual high-risk female subgroups. CPVT has minimal sex difference, but short QT has male preponderance. So if we summarize these hormonal mechanisms, simply speaking, estrogen prolongs QT, testosterone shortens QT, and risk varies according to life stages. Pickel-Haube syndrome, mitral annular disjunction, strong female preponderance. So if we look at this, we can conduct molecular autopsies, which should be different in male and female, but I'm coming to something which should affect all of us, and that is the fast food and ultra-processed diets, which is uniform to both the both the sexes, tobacco, alcohol misuse, and recreational drugs, and unsupervised gym training and sudden cardiac death. I know Mumbai has done yeoman work to train people to do bystander resuscitation, but in our all humble effort, we finally, along with the DMC Ludhiana, we could convince the government of Punjab to actually bring out the only advisory to regulate the proliferation of gyms in this country. So the state of Punjab is the only place where we managed to get this advisory out. I have been trying for the last 6 years to try and get this done. Last slide. So the causes can be ischemic, which are atherosclerotic. They can be non-obstructive, pregnancy-associated, structural. There will be differences in gender, in electrical abnormality. So the key message is young is not the same as low risk. Have mechanism-based, sex-aware evaluation. It will save lives. And there is just so much more to understanding women. Thank you.
Thank you very much. We'll have the discussion after all the three talks. So I'll request Dr. Bharat.
So after this lovely talk by Anil, the next talk, role of genetics, family history, lipoprotein small a, and polygenic scoring by Dr. C.K. Ponde.
Thank you very much indeed for making me come here, but I think Bhavesh and Milind has given me almost mission impossible to cover this thing in less than 10 minutes, but I'll try my best. So let's talk with family history. Family history definition has been expanded, and that is the most important slide I want here. At least one first degree relative with early onset CHD, men less than 50 and women less than 60. Here, history in siblings is more riskier than the history in parents. At least one first degree relative with late onset CHD, at least one second degree relative with early onset CHD, two or more affected second degree relatives regardless of the age, and last, important, what Anil Dal was speaking, in women, even of one first degree relative having diabetes is a major family history positive. And there are several studies. This is one study which was a prospective study which has shown that patients with genetic predisposition have recurrent events, and they should be included in the current guidelines for more aggressive pharmaceutical management. In MESA study, people with zero calcium score, which are considered low risk, but divided into two groups, family history positive, family history negative. Those with family history positive had 70% more increase in cardiovascular events over 7-year follow-up. There is also a relationship between family history and premature coronary artery disease and the risk of death. The mortality is also high in these people. And in the ECAD registry, positive family history of premature coronary artery disease had higher long-term mortality. 9.2 years was a follow-up after conventional coronary angiography. And there are several studies here confirming family history as a strong and independent risk factor for CAD, MI, and SCD. 6 of them prospective studies, 3 of them retrospective studies, and other case control studies. Family history of risk of sudden cardiac death also has been confirmed with Seattle case control study, Paris prospective study, and we know the largest study from Netherlands and Finland. There is also an association between family history, the polygenic genetic risk score, and the severity of coronary artery disease. And there has been an overview which is worth reading, but at the end of the day, what is the impact on individual risk? So if you have a family history with a first degree blood relative or premature CAD, your risk increases by 2 to 12 times, depending on your age. Second, kinship strength is important. Sibling history is more riskier than the history and the parents. A strong family history is frequently associated with premature coronary artery disease, more extensive disease, has higher mortality over the long term. And it is independent predictor even when traditional risk factors like smoking, high blood pressure and diabetes are absent. And therefore, family history of premature CAD is now declared a major risk factor by European Society of Cardiology, European Atherosclerosis Society, Lipid Association of India and the CSI. All guidelines, family history is a strong risk factor, major risk factor. Let's go to lipoprotein little a. Why it is called little a? Because this is the lipoprotein which is apobic containing most atherogenic lipoprotein. Though, why do we measure it today? Because it is causal, it is common, it contributes to the risk, and now we can act on it. Because phase 3 trials with a lot of good molecules are on the way. But remember, more than 90% of plasma LPA is genetically determined. So measuring it just once in lifetime suffices. High LPA levels are common. So in Asian Indian ethnicity, almost 30% of men above the age of 40 will have high LPA of more than 30. And in Africans, this incidence or this prevalence goes up to 55%. So African ethnicity have highest positive rates of LPA. LDL particles are more abundant than LPA, but LPA's atherogenicity per particle is 6-fold more than even a dense LDL particle. What does that mean? That impact of LPA on the plaque is pro-inflammatory. LPA destabilizes atherogenic lesions and increases the risk of events. So if you see a low attenuation plaque in the CT angio, those who are LPA negative, over next 6 years, the rate of MI will be 6.5%, and that with LPA high will be almost 4-fold more. Genetics provide a strong support for a causal continuous association of LPA with ASCVD regardless of ethnicity. So there's higher incidence of MI, higher incidence of aortic valve stenosis, today is the area of TAVR, and ischemic stroke and heart failure. Lifetime risk of MACE progressively increases with the lowest quartile of LPA to the highest quartile of LPA. And the proportionate increase is around 8-fold as compared to when you have LPA, which is normal, less than 30. And therefore, the NLA updated guidelines 2024 say less than 30, normal, 30 to 50, intermediate, and more than 50 is high. Currently, we are all looking, when you deal with a patient with high LPA, what do you do when targeted molecules are not available? Number one, target your LDL lower than what the ASCVD risk category dictates you. Suppose the ASCVD risk category dictates you a 70 LDL, but the LPA is very high, you target that LDL to 50, and so on. You have cascade screening, you have lifestyle measures, and you have probably PCSK9 inhibition, like inclisiran, 22% reduction in LPA, and evolocumab, around 18% reduction in LPA. However, the outcome studies with inclisiran and evolocumab on CVOT benefits of LPA reduction with these molecules are not yet there. They are all post hoc analysis of their individual trials. There is also a relationship between LPA and family history. So if you have family history and LPA combined together, your risk geometrically increases. So LPA is highly heritable. It increases the CAD risk independently of family history. When you combine both, the risk is even much higher. And elevated LPA accelerates atherosclerosis with earlier CAD onset, particularly in the young. So high LPA linked to complex multivessel disease and increases the risk of sudden cardiac death in patients with known coronary artery disease. At the end of the day, LPA targeted therapies are on the way. And I just hear that pelacarsen is now in phase 3 randomized trial. In the coming March end, we will have results out. And I just heard a buzzword from Novartis that people with high LPA and high atherosclerotic cardiovascular risk now Novartis is likely to give inclisiran, likely to give the pelacarsen to them free of cost, provided they pay the fees for the import license. All right? What does the future hold? The future, see, those so many trials, I'll not go into details, but I think horizon is right at the horizon, and we'll have something good news by the end of March this year. Polygenic risk scores. Why polygenic risk scores? Conventional risk factors are inadequate, and that's why many patients keep on asking you, doctors, I don't have family history, I don't smoke, I don't have diabetes, I am teetotaler, I am a non-drinker, I am a non-smoker, why did MI occur to me? And that is exactly what happens in younger population, because traditional risk factors are inadequate. In contrast, genetic risk of CAD is age independent and can be assessed right at birth, enabling early, lifelong, primordial and primary prevention strategies taken into account, taken or implemented very robustly. So the beauty of polygenic risk score is it can be determined at birth, does not change throughout one's lifetime, and therefore prevention strategies can be started at a very young age. Just to understand, what is a polygenic risk score? It represents the sum of risks conferred by several DNA variants to estimate the likelihood of disease among an individual. So forming a polygenic risk score requires using a list of multiple SNP, single nucleotide polymorphisms, and their respective effect sizes as determined by genome-wide association studies. So you do genome-wide association studies, variant selection, then you do the linkage disequilibrium adjustments, and then you form a PRS. Dr. Ajit Mulasari was just showing me one of his papers published just recently on 3 Asian Indian ethnicities, close to 660,000 patients with hazard ratios quite impressive with a polygenic risk score applied. And these were 2 editorials, polygenic risk scores and coronary artery disease, and an outbreak of polygenic risk scores for coronary artery disease, worth reading. And the ESC, cardiovascular risk collaboration, has shown the clinical utility and implementation of polygenic risk score in general population coming to you, me, and everybody else in the outpatient clinic very emphatically, and they state that polygenic risk scores are there. The problem of polygenic risk score is only one. Until now, majority have been studied in European ancestries. So their applicability in Asian and South Asian ancestries may be questionable. But people coming to you with high risk, no problem. You know what to do with them. But patient coming to you with apparently low risk, these are the people in whom you apply polygenic risk scores, and 40% of them then they get reclassified as moderate or high risk. So that is the beauty of polygenic risk score. These are the studies published from our own clinical research department. We started long ago in 2016, genetic determinants of lipid-lowering response to atorvastatin therapy in Indian population, quite well accepted and cited. And now recently, we have done differential methylation patterns in coronary artery disease, young MIs coming to our department. So I think there is a place. Advantages are one-time test, lifelong risk estimate, low cost, scalable, and ancestry translatable to a certain extent. And it enables precision primary prevention. That is the solid strength of polygenic risk scores. But the problem is, it is dependent on genome-wide association studies. And many risk variants still remain undiscovered. We have limited accuracy at the individual patient level and poor transferability of the data across non-European ancestries. But what Dr. Ajit Mulasari showed me the study now, I think, Ajit, your paper has all Asian Indians, right? So I think that will be applicable to our population. So what do you take home? That's the last slide of mine. Family history of premature coronary artery disease is an independent predictor even when other risk factors are absent. It increases the risk of an individual by 5 to 12-fold, with a CAD appearing a decade earlier with higher risk of mortality. So those with positive history merit aggressive primary prevention. PRS can identify individuals as substantially elevated lifetime risk. However, PRS can also identify people who derive greatest benefit from statins and PCSK9 inhibitors. And I think that's another beauty of PRS. LPA is ready for prime time. It is indeed ready for prime time. It is an independent, highly prevalent risk factor and must be measured once in lifetime in men and twice in women. Twice in women, if the woman is young, once, and 5 years after menopause, second time. All right? With pelacarcinoma on horizon, we have added opportunity to reduce ASCVD risk over and above LDL reduction. Thank you very much indeed.
Thank you, Ponde sir, for that enlightening talk. Now I would like to invite Dr. Pradeep Vaideshwar sir to speak upon sudden cardiac death, arterial and osteal. That's the topic.
Good afternoon. I'm sure all in the hall are very well aware of the various definitions of the term sudden death, and also that most of the cases of sudden death are caused by congenital or heritable and acquired cardiovascular disorders. And these disorders either produce structural cardiovascular disease, or sometimes they can also have a normal heart, especially at autopsy. In 2020, the government of Maharashtra passed a resolution whereby 22 police stations were put under our tertiary care center, and hence tissues from natural and unnatural sudden deaths were sent to our institution for histopathological analysis. So the presentations are based on our experience in those cases, which is roughly about 2,000 hearts which have come from medico-legal autopsies. And most of these cases were less than 40 years of age. In this session, I will present 7 case scenarios where the cause of death was related to either coronary arterial or osteal disease. Let me start with case number 1. 27 years male, sudden collapse while playing cricket. These are the cross sections of the left anterior descending artery in its proximal portion, which shows critical stenosis produced by a fibrofatty plaque. In addition, the stenosed lumen is also occluded by the presence of red-brown thrombotic material. What we can also see is the presence of distinct plaque fissuring, which is close to one of the shoulder, and this niche, if you see the bottom image, is filled with a thrombus. So this was an example of plaque fissuring and occlusive thrombosis, epicardial coronary arterial disease because of atherosclerosis in the young. 27 years male, sudden collapse while, sorry, what happened? Yeah. 29 years male, acute chest discomfort. There was weight gain through protein supplements from 61 to 108 kilograms in 6 months. And this is once again the cross section of the left anterior descending artery, and the lumen is occluded by a fresh occlusive red-brown thrombus. In contrast to the previous picture, here the degree of atherosclerosis is extremely small. It is present only towards one circumference of the artery, and most of the lumen is blocked by fresh thrombus. Hence, this is coronary arterial thrombosis, and possibly there would have been some element of hypercoagulability which may have been induced by the protein supplements or some other anabolic steroids which the patient may have been consuming. Let us go to case 3. This is 14 years male, fainted in the school premises and declared dead on arrival at a nearby hospital. Cross sections of the right coronary artery which is once again showing you extreme stenosis due to gray-white circumferential expansion of its wall. To our great surprise, not only was the right coronary artery involved, but there was also involvement of the left anterior descending artery and the circumflex artery because of panarteritis. And here we see a granulomatous inflammation involving all the layers of the artery, and because there was presence of added involvement of the lung and the liver, we could label this as tuberculous coronary arteritis, producing panarteritis of all the three coronary arteries, an example of non-atherosclerotic epicardial coronary arterial disease. 36 years male, known hypertensive on regular therapy, sudden collapse. The cross section at the mid portion of the heart shows the presence of concentric left ventricular hypertrophy, and in addition, you can also see foci of congestion in the myocardium. Now, these were because of the presence of multifocal healing infarcts in the subepicardial, mid-myocardial, and subendocardial regions. All of this was because of involvement of the intramural coronary arteries in the form of either fresh thrombi or organized to recanalized thrombi. So this was an example of intramural coronary arterial thrombosis with circumferential multifocal infarction. And unfortunately, the cause for this small vessel thrombosis could not be ascertained because no investigations had been done at autopsy, and other organs also did not show such microangiopathy. 27 years male, death on the treadmill, and the very innocuous feature that we noted was an abnormal origin of the right coronary ostium. It is situated on the left side of the commissure between the coronary cusps, adjacent to the left main coronary ostium. So in other words, this was anomalous origin of the right coronary artery from the left sinus of Valsalva. 9 years male, fell while running. This is the opened out right ventricular outflow tract showing a coronary ostium which is present over the left posterior pulmonary valve sinus. And this was noted on external examination where we see the left main coronary arising from the root of the pulmonary artery and entering the anterior interventricular groove. So, an anomalous origin of left coronary artery from the left posterior sinus of the pulmonary valve, an example of congenital coronary ostial abnormality. And the last case, 22 years female, postpartum, clinically preeclampsia with impending eclampsia. She had acute dyspnea and sudden collapse. The blood pressure was 240 by 180 millimeters of mercury. Opened out left ventricular outflow tract. It shows dilatation of the aortic annulus. There is separation of the commissures, and the free margins of the cusps show rolling and eversion, indicating that this patient has had acute or chronic aortic regurgitation. In addition, there was thickening of the wall of the ascending aorta and a typical tree bark appearance, and obviously you can barely see the coronary ostia. When we studied sections from this area, it showed involvement again of all the layers of the aorta. There was necro-inflammatory destruction of the aortic media, fibrocellular thickening of the intima, and much more effects were seen in the adventitia in the form of extreme fibrosis, presence of lymphoid aggregates, and you can also make out under the scanner view presence of endarteritis of the vasa vasora supplying the aorta. So all these are features of nothing but Takayasu's arteritis with coronary ostial stenosis, which was misdiagnosed as toxemia of pregnancy. And unfortunately, since this was a medico-legal autopsy, the entire aorta was not sent, and hence the degree of aortic involvement was not known in this case. Thank you very much.
Hello. Thank you very much. We have got, I think, 10-12 minutes for the discussion. I think Dr. Anil Dhal, can I ask you one question regarding male and females? What will be the percentage of young males or females without risk factors having coronary artery disease?
So, a large percentage of both males and females who do succumb to coronary artery disease when they are frightfully young do not have risk factors. So it's more than 50% of both males and females. Unfortunately, it's very difficult because we are only talking about the conventional risk factors. If we go beyond the conventional risk factors, we could still probably gauge a few more. But the truth is that in patients who die suddenly, about 50% of them, we actually don't even know what is the actual cause of death. You don't have such detailed pathological reviews. We do not know. We dismiss many of them as being possibly a coronary event, possibly an electrical event. So it becomes very difficult to have a precise percentage which we can give. It is largely speculative. But yes, in the very young, there are people who don't have, a large percentage of them, both males and females, do not have standard risk factors.
Thank you. Dr. Ponde, please. Dr. Ponde, one question to you. I just wanted to know, normally in adults, the LPA level will remain stable.
Yeah.
But we have seen so many reports where LPA levels fluctuate too much. What could be the cause? Whether it's because of the lab errors or it really fluctuates?
Acute, changes in renal function, liver injury, acute liver injury, or any other chronic inflammatory state is known to change LPA by around 4-5%. That's all about it. So anything, I don't think it changes beyond 5% in an individual. You have any patient?
Normally I've seen in some reports it's the variation is maybe up to the tune of 50% or so.
No, statins over long term do increase LPA by around 8 to 10%. Statins do increase LPA by around 8 to 10%. But I think nothing beyond that. Any of you know?
So I think one of the things which I thought I will ask you is that we till now, because pelacarsen has not yet been not available, we are all going by the European and US guidelines which say once in a lifetime estimation. But once we start controlling it, then the once in a lifetime estimation should change. The second question is that we also know that lipoprotein little a is not a uniformly homogeneous structure. The kringles do change. No, not much work has been done in the specific kringle association. So we understand that Asian population has about 25%, 30%. The African descent has about 50%. Europeans also have about 20-25%. And at this point in time, we can't use any expression more than
one thing that was added in your slide was the use of aspirin. There is a good cohort study from the MISA cohort that people whose LPAs were more than 50 milligrams %, they had a 50% reduction in events over long term. So aspirin is a very good practical tip till we get pilocarcin.
What I do is, I use aspirin only if the LP is high. And see evidence of disease elsewhere either.
So, go ahead.
So I really enjoyed all three talks, very, very nice. And I had one question. There was no mention of what the less than 2.5 micron pollution particles can do. And so I was wondering, every year when I come to India, in the large cities, I see more and more pollution. So the first question is, how much of this could be contributing to, acute presentations of coronary disease? The second is, what is being done to convince the Indian government that this really should be high priority? Should come from the cardiologists, I think, not just from the pulmonologists. Cardiologists, I think, not just from the pulmonologists.
As a corollary to that question, actually, there is an increase during these months, especially those of us who practice in the most affected cities like Delhi, of respiratory illnesses. But the comparative increase of coronary illnesses is not that spectacular. It is there. There is an increase in winter admissions, but it is not as spectacular as the respiratory illnesses. And also the government tends to use it for whichever government always tends to use discretion when they talk about the publicly available figures. So,
one quick question to Anil. In this data, what has COVID and post-COVID also influenced certain presentations? And also we can ask Anil if he has, Pradeep, if there is any autopsy of any post-COVID patient, whether it differs in any way.
I think the question should first be answered.
Unfortunately, we have not done too many COVID autopsies, but I can tell you that, this is my personal view, that there is no increase of coronary artery disease post-COVID or post-vaccination, because some of our publications had predated COVID. So the presence of sudden deaths in young were there before, and maybe it has come into prominence because there is more newspaper coverage rather than anything else. These are my personal views.
Anil, I think you made a point that the pollution is more sort of easily recognized by the respiratory symptoms. But I think the effect on the cardiovascular system is as dangerous. We recognize respiratory because we see its effect immediately, whereas the effect on the cardiovascular system could be chronic.
We are only dealing with the macro.
Recognized.
We are only dealing with the macro. We don't know what else is happening. And thrombogenics substrates do increase, especially during COVID. We saw some extensive thrombosis, which was pan-India. We saw that.
I think, Dr. Anil,
one question to you.
There is a lot of hope or hype regarding LPA. I think even bringing down LPA will not eliminate coronary artery disease. I think you agree or you don't agree?
The LPA is just one of the risk factors. Even if you, let me answer it a little more provocatively. Even if you have an LDL of 0, you can get coronary artery disease. So in which case, what are we talking about LPA? You don't need, these are the classically understood risk factors, which after Paul Dudley White introduced the Framingham study, we started looking at the associations. We don't know everything. Today we are talking about microplastics, we are talking about mRNA arrays, we are talking about a lot of things. So we don't know everything. Even an LDL of 0 can have coronary artery disease.
So, but it would certainly prove to reduce the risk. So, one take-home message from Dr. Ponde's talk is like strong family history and close relatives should be investigated with PRS scores and lipoprotein A, so that risk can be profiled and accordingly, risk stratification and reduction can be done.
The question is whether the polygenic risk scoring is going to supersede other traditional risk scores like GRACE and the other common ones we follow?
No, I don't think it is going to supersede. It's just going to be complementary. It cannot supersede it. Okay. It's going to be complementary because majority of them in European ancestries.
Ponde, one question from my side. The inclisiran is showing quite a good promise as far as reducing the LP little a is concerned, to the tune of almost about 40% in the Asian population. Yes. So you think it is going to be, they've been using it now in UK as a primary prevention drug. No?
I see it will reduce, it has reduced LPA to a large extent, but again we need a CVOT outcome. So we don't know that. And this other thing
I think we'll have to, Ponde will continue the discussion later. Thanks to all speakers. This is a really wonderful and informative session. And thank you.
Yeah. Thank you, respected chairpersons, for your conduct of the session. Now, we come to one of the highlights of this meeting, and that is the first Dr. D.B. Pelajani oration. I call upon Dr. Satyavan Sharma sir, Dr. Ajit Desai sir, to please take their place on the dais to introduce the oration and the speaker and carry proceedings thereafter. Thank you.
Dear colleagues, good afternoon. We are here for a very important session, and I'll give a brief background of Academy of Cardiology. The story of Academy of Cardiology is a story of leadership, mentoring, and advancing academics by Dr. Pelajani, in whose honor we will be having the oration. It is a story of over 25 years. We registered the AOC in '98 with Charity Commissioner of Mumbai. And the main aim was promotion of evidence-based medicine for practicing physicians and cardiologists by conducting CMEs, conferences, and interactive sessions. I have been one of the associates of Sir from that time and one of the original signatories to the memorandum. And since then, in the last 25 years, we could gather a team of academicians and very trusted friends, and that has been the reason for the growth of our society. And we have organized during this period multiple conferences, major and minor, on all subjects. Initially, we began with doing meetings every 4 years, and we had experience of getting very eminent speakers from all over the world, beginning from Dr. Valentine Fuster to multiple other people. Initially, we began with every 4 years, then made it every 2 years, and then for the last 13, 14 years, we have been doing meetings every year. After doing a couple of meetings, we expanded our objectives, and we also started awarding fellowships, national fellowship and international fellowship, called as the AOC Fellowship, We associated with World Art Federation as associate member. We also started a Face the Examiners program. Last year, we started a very popular program called as the AOC Teaching Hub. And also, we are associated with Heart Care for the programs for preventing sudden cardiac death. And these all programs have been done under leadership of Dr. Palajani. And this year, all the members of our academic council unanimously thought that AOC's commitment to respect leadership of Dr. Palajani should begin with starting Dr. Dev Palajani oration, and this should be delivered by an eminent person. And for this year's oration, we are very lucky to have Dr. Sumit Chugh, and I'll now request Ajit to speak about Dr. Palajani and also about Dr. Chugh. Ajit.
Good afternoon, friends. It's truly a pleasure and honor to say a few words about Dr. Palajani, with whom I have been associated for more than 30 years. And I'm sure many of you people who have been sitting in the audience here have been taught and trained by Dr. Palajani. Dr. Palajani trained in cardiology way back in 1960s at the Cook County Hospital in Chicago. At that time, we did not have the DM cardiology, but he came as a cardiologist to Mumbai, and then he joined the LTMC college, that is Sion Hospital, and was the professor in cardiology right from 1970 to 1996, that is 26 long years. He has been a teacher to many of the DM cardiology students. He has been a guide and examiner not only at the University of Mumbai, but also at the PGI University, at Pune, Mangalore, and Gujarat University. He has been the past president of the Association of Physicians of India and has been the past president of the Cardiological Society of India way back in 1994-95. He has been the president of the Indian Society of Electrocardiography in 1989. He has achieved and he's been honored by the Lifetime Achievement Award, both by the Physicians of India, Association of Physicians of India, as well as the Cardiological Society of India. And he has also been honored with the Master Teacher Award by the Coronary Artery Disease and the London Cardiology Academy. He has many firsts to his credit in interventions. He did the first coronary angioplasty in India way back in 1985 and did the first rotational atherectomy also close to about 1992. And he was one of the first to perform the first percutaneous coronary angioplasty with percutaneous cardiopulmonary bypass. He has been a teacher and a mentor to many of us, as I already said, and it is a fitting tribute today to have an oration in his name as the Dev Palajani oration, which will be delivered by Dr. Sumit Chugh. Well, friends, it's again also my privilege to introduce the speaker today, Dr. Sumit Chugh. He's a distinguished cardiac electrophysiologist and researcher, and presently he serves as the Vice Dean and the Chief AI Health Research Officer at the prestigious Cedars-Sinai Hospital at the Los Angeles state. He also serves as the Pauline and the Harold Prince Professor and Associate Director for Predictive Analysis at the Smith Heart Institute. Dr. Chugh is the past president of the Association of University Cardiologists and Electrophysiological Society. He is an elected member of the Honor Society's American Society for Clinical Investigation and Association of American Physicians. He is recipient of the 2024 Distinguished Scientist Award in the clinical domain from the American College of Cardiology. In 2025, he was honored with Distinguished Scientist Award, that is clinical research, from the Heart Rhythm Society and Sidus Sinai Pioneer in Medical Award. So at the Academy, I'm extremely privileged, and we are honored to have you as the speaker for the first Dev Palajani oration. Thank you.
Dr. Pelajani, Dr. Sethi, distinguished faculty and colleagues. How can I say this? It is just such a great honor for me and a privilege to be asked to deliver this first Dev Pelajani oration. As you heard from Doctors Sharma and Desai, it takes a very special set of attributes to be someone like Dr. Pelajani. You have to have foresight, you have to have the spirit of adventure, you have to be very clever, and you also have to have the ability to give, so you can teach, you can mentor, and you can affect generations of cardiologists. That is what Dr. Pelajani is. So before I begin, let's have a round of applause for Dr. Pelajani. So I was asked, and I thought a lot about what should I present for this oration. So I'm presenting to you today our newest concept in risk stratification for sudden cardiac death. And the concept is, can we merge static and dynamic predictors of sudden cardiac death? As this audience knows extremely well, and these beautiful 3 talks that started off the session are so connected to this. This is a condition which is something that nobody ever wants to have. You lose your pulse suddenly, unexpectedly, and usually it's a cardiac cause. In the US, there are 1,000 Americans a day, 360,000 in the year. In India, many, many more. Worldwide, maybe 5 to 7 million people who are going to have a cardiac arrest every year. Here's the problem. The survival rate is very low. Even in places where you have this 911 or ambulance calling system like the US, most people will not survive. It makes up a large number now of cardiovascular deaths, and many will present as the first manifestation. It will be a surprise manifestation of heart disease. So if we're going to do something, we have to end up doing a bigger focus on prevention. So we think of this on the top, we are looking at the chain of survival. When someone calls for help, and then the patient is rushed to the hospital, and then in some situations, you come to Breach Candy or another hospital, you get your angioplasty, and you make it. But by the time you are calling the ambulance, at least 90% of people are destined to die. So we have to be more innovative. We have to think of ways of predicting and preventing this disease and not waiting for ventricular fibrillation. Well, we do have the primary prevention defibrillator. It's a remarkable device. Shown on the left, an implanted defibrillator that will give a shock for this rhythm that is shown up here, a ventricular fibrillation, and it can create sinus rhythm. Based on some really good clinical trials that were done now 25 years ago, we know that we can use an ejection fraction less than 35% to identify candidates. But knowledge is a moving target. Now we can treat heart failure in a very, very much better way. There are lots of ways we do that. We have new medications for heart failure. We have guidelines. And so the number needed to treat to save one life with a defibrillator is also increasing. So it is at the point where now we are getting diminishing returns. So we need new prevention strategies. So our group, and of course others as well, we are thinking of prevention of sudden cardiac death in a different way. Of course, We have always been thinking in terms of long-term prevention, but we are looking for new windows of opportunity. And one window of opportunity is what we call near-term prevention. It's closer to the cardiac arrest, could be a few hours, days, or week before cardiac arrest. But could we really do that? And the example that I like to use is of golf. So if you hit a stroke, you want to be good at that, so you get close to the hole. That's long-term prevention. But when you get close to the hole, unless you can putt well and slide that ball in, you're not going to win the game. So that's near-term prevention. So let me start. I will first talk about long-term prevention and then near-term prevention, but in the context of the static versus dynamic. So we are all sitting in this room. We all measure whether it is risk stratification for coronary disease or for sudden cardiac death. We measure it in a static way. And the question is, why is that? Because sudden cardiac death happens in the young, but the reality is it increases with age. It's mostly acquired and is likely to be progressive. So if we actually look at risk that's dynamic, perhaps we would have more potential for a more personalized risk prediction and prevention. So let's look at long-term prevention. Here's a study that's more than 20 years old, where it came out of Mass General. This is from the MADIT-2 study. It was a post hoc analysis from J.P. Singh and colleagues. And shown on the right, the curves, the red curve is a post-heart failure admission, risk of sudden death, and the black curve is before the heart failure admission. On the top is ICD therapy. As the therapy risk increases, this is not looking at pure cardiac arrest. This is looking as ICD shocks as a surrogate for cardiac arrest. Really, the point that is being made by the panel on the top or the bottom, whether it is VT or VF or is overall death, having a hospitalization for heart failure increases your risk. So this is suggesting that recurrent shocks, this is a dynamic process. It's not a static process. Well, we got very interested in prediction and prevention of cardiac arrest. Now, over 2 decades, we have been working from a population-based learning health system that I started. The point was, you need a large enough community. If you're going to have 50 sudden deaths per 100,000 people, then you need a very large community. If you study as 5 or 10,000 people, it will take you hundreds of years to come to any conclusion. So what I started doing was, in a population of 1 million people, I worked in Portland, Oregon at the university, we started prospective ascertainment of cardiac arrest by working together with the police, fire department, the ambulance system, the medical examiner. We had pathology data as well. And so we integrated what was happening before a hospital admission, or most people don't even make it when they have a cardiac arrest. They're going to die before they come to the hospital. But we integrated the pre-hospital data with the hospital data. And that is what started this. We also have DNA, blood in these large number of these cases. So we started a biobank. Now we have so much data in tens of thousands that now we need AI to help us analyze that data. And I will also touch on that. So 1 million people for almost 24 years in Portland, Oregon, in the state of Oregon. Here it's shown by yellow stars on the map on the west coast of the US. Northwest is Portland. And I have been now in Los Angeles at Cedars-Sinai for 17 years. So we have a population of almost similar number in California. And I will show you data from Oregon. And a lot of times we discover in Oregon and we replicate, because if you can replicate, that means you have a real finding. So first we thought, okay, the ejection fraction is really important. Why don't we look at progression of the ejection fraction as a dynamic risk predictor? Well, this is data from Oregon, but the data from California looks almost the same. And what I'm showing you in this figure is kind of interesting, but very simple. In red is ejection fraction less than 35%, in yellow is 36 to 49, and in green is almost normal ejection fraction over 50 of the left ventricle. What we are looking at is ejection fraction in time. So this is the earliest EF measurement. On the right is the latest EF measurement. But all of this is before the cardiac arrest. These are all people who had heart failure and ended up having a cardiac arrest. You will notice that if you look at the red, the lowest ejection fraction, it is all over the map. It can be the same, it can get better. If you look at yellow, again, it can go anywhere, and if you look at the green, it can go anywhere. So ejection fraction really, in our populations, was not a reliable marker. So we couldn't really study dynamic risk with ejection fraction. So we went to that oldest and most reliable test, the ECG, that has been around for almost 125 years. And what we did over the years, we had several markers in the ECG, and we took all of them, 9 of them that were associated with cardiac arrest, and then 6 of them stayed in a model that we created. And we called this an electrical risk score. So what is in the score? Resting heart rate over 75, QRS transition after V4, electrical left ventricular hypertrophy, frontal QRS angle that's abnormal, QT interval, and this very interesting peak of the T wave to the end of the T wave that we call T peak to TN interval. And shown on this slide is a study we did that was published in the European Heart Journal in 2017. On the left, you can see that as the number of ECG markers from 0 to 6 start increasing, the odds ratio of cardiac arrest start increasing. This is data from Oregon. So when we saw this, we replicated this in a separate cohort study, the atherosclerosis risk in communities, and as shown in red, as you go from a 0 marker to 6 markers, the annual incidence of sudden cardiac death in this cohort also started increasing. So we now had an automated score. If you take an ECG, you can automate this score using these 6 parameters, and you can look at someone's electrical risk. So the concept is that if you look at that ECG at one point in time, that you have some kind of score. But on the right, if you look at the change in the electrical risk score from the simple ECG over time, could this improve risk prediction? This was our hypothesis. Well, let's see what happened. So something did happen because we published this paper more recently in the European Heart Journal, where we identified these dynamic changes in the ECG as a novel risk marker for sudden cardiac death. So now this is proof of concept, and let me briefly show you the data. Again, we did this in Oregon as the discovery population, and to make sure that it's real, we took it to California to a separate community population. And this is a summary, this is the main slide of the data. On the left is Oregon, on the right is California. On the extreme left, you have the blue bars. What are these? Well, there is an ECG that we had that was the earliest ECG. The unique thing about what we do is we have the entire medical record of each individual who has had the cardiac arrest, and we have control populations. In our control populations, most patients have coronary disease. We didn't want them to be normal. So they are matched for age and gender, mostly for coronary disease. The cases all had a cardiac arrest. The control populations have never had a cardiac arrest or any ventricular arrhythmia. So on the left in blue, this is the earliest ECG and the latest ECG compared. What are we comparing? We are comparing that electrical risk score that I showed you before. Notice in the blue, from the earliest to the latest ECG, there is a significant increase in the electrical risk score over time. In the controls that are shown to you in the orange and pink, you will notice there is no change over time. The same findings are replicated successfully in the California cohort. Again, in the cases, the risk score has gone up, and in the controls, there is no change. And this is very interesting. It's also these two curves. The red curve that is below, that has the lower area under the curve, is actually a combination of all the clinical variables and the static ECG. The blue curve on the left again is Oregon, on the right is California, is combining the dynamic ECG risk with the static. And so this is basically showing you that what you are getting from this dynamic ECG remodeling, such a simple test, is actually above and beyond what you can get from the clinical variables and from the static ECG. If you look at all the markers, this is just a simple point to make, the 6 components. If you just take the QT interval and the T peak to TN interval, they are mostly playing the biggest role. So you can take 2 out of those 6 and you can get almost similar results. And this is just a slide to show that what if just a few of those cases, separated by many years in time, were contributing to the change. So we did a sensitivity analysis where we looked just over a period of 5 years in cases and controls and found the same data. Cases, dynamic risk increases, and controls, there is no change. So we came to the conclusion that if you combine static risk with dynamic risk, is much better than static risk alone. And this is, of course, proof of concept for just the ECG. There's much more that we can do, but it looks like it has the potential to improve risk prediction for sudden cardiac death. In the last few minutes, well, what about near-term prevention? We talked about being there and predicting imminent cardiac arrest in the minutes to hours or days before. Where did that concept come from? Well, it came out of a study that we did, and in the first talk, I saw that Dr. Dhal showed some data from Elva Marijan and Kumar Narayanan. Well, both of them were postdocs with me, and it makes me very proud that now their slides are being shown. And so this is work that Elva Marijan did when he was a postdoc with us, where we looked in the Oregon study for warning symptoms before a cardiac arrest. So what did we find? Well, at least 50% of people who have a cardiac arrest, either men or women, are actually going to have warning signs within 4 weeks of their cardiac arrest. That's number one. Number two, at least 80% of people who have warning signs, they tend to ignore them. They just are somehow in denial. The 20% who call the ambulance right away after warning signs have a 5 to 6-fold higher chance of surviving their cardiac arrest compared to the ones who were in denial. And also, these are sex-specific. So, warning signs, most commonly, men will have chest pain and women will have shortness of breath. So this data, almost 10 years ago now, we published this in the Annals of Internal Medicine, made us really excited about, well, what can we do? Maybe we can use warning signs to predict imminent cardiac arrest. Well, the problem is, in the city of Mumbai, if everyone with chest pain or shortness of breath starts calling for the ambulance, all the hospitals will get paralyzed. So we need something more than that. So we did another study, and these studies are difficult to do. They take a long time. And this study was published in the Lancet Digital Health about 2 years ago. And so what we did this time was, we had, cardiac arrest cases from Oregon and cardiac arrest cases from California. But this time, in both of these communities, we had comparison groups. So if someone had a warning symptom and called cardiac arrest, which is the 911 call in the US, we compared them to people who called cardiac arrest with similar symptoms, called 911 with similar symptoms, but never ended up having a cardiac arrest. For the first time ever, there was a comparison group. What did that show? Really 2 or 3 things. One is the figure on the right is just very simply showing you all the symptoms. and the most important symptoms were confirmed to be chest pain, again more common in men, and shortness of breath or dyspnea, more common in women. And then we tried to cluster various symptoms. If you combine chest pain and seizure and other things, it didn't work so well. These two were the important, that's number one. Number two, again, sex specific. But the most important lesson we learned was that if we just use symptoms, then the C statistic, which is an assessment of predictive power, was in the low sixes, not very good. So we learned that we have to combine warning symptoms with other features to make prediction of imminent cardiac arrest better. What are those features? Well, here is what we are doing at the very moment. Our team in the Center for Cardiac Arrest Prevention at Cedars-Sinai is using AI because you can have these warning symptoms, but then today there are wearables everywhere. The number of wearable watches and other devices that are collecting data that we could potentially use is mushrooming. I mean, everyone's pocket right now has some kind of smartphone. You know, I don't think there's anyone in this room without it. And they're already making a lot of measurements. So we are taking symptoms, we are combining them with wearable data. And then there are, I don't have time to go into this, but we have discovered some novel markers in the blood that are actually independent of coronary disease and predictors of cardiac arrest. And then we have the entire electronic health record. So it's a huge amount of data, and it's all different data. Some are images, some is from the blood, some is, you know, from the modeled on the brain to help us sort out these various kinds of data to try to understand how we can improve prediction. So here's the concept. It's still a concept, but we have to work towards it, where if you take in the future someone who has a smartphone, they have warning symptoms. In their phone is their ECG, their demographic, their clinical profile, and the phone will be able to take some blood biomarker as needed. So their smartphone app might tell them, your chest pain is real. You should call the ambulance right away. Or it could say, okay, your chest pain, you don't need to rush, but you still need to see Dr. Pehlajani next week. Or it could say, well, you can see your family doctor. So what we are thinking in terms of is this is a summary of where we think this could go. So today we are just using a static approach. For most people, we're just measuring the ejection fraction, and it's not doing so well. In the very near future, there are some clinical trials, I'll talk about that tomorrow in my talk, that are coming up that will help us be better. But for now, we will use multivariable markers, not just the ejection fraction. Then, if we combine the static with the dynamic, we have a better chance. And finally, if we get to a few minutes to hours before the sudden cardiac death event, we can use these near-term prevention dynamic markers. And so here's my summary slide, that if we think about this new paradigm of merging static and dynamic predictors, here is what I talked about. In the long game of golf, in the long-term prevention, we must improve our static prevention. We can't just use the ejection fraction. Then static plus dynamic could be more powerful than static alone. And we have to extend beyond the ejection fraction, even beyond the ECG, to other measures. But we need prospective studies, and we need clinical trials before we can get to personalized risk stratification. For that short game of golf, the short-term prevention, the response to warning symptoms can determine survival. These responses are sex-specific. And we need to add more features, and we need to develop these early warning systems with the help of AI. So thank you very much for your attention. These are the people who did the work. Lots of collaborators, and thank you again.
Thank you, Dr. Chuk. That was wonderful. How to amalgamate both the static and the predictive risk factors, particularly based on the ECG. That was wonderful, something new for all of us. Yeah. And also how to give credence to the imminent symptoms before the SCD occurs. It was wonderful. Thank you so much.
Thank you.
And it is our honor and privilege to give you a small memento for this oration, the Dev Pelagian. Sir, can you come on to that?
Thank you, Professor Dr. Chok sir and all the eminent chairpersons for a wonderful session, the first Dr. D.B. Pelajani oration. And now we can start session 3. Very important topic, clinically relevant to all of us. All of us see these patients in our day-to-day practice. So it is acute MI in the young. And can I call upon Dr. Ajit Menon, Dr. Rajiv Bhagwat and Dr. Anand Rao to chair the proceedings. Thank you.
Thank you, Milind. I think the first topic of this session is by Dr. K.K. Sethi, acute MI in young. Dr. Sethi, please.
Thank you very much. Good afternoon, ladies and gentlemen. Sorry to keep you waiting for a few seconds. I just got involved with Sumit Chugh on this wonderful effort that he has made to gather data on sudden cardiac death for as long as I remember. I think it must have been 30, 40 years by now when he first started, and is still continuing to add to information which could be of very vital importance in coming future. Now, coming back to the theme of this meeting, acute myocardial infarction in the young has been assigned to me, and it's my pleasure to participate in this. The major question that comes to your mind when you look at this kind of a topic is, who is young and who is not young? In today's dynamics, it is very hard to call anybody old, because there are various definitions of being old and being young. And I'm not going into the details of that, but nevertheless, for the purpose of this talk, the age cutoff which has been used in most studies across the globe is between 40 and 45 years, although the standard risk stratification by the American Heart Association and other societies says less than 55 years in men and less than 65 years in females is premature coronary artery disease. More recently, a threshold of 49 years has been suggested for men, but we don't have any such suggestion given for women as yet. Now, myocardial infarction in the young is actually increasing in incidence, primarily because of the changing risk factor profile that we are seeing in our society, including smoking, obesity, hypertension, psychosocial stress, and so on. It can be divided into several categories that I have written here, and most common still out of all of these is the traditional risk factors. But importantly enough, and what is catching up in our country also, I believe, is the use of recreational drugs such as cocaine, marijuana, etc., psychosocial stress resulting in anxiety, hostility and depression is not uncommon in our society, particularly people who are living alone in the cities, going for jobs and under high stress professional work. Then spontaneous coronary artery dissection, myocarditis and coronary embolism are also important categories, not to forget the systemic inflammatory disorders such as psoriasis, systemic lupus, rheumatoid arthritis and so on. It has been said that in the young, particularly, rather than looking at the LDL cholesterol, high non-HDL cholesterol is the best discriminator to look at the risk. And in the Massachusetts General Brigham Young MI registry published a few years ago, 1 in 3 out of less than 50 years old had Lp(a) level more than 50 milligram per deciliter. And Lp(a) more than 50 increases ACS risk by 3-fold in people who are less than 45 years old. And now, of late, we have started talking about cardiovascular kidney metabolic syndrome, and you're all aware about it. And there are some gender-specific risk factors which have been particularly listed in that, apart from some of them which we have talked about just now. And particularly in women, history of premature menopause, adverse pregnancy outcomes like preeclampsia, preterm birth, and small for age polycystic ovarian syndrome, and in the males, erectile dysfunction are specific risk factors which are particularly applicable, obviously, to the young people. In Asia, most people in the young MI category present with ST elevation myocardial infarction, up to 75% of those in some studies, as compared to the West where this number is about 50%. And importantly, in the young, they have lower burden of atherosclerosis, fewer diseased vessels, shorter lesion lengths, and smaller overall plaque volume. Single vessel disease is present in almost 2/3 of the patients, and we'll be hearing about this in another presentation soon. So if we look at the actual division of various causes of premature myocardial infarction, obstructive coronary artery disease still tops the list. 80% of the cases of premature myocardial infarction are caused by obstructive coronary disease with risk factors which are traditional. Most important out of these is smoking, and then dyslipidemias, family history of premature coronary artery disease, and substance abuse. All of you are aware of a category what we call as MINOCA, or myocardial infarction with non-obstructive coronary arteries. This is an important cause of MI, particularly in young women, and again, can have two aspects to it. One is caused by the typical atherosclerotic cause, in which you have traditional risk factors and have plaque rupture or plaque erosion. And notice again that smoking, although lower in the list in this particular category, remains an important component of the risk factors in this group as well. Now, on the non-atherosclerotic causes of MINOCA, sorry, this keeps moving. You can have coronary spasm, embolism, and thrombosis in situ. And again, if you look at the risk factors here, smoking remains important, substance abuse, cocaine, and thrombogenic disorders, which I will be giving a brief mention about. And lastly, less than 5% of infarctions are caused by spontaneous coronary artery dissection, and these are particularly important in female sex. It can happen during pregnancy and is oftentimes associated with fibromuscular disorder in the other non-coronary vascular beds. If we lower the age of acute infarction to less than 30 years, let's say, about 40% will still have angiographic coronary artery disease. And in them, family history of premature coronary disease, the epidemic of obesity, hypertension, dyslipidemia, with or without familial hypercholesterolemia, and an elevated Lp(a) assume more importance. Smoking and recreational drug use continues as an important risk factor, but in this particular group, a thrombophilia screening is also very, very important to rule out a spontaneous thrombosis in the coronary arteries, and very much similar to what happens in venous thromboembolism. For example, look at antiphospholipid syndrome, polycythemia vera, essential thrombocytosis, factor V laden protein C and S, and antithrombin 3 deficiency, etc., etc. And in different series, between 5 and 14% of such patients have been found to have some of these disorders on thrombophilia screening. Another important but not very common component of this risk profile is the use of androgenic anabolic steroids. And I would say this is a misuse, because this is a very, very common thing that people are taking protein powders, going to gym just to build a macho image for them, and it leads to so many complications that result in accelerated atherosclerosis, hypertension, left ventricular hypertrophy, and occurrence of coronary artery disease. Briefly speaking about spontaneous coronary artery dissection, 90% of the cases are women, and it is a cause of myocardial infarction in 35% of women less than 50 years of age who present with acute coronary syndromes. It also constitutes 14 to 43% in different series of pregnancy-associated myocardial infarction. The precipitating factors, history can be elicited in almost 50% of them, usually comprising of intense exercise, intense Valsalva type activity, severe emotional stress, labor and delivery, use of recreational drugs, and use of exogenous hormones. And coronary angiography is the gold standard for diagnosis. Pregnancy-associated myocardial infarction deserves a special mention, although we don't see it very often, but in obstetric units, I am sure people would have seen this. It occurs commonly, the spontaneous coronary artery dissection occurs either in the last trimester of pregnancy or usually in the first week postpartum, but up to first month of postpartum remains a significant risk, although it can happen up to 3 months after delivery as well. Other important causes in young infarction which is associated with pregnancy are microvascular dysfunction in the coronary arteries, spontaneous thrombosis and coronary embolism. And it is important to know that if it happens during the pregnancy, in terms of management, we need to reduce the cardiac workload. So therefore, nurse the patient in left lateral position, treat hypertension aggressively, take care of the tachycardia, and if possible, postpone delivery by 2 to 3 weeks after the myocardial infarction. Low-dose aspirin and beta blockers are safe. Proper abdominal shielding is required if an invasive procedure is prolonged, because that is not a contraindication, and if the patient needs an urgent angioplasty, it should be performed with proper screening. And the problem is that earlier we used to recommend bare metal stents, but they are no more available. Clopidogrel is used only when absolutely necessary. Statins have not been tested in pregnancy. Heparin is safe because it does not cross the placenta. In the category of microvascular dysfunction, epicardial abnormal vasomotion or endocardial microvascular dysfunction, both are possible. And that can happen as a result of atherosclerotic embolization from the proximal vessel to the distal coronary artery, or from the aortic plaques into the coronary vessels, or in presence of inflammation. And treatment is calcium channel blockers and nitrates. Standard beta blockers should be avoided there. The nebivolol is an effective medicine. ACE inhibitors, amitriptyline, they all work via a vasodilatory action. Coronary vasospasm, I don't need to go into too much of details, it is very well known to you. Happens because of vagal withdrawal or increased sympathetic drive. There is a decrease in nitric oxide content and magnesium deficiency at the level of the endothelium. Smoking is an so are the recreational drugs, but more importantly, chemotherapy for cancer, use of simple antibiotics, and anti-migraine medications can all precipitate coronary vasospasm. Patients, and both macro and microvascular embolization can take place. The standard causes are all very well known to you: cardiomyopathy, atrial fibrillation, valvular heart disease.
Dr. Sethi, I think the slides are off. I think if you can come to the conclusion, slides, I think. Yeah. Okay, thank you.
Lipid syndrome is very important. It works by the mechanism of so-called virtuous stride, as you all know, where there is hypercoagulability, stasis, and endothelial injury. My last slide just gives a summary about how to treat this situation. Obstructive coronary artery disease has to be treated by the standard methodology, but as far as long-term secondary prophylaxis is concerned, cessation of smoking is one single action that we can take that reduces the risk of sudden deaths and the recurrence of infarction by almost 50%. Prognostically, it is important to remember that premature infarction, especially in obstructive coronary disease or female gender, is an aggressive disease with high rates of recurrence and mortality. 1 in 3 patients less than 45 years of age had 1 recurrence over the next 20 years, and predictors of recurrence are persistent smoking, diabetes, chronic inflammatory disease, and Asian ancestry. Thank you very much for your kind attention.
Thank you, Dr. Sethi, for this wonderful talk. We'll have the discussion at the end of the session.
Okay.
I'll invite Dr. Ajit Mulasari from Madras Medical Mission, Chennai, for his talk on STEMI in the young compared with older patients.
So thank you very much for inviting me, Dr. Sharma and Dr. Pelajani, and I'm going to just quickly go through STEMI. And so we already had the talk about is it different in young MI, and the definition too. There are multiple definitions, but I stuck to a definition of less than 45 because we did some work on this area, and we found that a less than 45 age seems to be a reasonable number. And what's important to know when you ask what is the difference is that the number of patients in Western population who have young MI are very low, 0.5 to 0.18, and most of them will have familial hyperlipidemia as the underlying problem. We also talked about the various atherogenesis, and it's important when you see young patients, you look at the non-atheromatous CADs and the hypercoagulable states. We also had the talk about the clinical presentation of these patients, and this is very unusual that young patients will present with classical angina. They will present usually as a first step as a myocardial infarction, and the duration is usually less than 1 week, and they quickly have a Q wave developing in these patients with young MI. So I'm going to talk about what is young and what is old based upon a paper which we published in Heart Lung Circulation, which was a subset analysis of the JAMA paper of the STEMI India data of an acute ST elevation in young as compared to old in the Tamil Nadu STEMI program. Now, what is important first is out of 2,420 patients of STEMI in the JAMA paper, less than 45 years of age was 24%. 24% is much higher than what you're talking about the Western population of 1%. So that's the first thing. The second thing is that if you look at and if you look at the female percentages, you can see that the men are predominant in the less than 45. The women have more diabetes, and one thing in diabetes, when you get it in women, it loses the protective effect of estrogen. Hypertension is more common in the young MI men, and dyslipidemia, as you can see that current smoking is also much higher in young patients as compared to old. So clearly, the traditional risk factors are more in the older population, while smoking and is a very important predictor in young patients. Now, if you look at the male and the female, we had 44 patients out of 2,400, less than 45 who were women. And you can see clearly that diabetes is more common In those patients, hypertension is more common, and current smoking is more common in men as compared to women. The other interesting thing is we had a good data set at point of care of this time to symptom onset to first medical contact, and you can see that the young patients went to hospital faster than the older patients. Though the p-value is not significant, the door-to-balloon times were similar, but the ischemic times were higher in the elderly patients as compared to the lower patients. The fibrinolytic times and 2-PCI was no different. The door-to-balloon times, all those numbers, which are the quality indicators, were no different between less than 45 and more than 45 in the Tamil Nadu STEMI data. But clearly, single vessel disease was more common in the younger patients, which is less than 245, while triple vessel disease and double vessel disease was more common in the older patients. The thrombus grade, or TIMI 0 flow to 2, was more common in the older patients than the younger patients. And that's very important because many of them in the Tamil Nadu STEMI project responded to tenecteplase, and the reason is many of them have plaque erosions and not plaque ruptures, and they respond very good to a quick thrombolytic agent. What about the mortality? The younger patients had better in-hospital 1 month and 1 year mortality because their other risks were lesser. They are younger patients, so their mortality was much lower than the older patients. The other MACEs, shock was lower in the young patients, and all the other risks were also lower in the young patients. The 1 year MACE, as you can see, the reinfarction, readmission, stroke, heart failure, and repeat revascularization was similar. But what is important that if you compare men and women, you can see the in-hospital mortality, 1 month mortality was higher in women who are younger than men, clearly showing that patients access, especially women access care lesser, they act later, and because of their typical symptoms, they are prone to more mortality because they come in much worse. Now, this is a patient, and I want to show you how these patients present. This is a 50-year-old, not classically less than 45, but has a beautiful picture of a SCAD, and you can see the tear in the vessel. This patient was just puerperal, and we had an intravascular ultrasound showing a beautiful tear in the artery. No disease at all, no atherosclerosis. It is just SCAD in this patient. And this is a classic SCAD. We normally don't do angiograms in these patients. Many of them just have a CT, and we treat the patients medically most often. This is another patient, anterior wall MI, lysed and sent to us, a young patient. What does it show? It shows no plaque, but just clot. This is a plaque erosion. These will respond very well with medical treatment, and you don't need to put a stent because these patients will have good flow with just medical treatment. And this is another similar patient with a lot of clot, no plaque, and these patients have just medical treatment with antiplatelets. Now we use a NOAC and single antiplatelet, and in 6 weeks you can't even see that there is any disease in the coronary on intravascular imaging. So these young patients have a different pathology in some group of patients, and they have erosion as their important thing. I will not go through this because I'm going to take a next lecture on this, but I think what is important is these thrombophilic profiles. Just like Dr. Sethi said, all young patients, we run this whole thrombophilic profile on these patients because many of them will have high LP layers, low homocysteine levels, high homocysteine levels, and some of them will have Willebrand factors of protein C, which you don't want to miss because these patients will get into trouble. So I think what I'm trying to conclude in this young versus old is that erosion is a very important cause. And this is the first randomized study on erosion, which shows that if you stent these patients unnecessarily, you'll have more poor outcomes than patients if you don't put a stent. Many of these patients can be treated just medically with single antiplatelet and NOACs or dual antiplatelets, and many of them will have very small lipid plaques in the arteries which just erode for a few seconds, and there's a lot of pro-thrombogenic substrate which creates a clot, and these patients do very well. So a 1-year follow-up of OCT in the erosion 1 study showed that there was a great decrease in thrombus volume, and patients did very well with just dual antiplatelet therapy. This is erosion 3, which was again run in China, was of basically using OCT to guide reperfusion in these early infarct patients. And clearly, if you do, as compared to angio-guided reperfusion, if you do an OCT-guided reperfusion, you do less stents, less, less aggressive, unnecessary treatment, and patients do well as the patients who did stents. So the important thing is don't put stents in these young patients because you're going to create disease in these patients. So I think in patients who are young, in our hospital, if you have any slight doubt that this is going to be thrombus, we will go in for an imaging, especially the thrombolyzed patients. In a primary PCI, it's difficult sometimes to do because patients are sick and we want to do the procedure quickly. But any patient who has some flow or who had a pharmacoinvasive therapy, we normally go in and do an imaging to decide the treatment. Now, the initial management of patients differs slightly. As I said, the testing is different. I think aspirin, most of those treatments are the same, but we have to actively use history of cocaine abuse. I had 2 patients, young people in last week who were less than 25 who come in simultaneously with AMI in Chennai, and both had cocaine use together, and they came in an MI in few hours difference. And I think we cannot be just closing our eyes that this doesn't happen in India. I think we have to do an early primary PCI because that helps these patients very quickly, but we need to look for other conditions like coronary spasm and other issues. Reperfusion, as I said, primary PCI is good, but I have a strong feeling that if you give Lytics very quickly in these young patients, within an hour or 3 hours, they do very well because a lot of these patients have just erosion and they will clear out very quickly with the thrombolytic agents. A large clot requires intracoronary Lytics at sometimes, thrombosuction, and if the clot is a primary problem and there's no lesion and you can clear the flow, I think all you need is good medical treatment. I think young patients do better than old because their traditional risk factors are lower, they don't have chronic kidney disease, they don't have other diabetes and other diseases which influences outcome, and I think the secondary prevention treatment is sort of similar, but quitting smoking, antiplatelet therapy, I use hypercoagulable states, warfarin, but today in erosions, I use NOAC with antiplatelet therapy in these patients. I think risk factor modification is important and stopping smoking is the most important. So my conclusion of young versus old is that in the sub-analysis group of the Tamil Nadu STEMI program published in JAMA, we showed that in the heart-lung circulation paper, 24% of patients had young MI. Smoking was traditionally the main risk factor. The prevalence of diabetes and hypertension is significantly less in these patients as compared to the older patients. And the traditional familial hyperlipidemia, classic, is very unusual in Indian patients. And I think that the role of plaque erosion in the setting of a prothrombotic milieu is the primary cause of STEMI, sometimes in these patients who are young. Thank you very much.
Presentation, thank you. We've got Dr. Mohit Gupta from Delhi. Spontaneous coronary dissections.
Thank you so much, sir. And I'm going to speak about spontaneous coronary artery dissection. In next 10 minutes, I'm going to give you profound 12 messages, all that you need to know about this entity. My first message is the eyes don't see what your mind doesn't know. So let me start with this case example. Typically, we had a 46-year-old female medical doctor with a posterior wall myocardial infarction last year, hypertensive, know the risk factors, physically fit, and was doing all the physical exercises. And this is what we had, a long lesion in the obtuse marginal. Now see, a very diffuse lesion which generally somebody has a tendency to miss. And when we did a angiography of the other arteries, renal artery also, we also observed the dilated left renal artery. This is what is a classical presentation of a spontaneous coronary artery dissection, suspected in a young female, presenting with an ACS, and traditionally absence of traditional cardiovascular risk factors, and typically non-atherosclerotic coronary angiograms. So what is spontaneous coronary artery dissection? A non-traumatic, a non-iatrogenic, a non-atherosclerotic tear, which is separation of the coronary arterial wall. This leads to the formation of the coronary intramural hematoma, as very nicely shown by Dr. Ajit. And this is what this entity is. My second message is, what is the epidemiology? Out of 100 cases that you see of ACS, mind you, 5% are typically of SCAD. Out of these, 95% are females, and remember, 25 to 35% of ACS within less than 50 years, it's SCAD. It's SCAD. It's probably one of the underdiagnosed entities. It's one of the most common causes of pregnancy-related myocardial infarction. There are various registries that have happened across, and data from India also shows that percentage remains about 5.9%. In our own Northern STEMI registry of 6,000 patients, we could observe SCAD in almost 4% of the females. It is gender predominance, there's no doubt, and the average mean age is 47 years. What is the pathophysiology? Two ways are running. Either there is a rupture of the vasovasorum in the adventitia and in the intima, and this leads to, you see, the false lumen, and false lumen is compressing on the true lumen. I'll show in the OCT. And the second theory is the inside-out theory. There is an intimal tear, and this leads to the formation of the spontaneous coronary artery dissection. These are the two ways that has been described. What is unusual? The risk factors, mind you, 1/4 to 90% of the cases, you will have a FMD associated with it. So if we suspect SCAD, and there is a diagnosis of SCAD, scan these females, all the arteries for possibly, ectasias of dysplasias, connective tissue disorders in almost 3%, and various systemic inflammatory conditions in other percentages. But FMD is mandatory. Today it is recommended that all the patients should be diagnosed, should be screened for aneurysms and dissections in the other arteries. My third message, why women are more affected? Probably they say estrogens affect, promote angiogenesis, vasodilation, autonomic regulation, and typically exogenous hormonal use is more common in females, and probably it has also been linked to SCAD, no specific cause known. Fourth message is there any genetic predisposition? The answer is yes. Typically polygenic inheritance, disorders that are linked with SCAD are Marfan's, are Ehlers-Danlos, and are polycystic kidney disease. So mind you, if you find the possibility of underlying SCAD should be ruled out in these cases. My fifth message, how do these cases typically present? Almost 70% are non-STEMI, almost 25 to 30% are STEMI, and a few cases will be unstable angina. Chest pain is the most common, arrhythmias are rare, practically absent, and SCD is very unusual in these patients. So these are the common presentations. My fifth message, what are the types of SCAD you are going to deal with? Now look at this coronary angiograms, and you will have an image, and you will really understand how many cases I would have been missing. The typical type 1 SCAD is a multilumen. This is a very classical SCAD. You see the proximal LAD, and there's a double lumen appearance in the proximal LAD. This is the type 1 SCAD, 25% of the cases. Type 2, look at this, the distal RCA. There is a long stenosis, but reformation of the normal vessel. This is type 2A SCAD. And if this extends to the distal vessel, like typical occlusion of the left anterior-descending artery, you see the circle, no opacification of the distal artery. This is type 2B SCAD. And then we have a type 3, which is typically a focal stenosis, and OCT in such cases is very important. It should be done. And type 4 is complete occlusion. My sixth message is, how do we diagnose? Coronary angiography is gold standard. Let me tell you, it is very important. It is primarily and usually sufficient. Rest all our adventures, rest all are where we want to fulfill our desires, and we want to be very, very sure. How do we differentiate typically a SCAD with atherosclerotic plaque? Lesion appearance, it's a typical linear and tubular in SCAD. Just a very classical description. Location is mid to distal, whereas atherosclerosis could be anywhere, and non-culprit arteries will usually be normal in a case of a SCAD. But if you're still in doubt, then we have modalities, as it will be shown in next talk, and it's like OCT and the IVOS. OCT is great resolution, IVOS is great penetration, and a typical prediction, typical features that we see is, look at this, the false lumen. The true lumen is completely compressed. This is the beauty of OCT, how beautifully it shows that there's a classical false lumen, and then you see a typical re-entry into the true lumen. And similarly, IVOS also demonstrates it very beautifully. But we have to be cautious. Why? Because these vessels are very small. They are tortuous, they are distal, and if you are injecting into these vessels specifically with OCT, you are and if you enter a false lumen, you can actually increase the tear in the intimal flap. So OCT and IVOS have to be used judiciously, not universally, and on a case-to-case basis. Some people advocate use of CT coronary angiography. Today, it is very grossly limited, not a great modality to typically diagnose a SCAD. My sixth message to you, how do you manage SCAD acutely? As very nicely in one line summarized by Dr. Malasri, the answer is conservatively. That's the biggest problem. This is one place where as we intervention cardiologists need to restrain. Why this is important? Because 80% to 90% will spontaneously heal. As soon as 30 days, 80% will be absolutely normal. And what we do, if we do a PCI in these patients, we give them an antiplatelet, which is dual antiplatelet, we may increase the hematoma. We may increase the chances of complicating. So we must understand that these are the cases where single antiplatelet is probably a possibility to be used, and PCI should be less used in these cases. But we don't have a role? Yes, we have a role, obviously, with a persistent chest pain, with a hemodynamic instability, with a prox location of a left main, multivessel dissections, and a patient is compromised. You do a PCI, there is no problem, and it should be done. What about grafting? Look at this. This is important. Very interesting. If you happen to do a graft or a CABG in these patients, this is one place where venous grafts have to be used. Why venous grafts? Because these cases are going to be healed either way. 30 days they will be healed, and if you put a lima, it's going to degenerate. So that is why venous grafts are very important, which are to be used in cases of SCAD. Remember this message. This is very important. Now, drug therapy. Drug therapy, single antiplatelet. Remember, don't be adventurous and give dual antiplatelet therapies to these patients. Statins practically have no role. Some studies have shown harm, some have benefit. I strongly say that you can use these cases. Beta blockers, long studies have shown that yes, beta blockers may decrease the recurrence of SCAD. ACE and ARBs only when LV dysfunction is there. We have mixed data about the antiplatelet use. I'm not a great fan of using a dual antiplatelet therapy in these cases. A single antiplatelet, either clopidogrel or a P2Y12 inhibitor or a aspirin is more than enough generally in these cases. What is the role of beta blocker? As I say, they are significantly associated with the reduced incidence of SCAD. My ninth message, what happens if these patients have a recurrent chest pain? Yes, these patients may have a recurrent chest pain, typically because of the non-healing of the SCAD, because of microvascular dysfunction, and remember, 40 to 60% of these cases of SCAD keep on having atypical symptoms. So one must counsel these patients, advise them, make them understand that this is going to be normal. You don't need to worry, you don't need an intervention, because most of the people will say, Doctor Sahab, kar kyun nahi rahe ho? We are ready, do it, fix the artery, but it should be refrained, it should not be done. My 10th message is, can I go for a gym or a run after a SCAD? Remember, this is one area where all SCAD should be referred to a proper cardiac rehab programs. It needs a gradual building of the exercise. Very important. Females versus males, this is one place where cardiac rehab program has to be very structured, very monitored, and it has to be increasing gradually. You need an interval training. You need a low resistance and high repetition. Consistency is the key in these patients, and avoid high intensity, avoid abrupt movements, avoid every, extreme head positions. My last message to you is SCAD and pregnancy. Coincidence or a causation? SCAD is a leading cause of MI in pregnancy, especially in the postpartum period, and almost 4% of all the patients, they die. They have a high in-hospital mortality rates. So it's important that these patients who are having a peripartum, infarction or around the pregnancy, SCAD has to be considered strongly. These are patients who have higher rates of STEMI, more chances of a poor LV ejection fraction, and higher chances of a left main and a multivessel involvement. My dear friends, my last message to you is look beyond the obvious. Just rather than interpreting the routine coronary angiograms, look at the clinical structure. Look at the clinical profile of the patients. Each one of you as a physician, as an intervention cardiologist, may be missing many of these SCAD cases. It is important for us to pick it up because these are the cases which heal spontaneously. My take-home message is very simple. It's underdiagnosed, no doubt about it, but it's underdiagnosed because our mind doesn't know the nuances of a typical SCAD. FMD must be ruled out in all the cases. Proper differentiation is required from all the atherosclerotic lesions, and management is best conservative. Number 1, conservative. Number 2, conservative. Number 3, conservative. And PCI and CABG only for the select cases. I leave you with this one slide. All modalities and skills have to be used wisely in clinical experience. Why? Because a fool with a tool is still a fool. Thank you so much for a patient hearing.
Thank you, Dr. Gupta. We'll call you back for the question and answers. Last lecture of the session is intracoronary imaging in young CAD by Dr. Mulasari.
So why do you have intracoronary imaging in young patients? And my talk will quickly tell you 9 patients, show you how they all differ with young MI. So when you have acute coronary syndrome, you have a few conditions. The most common thing is plaque rupture. And the plaque rupture is classical. There is a cavity, there's a thin fibrous cap which gives away, and it creates a rupture. The second is a nodule which protrudes, which is a calcium plate which is given away at the hinge points of movement, and a clot forms on top of that, and this is a nodule which is protruding in. The third is when the cap is intact, and that's a classical plaque erosion where there's only clot, nothing on no thin fibrous cap, nothing. There could also be a spasm, there could also be a SCAD, and the others are the other groups which are like hematoma, SCAD, and what we saw the last presenter presenting. So this is a young guy who comes in with MI, very typical. We did an angiogram, he was thrombolized outside, and then you can see this large cavity here on the OCT and a thin rupture of the fibrous cap, and clearly a lumen which is very jagged, and the lumen looking pretty ugly. So this is a plaque rupture. What do? You just go in, directly stent this patient, and you get a nice flow, and there is no problem here. That's a classic. Now the second case is a young guy who comes in, and there's a suspicious looking lesion in the LAD. It's a little hyperdense, and you look at this, you can see here that there is clot here, and at the back there is no lipid plaque, and this is a classic erosion. In erosion, what happens is you have to make a decision what to do. What is important in this situation is the lumen. If the lumen is good, you leave these patients on medical treatment. There is no need to stent this patient at all, even if he comes with a TROP positive. This is a third patient who's coming now with non-STEMI, a very ugly looking lesion in the proximal LAD. If you go and stent these patients acutely, all that stuff will go down the microcirculation, and you will get a no reflow, and the myocardium will get into trouble. In this patient, again, you can see a large thrombus. I can't see the back of that plaque. Therefore, we call it as probable erosion. It is not clear erosion because I can't see the back. Is there a lipid plaque or not? And I call that a probable erosion, but the treatment has no difference. Because I treat this patient medically, and you can see that after 6 weeks, there's nothing. There's only a thin area of organized clot, and the patient had no stent and just medical treatment. So these patients can be treated. This, unfortunately, angiogram is not running, but what you can see in the angiogram is a hazy proximal right, but here you can see a classic nodule. This is a nodule which is protruding into the artery, and these are present with ACS when clots form of it. Once the clots are treated, you may have to debulk these patients with an atherotome sometimes, and if there's an eruptive nodule, all you need is a high-pressure balloon for these patients. So this is a calcified nodule which is seen in a small percentage of patients with acute coronary syndrome, which may sometimes require plaque modification with something. This is the same patient I showed you was SCAD. I'm just repeating that this could come as a clinical presentation in a young patient with ACS who presents to you. So SCAD has to be treated predominantly medically. Now look at this patient, 45-year-old patient, inferior wall end STEMI, treated outside, comes to you, and you can see this. There are multiple holes in that OCT. You can see it very nicely. This is recanalized thrombus. What you need to do in these recanalized thrombus is do nothing, because the flows are good. Unless a patient has chest pain and STA changes dynamically, Don't go and fiddle around with these holes, because if you try to get the wire and it goes in the wrong way, you will close the vessel. The patient is well with just simple medical treatment on this patient. So this patient can be treated very, very nicely. This is a typical call, what we call on OCT as a lotus stem appearance on the OCT. And these are the recanalized thrombus with microchannel. This is a 27-year-old guy, non-STEMI, family history of CAD, strong smoker. Very interesting case, because he came to us, that was his angiogram after medical stabilization overnight. You can see this proximal LAD, watch this lesion. It is very close to the septal. And this patient had good flows. He was a smoker. We left him alone. He was on DAPT, statins, and low molecular weight heparin. We did not stent this patient. We left this patient on medical management. 2 years later, he had quit his smoking. He comes back with chest pain. And now you can see that the lesion is now there, but is beyond the first septal. So the lesion has moved from the proximal to a little mid now beyond the septal. So if you had put a stent in the proximal LAD, he would have now come back with another lesion, the little distal. So it's very important that these ectatic vessels may change the position of the lesion on a follow-up. So what did we do? We treated the patient. Again, we went through this whole profile of lipoprotein A, APA, lupus anticoagulant, because this patient had an unusual presentation. He had a little bit of a high LP little a and a little bit of homocysteine, which is high. And this patient, post-anticoagulation therapy with low molecular weight heparin, had a re-angiogram and an OCT, and you can see it's plaque erosion in an ectatic segment. This is a very peculiar disease we have now a randomized trial which is just published in the American Heart Journal on patients who have these ectatic coronary arteries. They have 6 times more events than non-ectatic vessels, and they do well with a NOAC and antiplatelet rather than a dual antiplatelet. So it's very important that we understand these pathologies, which are a little bit different in young patients. Ectatic vessels, plaque erosions, SCAD, recanalized thrombi. These are very typical problems which you see in young patients. This is now an 8th case, a 33-year-old smoker who came with chest pain. Troponin was high, treated medically. We took him for an angiogram next day. And again, a very suspicious lesion. We gave this patient, again, just medical treatment for the treatment. And here you can see again, occlusive, non-occlusive, but large thrombus. Lumen is small, lumen is big, but it's not small enough to put a stent. Here again, hold your stent off. That is the important conclusion. And this is a 6-week angiogram. 6 week is OCT. Everything is clear and everything looks good. And this is a 3D OCT. Look at the thrombus before and after. Completely cleared with just medical treatment. You don't need to do any of these. This is the 9th patient. Patient comes in MI. And you can see a suspicious lesion here. And what is important is if you look downwards, there's another total occlusion here. And so your STs went up not because of the proximal lesion, but because of the distal lesion. And that is because that is the occlusive segment. So what we do here is that we don't have these clear catheters now. So we punch holes in a balloon and give intracoronary tenecteplase distally. So what we have done is we gave the intracoronary tenecteplase through a punctured balloon, retiplase through a punctured balloon. We got some flows and then brought the patient up the next day for a procedure. And the angiogram is shown here. And what is very important now is the OCT. Now the OCT you can see is a rupture plaque in the proximal LAD. So what has happened is the patient ruptured the plaque in the proximal LAD, thrombos there, that thrombus distally embolized, and the patient came with an MI. So the problem is not distal, the problem was proximal, which distally embolized the clot. So the patient, again, had medical treatment because the flow in the proximal was good, and the patient continued on pharmacological therapy and stenting of the ostial LAD, not the distal, because that was the plaque which was ruptured. So conclusion is that intracoronary imaging is important in patients with young myocardial infarction, as they very often have plaque erosions, which can be managed very nicely medically. Occasionally, which is very small percentage, 5% of patients, like the previous speaker said, young women can come with SCAD and they have to be picked up by either angiogram or a high, good level, a 640 slice CT, and now a single photon CT is fantastic for diagnosing SCAD. Finally, young myocardial infarction is not uncommon. It's 1/4 of patients today, and in at least most of our practice in India. And we should know what is suspicious of erosion and what is classical of rupture and treat these patients accordingly. Thank you very much.
Thank you, Dr. Mulasari. The session is open for discussion now. Any questions? The mic is open over there. I will start with one question to Dr. Sethi. Since there's a lot of physician crowd in the audience, now the post-COVID vaccine is tainted as one of the most common cause of acute MI in young. So what is your take on that?
Surprisingly, we did not see too much of it in our experience. And in any case, to attribute a myocardial infarction to COVID vaccination, where etiology cannot be established unless there is a well-defined temporal relationship between the time of the vaccination and occurrence of myocardial infarction, it becomes very difficult to call it a COVID vaccine-induced myocardial infarction. Having said that, I will also say that there is a definite increase in thrombogenicity with the use of vaccines, and the risk of getting a myocardial infarction was real, but the actual incidence even in the Western literature has not been very well worked out. At least we did not see it very much in our experience.
One extension to that question to Dr. Mulasari, acute MI and post-COVID.
Just, tomorrow we have a debate on this topic, so I think we can keep the questions post-COVID for tomorrow's debate.
One practical question to Dr. Sethi. Have you analyzed the myocardial infarction in young patients? How many of them were genetically predisposed, or how many of them had the environmental factors which predisposed them to myocardial infarction? Delhi is a city where even if you don't smoke, you are inhaling 30 to 40 cigarettes per day. So has anyone done more genetically predisposition to myocardial infarction or environmental?
See, there are two things which are very important in this. Number one is that we have been studying data on young myocardial infarction for the last 25 years in our country. Most of the time below 40, some people have taken even below 30. 95% of them are smokers. That is undoubted. Incidence of hypertension and diabetes in Western literature is not high. As you go down with the age, the traditional risk factors go low. But in our country, diabetes being more common, you have seen the data being presented just now. The diabetes is a significant risk factor in our young population, particularly if they have that body profile with abdominal obesity and all those things. As regards dyslipidemia is concerned, in young MI, dyslipidemia is very common. Nearly half of them have dyslipidemia. Lp(a) was a problem, is a problem, I should say, but we never measured it for two reasons. For many decades. Number one was that there is complete unreliability of the labs in terms of the standardization of Lp(a) levels. And you do the same lab, two samples, same patient, you will find a different result. Even today I have that problem. However, there was no drug available for treatment of Lp(a) in those days. So what was said was that you follow the standard rules for controlling lipids, and even the concept of getting the LDL cholesterol down to 55 is relatively recent. It's not very old. At that time, initially 100 and then 70 milligrams was the target. But now that the therapy for Lp(a) management is available, one needs to do it more seriously, although we don't know what is the level of Lp(a) that we need to bring it down to, which will reduce the risk. Long-term follow-up of medication for treatment of Lp(a) and actual reduction in risk of infarction has not been studied very well in the studies. And the third thing that I would like to say is that the risk of Lp(a) causing myocardial infarction is high till the age of about 50. Gradually, as you go up above that age, the association between Lp(a) and infarction gets blunted. And there you need at least a level of 100 and above to call it more definitive risk. And the problem regarding treatment, certainly I have already mentioned to you. Even with the inclisiran and similar therapies that are available now, or PCSK9 inhibitors, maximum reduction of Lp(a) comes to the tune of only 20 to 25 milligrams. And whether you need to take it down to less than 50, less than 30, less than 20, we don't have any idea as yet.
I have a question to Ajit and the panelists also. We talk about various risk factors in young people. We are looking at the LDL values, we are looking at the LPA values, homocysteine, family history. We also, what we see in a lot of our population is a low HDL and a high triglyceride population, especially in youngsters, right? So the question is, do we have, at what point of time do we look at these as major risk factors? And in young patients, to prevent coronary disease or to prevent episodes in young people, what is the age that we should start looking for risk factors and investigating youngsters?
So for us, out of the 2,420 patients, of 549 patients, 81% were smokers. That is the number one. So smoking is still the commonest cause of young myocardial infarction, especially in men. The second most common factor was diabetes, which was in women, more sensitive than men. And I think we did a propensity match analysis on that, and we saw that women who are diabetes, and it makes sense because diabetes removes the estrogen protection which women have, and if you have less than 45, I think diabetes does that. The question of how often should I go ahead and start investigating other things, I as a policy would go after all these unusual things. If I see a non-smoker who came with an erosion and a clot, and in those patients we have about 76 patients now whom we have looked for all these unusual problems. And the fact is that only 5% of them in those unusual groups had these unusual problems. So it is very low, the chance you'll pick any of these protein CS deficiencies, Van Leeuwen factors, or any of those. Now the two other questions is, just for interest's sake, Lp(a). See, the Lp(a) is high in African Indian populations, and this is typically equatorial. And one very controversial paper came in, I think it was in one of the JAMA, which said that in malarial belts, the Lp(a) bounces high. And is this a surrogate of chronic malaria and not a real predictor of anything else? Because we clearly have not shown clear evidences that this is right and that is no. That has been sort of discussed and fought against and debated against, but I think what right now we know that Lp(a) may be high, but really treating that, will it help? Same with homocysteine. You can give any amount of folic acid. It has not shown event reduction. So I think many of these are not proven to be treatable.
And just one question on role of the newer PCSK9 inhibitors in young influx.
One more addition to what Ajit has said is that there is an advisory by American Heart Association president about a year ago that talks about cardiovascular kidney metabolic syndrome, which is a problem of dysfunctional fat deposition around the liver, abdomen, and that becomes the mother of every other disease that happens in terms of coronary artery disease, hypertension, and diabetes. In that, it is clearly mentioned and recommended is that the first lipid profile should be done at the age of 3. And if not done at the age of 3, certainly it should be done at the age of 10 and then followed up subsequently. Second question is regarding high triglycerides and low HDL. As I said that in younger people, the non-HDL is a much better risk marker than looking at the HDL. And if you ever find high triglycerides, because fibrates are useless, you should look at the non-HDL or look at the remnant cholesterol. And I can tell you a paper which has just been published about a month ago, November of 2025 in JAC, that specifically looks at the remnant cholesterol and the risk of atherosclerosis and acute myocardial infarction in the young as well as old. And in younger people, there is a linear correlation between the remnant cholesterol level and occurrence of myocardial infarction. That will cover your triglyceride because most of the remnant cholesterols are contained in VLDL and in intermediate density lipoproteins.
Dr. Ajit, one last question from Dr. Ajit Desai.
Yeah, question was to Ajit. We talked about the SCAD in females, you know. When you do the angiogram, it sometimes is very, very difficult to find out what is the cause, whether it is SCAD or what it is, because it becomes very, very difficult. And you showed some fantastic images as far as OCT. My concern is when you do the wiring in these patients, it's going to be very difficult to find out.
I would strongly recommend not to do it. It is only, that picture was taken on a patient without knowing that the patient had SCAD, to be very honest. Somebody did it without knowing that the patient had SCAD. So the question is, will I interfere with the SCAD with intravascular imaging? Answer is no. The angiogram is reasonably good, but again, it can be confusing at times. But you need to be looking at the angiogram a little more carefully. I really think the single photon, I just did one in one of my patients in single photon. It was fantastic, the picture. I think really that technology is maybe better than the angiogram for this sort of a picture.
I think we are running short of time. Thank you very much for this wonderful session.
Last comment, can I, if the chairman permits? No, I think we can stop it here.
So thank you very much, respected chairpersons. We are short of time now. And for the next session, the guest lecture, Professor Dr. Narasimhan was going to be here with us in person from Hyderabad. Sir is unfortunately indisposed, but because of technology, we can hear him. We can have him live from Hyderabad. So they will just be setting up the link, and I think sir is all ready to present. So I call upon the chairpersons, Dr. Pehlajani sir and Dr. K.K. Sethi sir, please, for this lecture. Thank you. Dr. Pehlajani sir, Dr. K.K. Sethi sir. Thank you.
We will miss Dr. Narasimha here in its presence, physical presence, but he will be there with us as intellectual talk. He is going to give us a talk on post-myocardial infarction on the Zoom call. Dr. Narasimha, you are with us? My co-chairman, Dr. K.K. Sethi, is here. Everybody has already heard him, and everybody knows him all over the country. He has been the past president of CSI. He has been the editor of the Indian Heart Journal. Been a very dear friend more than anything else.
Thank you very much, sir, for that.
Dr. Narasimhan?
Yes, can you hear me?
Yes, we can hear you, but we want to see you.
Oh, I don't know, 1 minute, let me just, yeah. Yes, I suppose that's all right.
Narasimhan has been a good friend for many years. We have been on many conferences together.
Thank you very much, sir, for that kind invitation. It's unfortunate that I couldn't attend this wonderful meeting. I was in a meeting talking about microbiome in cardiovascular disease and acquired a microbiome, which made me avoid the travel. That's how I ended up giving this Zoom call. Anyway, the topic assigned is on post-MIVT. I'm extremely grateful for the scientific committee, Dr. Satyavan Sharma and Dr. Pehlajani, for this kind invitation. We briefly talk about the pathogenesis, predisposing factors, and the difference in acute management and prevention of recurrence. Now, fundamentally, when we see a patient with post-infarction VT, this is very important. In a single lead, sometimes you can miss seeing a polymorphic VT in the acute setting, unless proven otherwise, it's ischemic. Even though the coronaries, you have opened up the vessel, it could be distal embolization, side branch occlusion. So persistent ischemia is often the cause for this kind of a problem following an acute myocardial infarction. whereas monomorphic VT in the acute phase of infarction can be related to temporary conduction blocks, and they often improve after restoration of blood flow. So revascularization is the key in the acute phase of both these disorders. Now, this is the famous GUSTO data which looks at patients who have never had a VT or VF in their ICU following a myocardial infarction. Their prognosis is very good over a year. But moment a person has an acute infarction and VT or VF, then the acute mortality is high. But if you can take care of this acute mortality, the survival curve plateaus over a period of time. So it's extremely important to be very vigilant in this acute phase to prevent VT-VF. Small things like periodic monitoring of their potassium, adjusting the medications. Maybe I'm sure the yesteryear physicians were so paranoid about these patients, they used to call them frequently, get them checked up and titrate the medication. That's important still if you want to avoid this steep drop in the first few weeks of a myocardial infarction. However, when a person has both VT and VF in the acute phase, their survival is poor, and we need to be very aggressive about treating these patients. One of the things that I would like to see is whether the patient has a good ST resolution or not. If a person has a good restoration of blood flow and an ST has resolved, ST resolution says functionally at the level of the myocardium, the ischemia is gone. These patients do much better because this is an important factor for you to decide at the end of 1 month whether to offer an ICD or not. Sometimes the EF slowly starts coming up over a period of 6 or 8 weeks. So if the person has a persistent ST elevation and the EF is still not improved, I'll have a low threshold for recommending an ICD in this subset of patients. So again, ventricular arrhythmia in the acute phase, the treatment is acute revascularization. And in late phase, monomorphic VT tends to recur, and very often this is scar mediated. Some of these patients have small infarcts, say a small inferior wall infarct, Q wave is hardly seen, but their natural history can be punctuated by frequent VT and VF. So we need to be very aggressive in preventing VT and VF in them so that you can prevent their functional class is good. If you just prevent this sudden cardiac death, either with medical therapy, sympathetic modulation, they'll do well over a period of time. So ongoing ischemia should be considered even in the absence of chest pain, and you need to relook at the angio, look carefully for an occluded septal diagonal, and you need to be aggressive about anti-ischemic therapy in these patients. Now, I didn't have a slide. There is some data to suggest that following the Merlin trial, that this subset of patients where you have small vessel occlusion, branch vessel occlusions, and recurrent VT, adding ranolazine seems to be protective. That is one thing which almost about 25% reduction in event rate in this subset of patients. So when you have a person with non-sustained VT in the acute phase within 24 to 48 hours, once they are revascularized in the long term, their survival is good. However, once you discharge and on a monitor the patient Holter or ELR, they have frequent non-sustained VT, this is a strong predictor for future events, and we need to consider offering an ICD in these patients. This is always a dilemma in a situation like ours where the resources are constrained. So we still, once you revascularize and the EF remains low, it's prudent to kind of give an ELR for them. And there's data emerging that if they have frequent non-sustained VT, that selects a high-risk group, and you may consider giving an ICD in that subset of patients. So arrhythmias during acute phase of MI, it's correcting the electrolytes. This is something which of late we have been seeing. Patients who have been on long-term proton pump inhibitors, they have a very high prevalence of magnesium, hypomagnesemia, and you need to, diuretics and needs to be taken care of, and you need to correct the magnesium in these subset of patients. Of course, the beta blockers are very useful. And for VT in this subset of patients, it's class 3 drugs which are used, reasonably preserved EF, and the patient is not in heart failure. Creatinine is normal, you can consider sotalol, whereas the conventional drug in the acute phase is IV amiodarone and lidocaine. AAVR is very often seen after revascularization, relatively benign, but it does have a prognostic significance. Patients who have been revascularized and who continue to have frequent AAVR do have some degree of myocardial scarring, and if the EF is low, we may consider giving ICD after 6 weeks. So acute MI and VT, again this chronic VT, this data has come out recently from the European group to maintain the potassium above 4, 4.5 in this subset of patients, especially if it's recurrent VF. One of the caveats are patients with diabetes. Patients with diabetes, when they have a blood sugar of 250 or 300, and if they have a potassium of 4, the corrected potassium is coming to as low as 3.6. So you need to, because once you correct the hyperglycemia, you will find that the potassium is going to drop, and when you do that with insulin, it's prudent to start potassium at the same time, provided creatinine is normal. And maintain magnesium about 2 milliequivalents. As long as the GFR is well preserved, you are not likely to hurt the patient. You can frequent polymorphic VT. We try at least to give an initial bolus of 2 grams of magnesium and then take care of the rest. So if a patient comes back little later after 2 weeks or 3 weeks with recurrent monomorphic VT, again, IV amiodarone has been proven to be effective. Between lidocaine and procainamide, there is a trial which looks at the efficacy. Procainamide is superior to lidocaine. But where this works very well is a class 3 drug and a class 1B drug. They are mutually complementary, and if a person hasn't responded to amiodarone, you can add lidocaine or vice versa. Again, these patients, time and again, it has been, this is a nice paper which came out from Belgium, from New England Journal of Medicine, saying that the choice of your drugs are important. If a person needs an inotrope, please avoid dopamine, and there is evidence to suggest, especially in cardiogenic shock patients, recurrent VT-VF, there is a case in point for using NORAD over dopamine or even dobutamine in this patient. So in the acute phase, in addition to antiarrhythmic therapy, this is very important to reduce the central cerebral autonomic stimulation. A person, the typical situation is a critical care person who's managing these patients. Patient is sedated, paralyzed, and ventilated. The only clue, if you look at this, is as the sedation effect wears off, there will be a bit of sinus tachycardia, there will be a bit of hypertension, and then the VT-VF will start. So at least for this group of patients, we need to talk to our critical care colleagues and rely little more on sedation and less on paralytic agents if the patient is in very sick condition, intubated and ventilated. Of course, I can't underscore the valve. Again, I'm going to talk about repetitive thing about correcting the ischemia. Now, if a patient has features of you need to give Lasix for a patient, or a person, you find the LV is quite dilated as an MR, there's a very low threshold for intra-aortic balloon pump for the simple reason it will allow you to cut down the dose of inotropes. It's not a great, I do agree from the several studies, but this is one situation where if you unload the ventricle, reduce the stretch activated channels, you will be able to mitigate some of these arrhythmic symptoms. Decreasing sympathetic drive is paramount, both with sedation and with beta blockade. Again, I would like to emphasize the circulating adrenaline, which is released following a hypotension, can be corrected to some extent with beta blocker. But when there is central cerebral outflow of norepinephrine through the stellate ganglia, they directly are delivered to the intramyocardial sites. And this is the reason why time and again we are talking about sedating the patient very well. We'll just go through one of the case examples. This is actually 14-15 years ago. One of our patients, lady, recurrent VT, was revascularized elsewhere. A couple of days later, she presented with recurrent VT, burnt chest completely because of 60 shocks or so. And this was going on, and she was sedated, ventilated. Then we put in a temporary pacing for overdriving the patient. Didn't work. IV lidocaine, beta blocker, and amiodarone. Now, this is one situation. The data suggests that using the non-selective beta blocker, good old propranolol, seems to have a benefit in terms of reduction of mortality in this subgroup of patients. So, if the patient doesn't have an obstructive airway disease or reactive airway disease, instead of metoprolol, which is often used, we would prefer in this situation to switch over to propranolol in this setting. Hypotensive patient, of course, look at the volume status, NORAD and dobutamine. Some of the youngsters in the crowd, I would like to say, increasingly, please don't just go by the IVC diameter. Time and again, focus shows IVC that is, full or collapsing, and you go and check the patient, the JVP is elevated. What will you believe? So don't lose those clinical skills. There is a discordance in some of you need to take this very important, because if the hypotension is due to any degree of hypovolemia and you are just going on increasing the dose of your inotropes, you are doing greater harm to the patient. Of course, we did talk about mechanical unloading, and these patients, they do very well with left sympathetic blockade. In the acute phase, you can call the anesthetist to use you can use sensorcaine to block the left stellate ganglia under ultrasound guidance. It gives you at least 12 to 24 hours of window that the patient has improved. If a patient has improved and then has a recurrence after 24 hours, you can think of doing a direct ablation of the stellate ganglia with RF. The anesthetists are very comfortable about doing this. Now, increasingly, this pseudo-torsades pattern is getting recognized over the last several years. It's well recognized in EP community. When you have a person with recurrent polymorphic VT, it's very important to look at the coupling interval of the initiating beat. So you may have a varying coupling interval, or you have a fixed short coupling interval. Why is this important? Because usually myocardial reentry takes a long time for the impulse to get into the infarct zone and set up a reentry. Whereas when you see a short coupling interval, it often indicates that his Purkinje system is the one that is responsible for initiating the VT and VF. I think all of you are aware, even in the presence of an infarct, his Purkinje system is relatively resistant to ischemia, and therefore they survive. They get decoupled from the adjacent myocardial cells, and therefore it's like a denervation supersensitivity, which you have heard in neurology. They'll have repetitive firing. And the reason why this is important, they don't respond very well to amiodarone. The specific ITO channels and Purkinje related ectopy responds well to quinidine, and that's the reason why that you need to. So you need to look at the short coupling interval, less than 400 millisecond, versus typically a long pause related VT, the mechanism that is true torsades, whereas pseudo torsades is when you have a short coupling interval which is triggering this, and this responds to quinidine. So this patient continues to be unstable, VT degenerating to VF. Would you consider ECMO, increase the dose of antiarrhythmic therapy, substrate mapping and ablation? Now I would like to pause for a minute. If quinidine is not working and you're progressively escalating the antiarrhythmic therapy, there comes a point when you shock the patient the next time, because you have completely blocked all the sodium channels, they'll go into electromechanical dissociation. So this is the time you need to consider either unloading the patient or mechanically unloading the patient with the impeller, whatever you have. But this important decision is, if the patient is completely doing well, in between the inter-VT period, the patient's hemodynamics is okay, but suddenly crashes only during VT, then the mechanism of, the clinical deterioration is all arrhythmia driven. So you need to think of a definitive therapy for an arrhythmia. You can call one of your EP colleagues, they can quickly map. It's not difficult. We have done in the presence of acute infarct. It's not very friable or anything, and you can get rid of. We have about 6-7 patients done within the first 2 or 3 weeks of infarct, and they do very well. And usually the cis-Purkinje system is at the borderline. This is a large infarct zone, and what you see in purple is a normal. At between the border zone, you find Purkinje potentials, which are tagged and ablated. And that gives this lady done well for about 12 years after the infarct, after the ablation, and recently she passed away due to a heart failure. Now, you have done everything right, and then you are going to discharge the patient. It's always prudent for especially the youngsters, don't reassure saying everything is all right, because sudden cardiac death is there is a finite risk in these patients. You need to counsel them. At the same time, you don't have a recommendation to implant an ICD in this acute phase. So we discharge them on class 3 drugs, always combine them with a beta blocker, and it's important to discharge them with an ELR. Nocturnal bradycardia will again trigger VT and VF when they are especially on class 3 drugs like sotalol. So the reason for putting an ELR is that you get an information to titrate the dosage in these patients. And as all of you know, oral amiodarone takes a while to achieve a steady state level, and that is the reason why in some of these patients who are hemodynamically stable, we may choose sotalol. So after a primary PCI, optimal medical therapy, MRAs have a significant antiarrhythmic roles. So there's again several studies which have shown both spironolactone as well as eplerenone reduces sudden cardiac death as well as your sacubitril valsartan. So optimize your heart failure medication, reassess at the end of 30 days. Now in this period, you need to monitor if there are frequent non-sustained VT. You need to consider, especially when the EF is below 30%, the decision is pretty straightforward. When you have between 30 to 40%, but high-risk indicators are there, we need to sit with the patient, talk to them, and then go ahead with an ICD or not, you need to take a call. One of the other conditions which presents like a sudden cardiac death is a myocardial rupture. Now, this is statistics from Valiant trial, which looked at valsartan in heart failure. In the first 1 month, the patient's so-called sudden cardiac death, when they did a autopsy, they found that a very high prevalence of recurrent MI or rupture in the first 30 days. This is probably the reason why ICD implantation in the acute phase doesn't provide mortality benefit, whereas arrhythmic risk increases subsequently in late phases after myocardial infarction. Now, what are the other ECG markers? When you look at the ECG, all the senior physicians, we used to look at the late potentials. When you see a delta-like wave at the end of the QRS, those are early repolarization pattern that is seen in patients in the post-infarction state. They suggest that there is a higher risk of mortality. So despite beta blocker and amiodarone, if a patient is getting discharged with persistent tachycardia, if the patient has a bundle branch block or a QRS duration that is prolonged QT interval, or this early repolarization pattern that I alluded to, all these things suggest a high-risk indicator So even if the EF is 35 or 40 in a young person, we need to push strongly for an ICD. This is the Japanese colleagues who have presented post-infarction patients who have had an early repolarization pattern on the ECG. This is the green survival graph where there is a increased mortality when the ER pattern was present compared to persons without ER pattern. In the first 3 years, the mortality is higher if they have this late early repolarization pattern. This is again a paper which came out from Circulation, a large number of post-infarction patients with mildly elevated NT-proBNP. If they have a normal QTC, the story is different, but the QTC is prolonged even in a post-infarction patient. If they have the combination of high BNP and prolonged QTC, predicts sudden cardiac death in these patients. So ventricular arrhythmias peri-MI, address the acute ischemia, correct the electrolyte abnormalities and all the hemodynamic factors. If the patient continues to have incessant VT-VF, look at this tracing, look at the coupling interval. If the coupling interval is short, continue, start quinidine on this patient. Whereas if it's a long coupling interval, the drug of choice is amiodarone, lidocaine, but do not withdraw the beta blocker. Anesthesia for this patient, low threshold for mechanical unloading, sympathetic blockade, initially with bupivacaine, followed by RF ablation if required. And at the end of a month, you need to think of giving them an ICD, depending on the risk character. If they have remodeled very favorably and everything has gone on well, you may just maintain them on medical therapy. So in summary, Chairman, ladies and gentlemen, I would like to conclude in the acute phase, any arrhythmia, the main emphasis is on revascularization. Optimal medical therapy significantly reduces the arrhythmic risk in these patients. Coupling interval of the PVCs are very important to look at it. When you have a varying coupling interval, that again suggests automaticity, and IV amiodarone and lidocaine for sustained monomorphic VT in our context, but procainamide is superior. And at discharge, you need to look for the risk of sudden cardiac death. Probably in a high-risk patient, it's prudent to call them to the clinic more often for titrating the medications. And then at the end of a month, you need to take a call to give an ICD. But if the patient had a recurrent VT and VF 48 hours after the infarction, then he is not in this primary prevention group. He has already had a VT-VF. You may give him an ICD before discharge. I think I'll stop here and again apologize that I'm not able to attend your meeting in person. Thank you so much.
Thank you, Dr. Narasimhan. It was a very elucidative talk telling us about the post-myocardial infarction, arrhythmias and death. Just only one short question. We used to talk about the R&T phenomenon. Is it still valid, like what Bernie Lown used to talk?
Yes, usually this R-on-T goes along with short coupling interval. So where it doesn't work is prophylactically treating these patients hasn't shown mortality benefit. But if a person had an event with short coupling interval, the R falling on the T with a short coupling interval, then it's prudent to treat them aggressively.
What is the current status of the wearable defibrillator in a post-myocardial infarction patient while the patient is waiting for a ICD? Want to ask any
so the event, as we saw this data, the first 30 days after a myocardial infarction, the mortality is driven by a large proportion of recurrent MI as well as myocardial rupture. There is data to suggest that patients who are present to our clinic about 6 hours after an MI, even though we revascularize, some of them become a hemorrhagic infarction. So intramyocardial hemorrhage increases the tendency for VT and VF. So those are patients where you can think of doing an MRI and giving them an ICD. But in large-scale randomized trials with wearable defibrillator hasn't shown a benefit. But having said that, there is a problem about randomization. All of us know in a very high-risk patient, we may consider using it.
Thank you, Narasimhan. Dr. Sethi here.
Sir, thank you, sir.
I have just like to request you to give two quick comments on the role of mineralocorticoid receptor antagonists, and the second is the secondary ventricular tachycardia after acute MI. The point that I am trying to make is that I call mineralocorticoid receptor antagonists as poor man's ICD. The reduction of sudden cardiac death with mineralocorticoid receptor antagonists is equal to what is caused by the ICD. However, this data is for primary prevention in patients with low ejection fraction after myocardial infarction who have not had a ventricular tachycardia. In the context of treatment of ventricular tachycardia after myocardial infarction, probably the other antiarrhythmic drugs are more important. Secondly, the take on secondary VT occurring more than 48 hours after an acute ST elevation myocardial infarction, and the role of ICD, because this group of patients has not been actually included in the guidelines and have not been studied by randomized trials.
You're absolutely right, hit it on the nail. In fact, way back in 1980s, Carl T. Weber, he was the first person to look at how the interstitial collagen comes down significantly once you give mineralocorticoid receptor antagonists, MRAs. And that was the foundational paper which led on to further clinical trials. And as you rightly said, it favorably remodels and reduces the arrhythmic risk. Now, the moment the patient has a VTB of 48 hours after an MI, even though it has not been well studied, the guidelines consider them as an indication for going ahead with an ICD. The only caveat is, please be aware the patient is on dual antiplatelets. They're going to bleed like crazy, and you need to take all precautions. This subset we quite regularly implant, especially one of the worst thing is ticagrelor. They bleed, and we have put in a device, and they do have slightly higher pocket complications compared to the rest.
It was an excellent presentation. Everybody enjoyed. Please give him a big hand. Thank you very much.
So we come to the end of this session. Thank you, Dr. Narasimhan sir and chairpersons. So we have some very exciting sessions ahead, the debates. Quick tea break. We'll be back at 4:45. Thank you.
Hello, check, mic check, check. Hello, mic check. Hello, mic check, check, check. Hello, mic check, check. Hello, mic check, check. Hello, mic check, check. Check, check. Hello. Check. Hello. Check. Hello. Hello. Check. Hello. Check.
उसको आ रहा है क्या देख
Hello. Check. Hello. Hello, mic check, check. Hello, mic check.
Ravenna. आवाज़ बाहर नहीं जाता है ना? हाँ, किसको बोलूं? Well, I want to welcome everyone for the post-tea session. The next session is session 5, which is on debates. Can we have all the people who are out for tea to come into the auditorium, please? A warm welcome to everyone. We are just shortly starting the next session on the debates. We have two very exciting debates coming up. The first one is the burning topic of, since last many years, which is on, is CT coronary angiography essential in an executive health checkup? And the second debate is the age-old debate which is it's evergreen, which is PCI or CABG, long-term strategy for a 30-year-old with multivessel disease. So please bear with us for a few minutes. We are just starting as soon as our speakers come up. So can I welcome Dr. Praful Kerkar, please, and Dr. Ajit Mulasari and Dr. Zoeb Sheikh as the chairpersons. Can we have Dr. Zoeb Sheikh? Yeah, thank you. So, sir, I'll hand over the sessions to you all to take the debate forward. Can we also please make sure we stick to time? That's 10 minutes for both speakers, followed by 2 minutes, 1 minute of rebuttal each, and maybe a very short conclusion of 1 minute each, just trying to save the time we've lost.
Thanks, Yuval. So I'd like to first call on, in this debate, which is a very important debate, is CT coronary angiogram essential in an executive health checkup? It is Dr. Uday Jadhav, and he will tell us why it's required.
Thank you, Ajit. So as you can see, I straight away changed the title that do I have a coronary artery disease? That's what a patient asks in the health checkup, and I say, get a CT coronary calcium score done, bottom line. So that's basically the, what is that? That's the message I'm trying to convey through this talk. All right, so hospital executive health checkups offer to detect CAD. What do we have? All corporate hospitals. Gold package, silver package, premium package, and they are inclusive of all these things. There are no exceptions in anywhere in India. This is what all hospitals have to offer. ECG, to detect a CAD, come on. Echocardiography, because something has to be included. And then a stress test, and that actually is what the label is. It's the current one, that's the current defined modality to figure out coronary artery disease. Now, how do we agree with this proposition, right? Because if you look at the data, it's miserable. And therefore, I quote this, why do hospitals have a stress test to detect CAD long back? This is what Bernard Shaw wrote in his prefaces, that it's not the fault of the doctors, that the medical service of the community as it's provided for is a murderous absurdity. That any sane nation, having observed that you could supply or provide for the supply of bread by giving the bakers a pecuniary interest in baking for you, should go on to give surgeon a pecuniary interest in cutting off your leg is enough to make one despair. So, that hospitals are offering a stress test to detect CAD is basically, it has nothing to do with the welfare strategy at all in terms of detecting CAD, just a modality where some amount of finance has to go to the corpus. So, I looked at what else you can do. In executive checkups, we don't do CT coronary angiographies, by the way. There are very few hospitals, but certainly a coronary calcium score should be done. We can argue and argue. Here is what hospitals offer as the first step, ladder step, and that's stress test. Here is the latest review of 35 years of treadmill exercise stress tests in symptomatic individuals. I'm not talking on asymptomatic, that's still worse in terms of sensitivity and specificity. What is the diagnostic accuracy? 58 and 62% for a treadmill, 97% for a CCTA. Scott trial reported as low as 39%. That makes CT coronary angiography probably as a first-line test in low to moderate pretest probability based on close to 100%. I would call it 100% in good centers, high negative predictive value, and the ability to detect a non-obstructive CAD. We must keep this figure in mind because what else we can do here? So let me show you exercise test. What is the future? And we look at normal, non-obstructive, and obstructive, and the follow-up period. Half of the myocardial infarctions that come through have no obstructive disease. And only 1/3 of the abnormal treadmills that have come through have an abnormal exercise stress test, right? We look at Scott, we look at PROMISE. PROMISE looked at, again, similar data to different studies. 50% of the MIs had non-obstructive disease anatomical. More than 55% of the MIs in PROMISE had a normal functional stress test. I'm saying this. The predictability power in symptomatic patients also has not exceeded 38%. It's truly very pathetic. And I can show you examples because I'm involved with both this and the cardiac CT. So here is a lady who is asymptomatic and test was stopped due to fatigue. This is very typical, right? You will see it on all your hospital executive checkups. The treadmill reported as positive a year and a half back. She was advised for a CAG. She deferred for it naturally. She said, I don't have any symptom. What is this? I just stopped because you asked me to stop the walking. Now in a dilemma, this was a pre-test ECG. That's the typical ST depression with a computer synthesized rhythm, nice one. in all the EKGs, stage 3, stage 4, recovered early, and but then that's the report, right? That's what the patients are given, that the treadmill exercise test is positive at peak exercise for reversible, inducible ischemia, need a clinical correlation, goes to a cardiologist in the hospital, he says, I don't have anything else, please get a coronary angiography done. And so this patient said no, somehow has a high LDL cholesterol, 0 calcium, angio done, absolutely normal, clean, nothing. RCAs, clean arteries, RCA clean arteries, PDA, PLV, distals, LADs, good images, no problem. Both 3D and the usual images, circumflex normal. So everything normal. This patient was put on a statin with ezetimibe, sent home, absolutely no problem. I will show you two important aspects to this. Here is a patient with a high LDL-C. The chest pain is atypical. The symptoms are positive. The treadmill test is negative. Now this patient also remains in a dilemma because the chest pain is there, irrespective of what your treadmill has said, and she is not able to exercise well. What do you then do? And therefore CT coronary angiography is normal. Here is a clean artery. Another one. A similar LDL-C of 160, atypical chest pain, coronary calcium score, though I said it should be done in everyone, and still say it should be done in everyone above 40, 0 calcium, no ischemic changes on the exercise tolerance test. You can see in the panel on the right coronary artery, in the middle part, there is no contrast. This was a significant obstructive disease. And now if you look at these two patients put together, the first and the second patient, look at what is the hazards ratio for getting with that major obstructive coronary disease, 1.293 versus 0.392. What are we trying to say? You may pick up such sort of lesions, which you will never do on anything else. Even a coronary calcium score, you will not be able to pick it up. But then you need some gatekeeper. You need some gatekeeper to progress further, and therefore these are some of our images just trying to tell you, you can pick them up. This patient had a chest discomfort on walking. Treadmill test showed nothing. The patient could not exert beyond the mid-third stage of the Bruce modified protocol, and the CT picked this up, and well, this patient underwent whatever the therapy. That brings us to a crucial question. Patients are asymptomatic, and what are you then going to do? What are the likely expectations? Translate this data into India. This is the largest data ever available. It's CAPIS. 30,154 randomly invited individuals between 50 to 64. Good, mid-age. Did not have any CAD, had a high quality CCTA, perfect CCTA. Silent coronary atherosclerosis in 42%, significant stenosis in 5.2, proximal 1.9, published in Circ, and probably the most quoted paper. All right. In those who had a 0 calcium, the CCTA still detected atherosclerosis in 5.5. Who are those patients? Strong family history, current smokers, diabetics. I think this is extremely important. When your calcium exceeds 400, you will see a significant stenosis in large number of. The CAPIS is actually an eye-opener. Look at it the other way. Patients without angina but coronary artery disease, what then? And this is still in publication in JAMA Cardiology from the Scott 2. In these patients, what does it help you? It helps, CCT helps you in getting a better control of LDL-C, better control of blood pressure, better weight reduction, improving the daily steps which patient monitor on their watches, right? And in this sub-study, you look at both cardiovascular risk score and atheromas. So what are we trying to say? That CCTA will score over everything else that you do in the executive checkups, and then you can look at if that's the center point, all-cause mortality, MI, combined endpoint, all gets better. The outcomes get better. This is the Danish National Cohort Study, 90,000 patients. Now, India has a huge number of patients. What else you can do in India, right? CT coronary calcium, by the way, get off the myth, is intimal calcification always to start with. There cannot be something that starts from adventitia. It's not a risk marker. It's not a risk factor. It's the certain documentation of CAD. No other test is comparative. No other test is confirmatory, it has superior diagnostic accuracy and prognostic, will avoid unnecessary invasive procedures, better event-free survival. You need it. You need to integrate this into the final diagnostic pathway. It's an absolute necessity in India. Lancet data telling you preventive therapies over 10 years have increased. So what am I saying at the end of it? You will listen to Dr. Prafulla speak after me. As Caesar said, he's a very honorable person. And whatever he says, you will have to accept that. But here is the point. Final point. Today morning, before I came here, I reported a cardiac CT in a stented 45 years old person, very closely known to us. It's normal. His brother, 42 years of age, if you are listening to me, day before had a MI with cardiologists around. 6 weeks back, stress test was done, it was normal. He suffered a MI and passed away, anterior wall MI, right? Well, you will have to look at it very carefully, ladies and gentlemen. Use it judiciously, but it's a great test in India to progress after the calcium score when indicated. Thank you.
Thank you, Uday. And then call on Praful, who says, this is not needed, often leads to further testing and debatable invasive procedures. Praful.
Well, thank you. Unfortunately, Doctor, by the time the slides load up, he spent almost till the end of 2 minutes, meaning 2 minutes to go, trying to explain to you that CT coronary angiography is a great modality. I totally agree with you. That is not the debate here. The debate is that I will not use it for an executive health checkup simply because this proposition that he makes is very worrying. Worrying not only because it's not based on any scientific evidence and it has got a potential to cause more harm than benefit, especially leading to unnecessary downstream further testing, including a stress test afterwards to invasive procedures. And what does a positive CCTA do? The natural corollary, we know what it happens after a positive CCTA. But there is a fair number of false positivity and overestimated CCTA lesions which lead to increasing costs, procedure-related risks, and of course the invasive evaluation and the revascularization, building up patient anxiety. What big deal did you do? You told him you grade here, you got a plaque there. Now he starts getting anxious. I'll show you cases to show that. No clear improvement in hard outcomes shown by him, and oculostenotic reflex that we have, borderline lesions get plumbed. Typical executive health checkup, the 4 HOLD, 3.5 positive, bad lifestyle, vices, party animal, family history negative. It's a no-brainer, right? What will he receive as therapies? What lifestyle advice you will give? You don't need a CCTA. And what happens? He gets it because he's got the money, executive health checkup. And for a change, this what he has shown here, the CCT grapher. Where is my timer, by the way, guys? Oh, I got to keep on looking here. Where is it here? Where is here? But I have got to each time look there, is it? Okay, fair enough. So what next? Now this guy has got this so-called, should I do an angiogram or should I do a stress test for him at this stage? Which case, I would have done it right at the beginning, right? We've given so many risk factors. Okay. Stress echo, negative. Okay. So what next? Just to remind you, he is asymptomatic and he does not have any functional test which shows him to be positive. Yet, this man who was asymptomatic up until now starts becoming symptomatic. He's now anxious about his coronaries. And what does he do? He is still got those usual after a post-party GERD-like symptoms relieved with pantoprazole. But no, he doesn't listen to me. He gets an angiogram done. And for a change, the CT grapher has given a fairly good, yes, but our oculostenotic reflex will tell us that this is not 70%, this is, and with a stress test negative, you want to do a plumbing job on him. Lo and behold, it's done because the oculostenotic man has reported it to be 90%, and he gets it. Nocturnal symptoms, placebo effect, gone possibly, right? But Lifestyle continues the same. Reassured, now you got nice normal coronaries. You had just one block and GERD-like symptoms continue. So, who benefited here? Yes, the hospital viewpoint, a revenue, easy revenue coming on, justifying the expensive equipments that they have got, as also the salaries to given to all those interventional cardiologists as well, right? I am one too, by the way. Yeah, so having said that, potential hazards, undue alarm and concern, implications, we do not know what to do about employment. Say a pilot has gone and done his CT angio, he's got a plug there. What are you going to do about his employment? Insurance premiums, we don't know. Whereas half of them, the SCAPI study showed that, half of them, asymptomatic ones, will have coronary artery disease. So what big deal about it? Yeah, potential for unnecessary testing, I showed you. Reassurance, with a normal CT angiogram, lifestyle continues, right? So, it's not just we guys who are doing that. This is an excellent study. Pricey, unproven executive CVD screening is the norm even in top US hospitals, including the Mayo clinics and the Cleveland clinics, whom we follow. And this excellent survey of 18 out of the top 25 ranked hospitals compared what tests they offered in executive health checkup with their top 3 guidelines recommending them or otherwise. And what do you see? Bottom line there is CCTA. A whopping 29% are offering them in their executive health checkups when the guidelines totally talk against them. So you might say guidelines are not guidelines. But you got to follow something. And why guidelines are made? They are flouted left and right by everybody. Right? Why guidelines are made? Okay, based on scientific evidence they are made. And this is an excellent editorial, worth reading the entire thing. I wouldn't read. 2 very important caveats. We are taught primum non nocere, right? Which we first do no harm. And we are doing harm by doing CC angios for everybody. And the second one that they point out is excellent. These executives spend a lot of their time and money for these tests because they believe that they will help them. If so, that belief is mistaken, right? And undermines the very legitimacy of cardiac executive screening programs. So, I agree. We have premature and malignant atherosclerosis, but widespread and indiscriminate use of CCTA is not a solution to prevent our problem. I agree again that it's a great modality, a preferred diagnostics test, better than a stress test, excellent negative predictive value, but only in the symptomatic ones. By design, all these executive health check patients are apparently at least healthy and asymptomatic, right? And again, top of it, not everybody is an Uday Jadhav to have that kind of a local expertise to interpret them, the CT angiograms. And there is a whole host of reasons why you should not be doing it. I was just telling them at the tea break, just yesterday, somebody has gone with an unstable angina and got a CT angiogram done with a troponin positivity left from one hospital to the other hospital and totally off. Because the calcium score was 2000, yet our man did the CT angio, thought the culprit is the LAD 90%, it was 100%. And the culprit artery was RCA, okay? So, on a philosophical note, does all this screening help us to save lives? No, says this elegant study, yeah? Then Scott-Hart, the much touted trial, Scott-Hart, it was done in symptomatic patients. Though a positive trial, okay, mortality reductions not there. And what is the explanation of this Scott-Hart to people who have designed now basis this trial on symptomatic patients, a trial going in relatively asymptomatic patient, just one risk factor, go ahead, do their CCT angio, and then see what's going to happen to them. Okay? So that is designed on this. The only scientific evidence available for asymptomatic patients to do CT coronary angios is the Factor 64 trials, 10-year-old trial, wherein what have they seen? It was a negative trial, right? Over a 6-year period, a negative trial, 900 patients, huge trial, excellent baseline control of CV risk factors in a standard care group. And who says that explanation why it came negative? Because the control group has excellent preventive therapy going on, right? So that's exactly what you need to do. Just know your risk factors, go ahead and do it. And 10 years later, now they want to still generate evidence, and they prematurely publish the Scott-Hart 2 data. I allege they prematurely publish it with only 400 patients followed over 6 months, when it's supposed to recruit 6,000 patients. And over the 6-month period, what do? Machhar marne ke liye atom bomb. That's what it is. Greater adherence to lifestyle recommendation and acceptance of preventive medical therapy. Instill fear into the patients that you got disease and therefore you will adhere to your lifestyle. My patient did not. Okay? So you will adhere to the lifestyle and the preventive medicines. And that's exactly what they write in their design paper too. Right? That patient acceptability, physician acceptability compared to risk scoring is low. That cost implications are more. Then also, unlike in a usual coronary risk scoring and giving therapies, incidental findings, radiation exposure, occurrence of adverse events, very many. And yet we do not know, on top of all this, the impact of what we are achieving by doing a CT angio first rather than following the usual risk. No international guideline, including the NICE guidelines from where the Scott-Hart 1 and Scott-Hart 2 have come around, recommend. Because why? They do not recommend because there is absence of any trial evidence. And even the Society of these CT graphers themselves, for asymptomatic patients, say may be appropriate for high risk. I've got one more slide after this. High risk of having CAD, maybe you may do it, which means maybe, right? And for asymptomatic low risk patients, they say that it is rarely appropriate. So that is where we are. And let me advance that to the last one. So just screen for these 4 hold risk factors and break their hold, or break away from the vice of unhealthy lifestyles, not just cigarette smoking, sedentary lifestyle, eating wrong. So in conclusion, ladies and gentlemen, I rest my case by telling you all that CCTA is not essential in health checkup schemes. No scientific evidence for CCTA as a screening strategy. Not recommended in asymptomatic by any major guidelines. It is more a money spinner, as I feel it is so. And potential for harm. Rather, I did not show the ones that get harmed because of the oculostenotic reflex that comes out because of the wrong way you diagnose those coronary disease, unnecessary investigations downstairs. Of course, there are, like the Scott-Hart trial, there is a Dane-Hart study that's going to come up. There is a Transform study that's going to come up. Until that trial evidence comes, currently at least, just screen for the risk factors, break the hold of hypertension, obesity, lipids and diabetes, and break away from the vice of the vices. Thank you so much.
We have a rebuttal.
I'm not going to state. Come here, Prafulla. So good. So there are a couple of quick points. That JAMA paper 2014. SCAPIS is the largest study in 30,000 patients, and the Danish registry, that's 90,000 patients. So that's one observation. Second, I absolutely agree with you. CTCA should not be an executive health checkup. First line strategy, the coronary calcium score should replace all the other stuff which are absolutely nonsense, as we showed. Third is that, Prafulla, we in CAD spectrum, we are not the tip of the volcano. India is a volcano by itself in young CADs. How else you are going to focus the attention on CAD? How we are going to pick up individuals at least 40 years of age and above? Below 40 is difficult. Below 30 is anyone's guesswork. I don't think we have a parameter by which you can conclude.
So I totally agree, CCTA. Again, I do agree, CCTA is a great tool. I suppose amongst our interventional cardiology group, there is nobody who recommends as many CCTAs that I do. I myself also go to my radiologist and try and correlate with what is in the angiography to it. Of course, for the future, CCTA is going to be a great tool. You might even make out the vulnerability of the plaque. Already the prevent trial vulnerability, not the invasive way as Ajit Mullah. But for the future, as of today, there is just no role to even offer it, even in an executive health checkup scheme, we do stress tests. No, though in asymptomatic people, 50 to 60 year age group, whatever executive 40 to 60 year age group, obstructive coronary artery disease is not required to be looked at with a stress test. No. It's just the risk factor screening, and that's about it that we need to do in any, because you can afford, you can pay more money, you have the right to pay more money, fair enough. So that does not mean I will do a CCTA to you to reclassify your risk. I can do your risk stratification just by spending some time with you and understanding your risk factors. That's about
Thanks,
all.
Praful. You made your point very clear that, and I think I'll just make one comment, and I think this is a great paper in BMJ in 2020. They took all, American system need not be followed. I don't think it's a great system. And if you look at the NHS system, maybe it's more sensible. So they took 12 tests in executive health checkup. Sugar, lipid profile, PSA, pap smear, mammogram, ultrasound abdomen, ECG echo, and a treadmill. And you'll be surprised, the mortality at 10 years was changed in men by only 2 tests, blood sugar and a PSA. And for women, a blood sugar and a pap smear. None of the other tests showed any difference in 10 years in terms of mortality. So the question of doing it for a routine health checkup, any other test is sort of very, very debatable. Well, you can have isolated high-risk patients, strong family history. All those patients maybe yes, but I think at this point of time, even a calcium score in a young patient will be negative. The calcium score is only useful above the age of 60 and not below that. So I think at this point of time, the CT should be only reserved at this time for symptomatic patients, not ACS patients, and extremely high-risk patients who are asymptomatic, like a strong family history. Is there any other comment?
For any test, the outcome depends on the pretest probability as a diagnostic test. So in low risk, intermediate risk group, the pretest probability itself is low. So using a CCTA coronary angiography would not be of much diagnostic yield, barring economic yield to the hospital. Is it going to change the way we treat? No. As said, diet, lifestyle would be the key. Even in Factor 64 study, they took patients who were diabetic. They were symptomatic, and they followed up, and they said that it made no difference in terms of mortality or no difference in terms of recurrence of MI. So here also CCT is not showing any benefit. But is this going to be like this? No. In future with photon counting, I guess this will change. We'll get IFR and photon counting, which will help us to predict. But that too in high-risk patients, not in intermediate.
All these are tests of the future. Everybody wants them. But as he said, basic testing, to add to what he said, blood pressure measurement should be a part of every primary screening. And you treat blood pressure and you save lives. Yeah.
Thank you very much.
Thank you.
Nice debate and a very contemporary debate.
Thank you. It is impossible to stop PGK sir in full flow. You can imagine he was my teacher and my guide. What a terror he must have been. So we can now go to the next session. Another very interesting debate. Can I call the chairpersons, please? Dr. Arun Mehra sir and Dr. Sanjay Rajdev, please. The topic is PCI or CABG. What is the long-term strategy for a 30-year-old with multivessel disease? So please.
Okay, good afternoon, everybody, and I must thank AOC for asking me to come and talk of this particular topic. The brochure shows me and Dr. fighting with boxing gloves on. It's not meant to be that. It's going to be a gentlemanly debate about what we're going to do. What is multivessel disease in a CAD in a patient who's 30 years old? This is something that in the literature doesn't exist, hasn't been covered in any trial whatsoever. So we are talking of hypothetical, and we're talking of what we usually see. What is multivessel disease? It could be anything. It could be left main with TVD, it could just be TVD, it could be some total occlusions, bifurcations. The disease could be discrete or could be diffuse. Calcification, presence or absence. And then what is the significance of all this in a young patient who's 30 years old? A patient who's 30 years, we expect him to live at least another 40, 45 years minimum. And that's the kind of timeline you're looking at in terms of what we do to him today, if at all. So is there any trial data to help us guide this? Nothing at all. We all know this kind of premature heart disease occurs in people with aggressive risk factors, and the disease itself is fairly aggressive. The long life expectancy, we just don't have any data from any randomized trial talking of 30 and 40-year-old patency of either stents or grafts. With this not there. Clearly, given the time span these patients are going to live, there is going to be a need for repeat procedures. That's a given. And clearly, what would be a reintervention or a repeat sternotomy is an issue that we need to decide today, because that's another problem completely as to what we are going to face. What are our goals? They remain exactly the same in a 30-year-old or in an elderly patient, which is symptom relief first. We want to, clearly in this age group, prevent future cardiac events, both in terms of recurrence of disease, new disease, closure of grafts, etc. And we hope, though there is no data to tell us that we improve survival and possibly improve the quality of life. So why is my PCI preferred? A, it's a minimally invasive procedure. The procedure risks are low, hospital stay is shorter, faster recovery, good symptomatic relief in appropriately done cases, and more importantly, I am reserving the need for a surgical option in the future that may be 10 years, 20 years down the line. I don't want that patient to be subjected to a repeat sternotomy at the age of 45. Clearly, we have data, at least from the elderly patients, that PCI in low risk complex cases is better than CABG, though in high risk, which amplifies. Again, syntax score we cannot apply to young people because it is derived from elderly patients, so you can't really think. And of course, ultimately, a young patient is not necessarily going to want to have his chest opened. So that's one thing, and his lifestyle doesn't need to be changed. So that's something that would put us more in favor. So then, what are the limitations of CABG? Lifespan of grafts, we all know vein grafts, 50% are occluded by the year 10. Of course, my colleague is going to talk about arterial grafts that live longer. Yes, they do live longer, but they are not lifetime grafts. And these are grafts, lifetime or duration of grafts, which are done on pump surgery in elderly people, and it applies predominantly Lima to LAD. We have just no data on what happens to OMs, what happens to RCA from a radial or a Lima, whatever. So, whatever we do, we are going to have a repeat procedure. So what are we going to do? Either do a PCI first, follow up with a surgery at a later date, or do a surgery first and then repeated PCIs as time goes by. CABG does not stop atherosclerosis. I think that is something that we need to realize. And the future need to operation is always, my surgeons will agree, technically doing a second sternotomy is difficult. The risks are higher, and at every time you open a chest, the risks are less, the benefit is lesser for these patients who undergo second surgery. You have a sternotomy scar, keloid formation. We all have patients who have keloid formation who curse us for experiencing the pain of angina, the pain of the keloid scar. The impact on careers, particularly people who are pilots, ship captains, etc., who undergo CABG lose their jobs. So that is another issue at this age group of 30 that we need to look at. Psychological impact from a variety of sources. And clearly, it's not really ideal CABG for small diffuse disease. And as I mentioned earlier, surgery is not a cure. I used to laugh when some of my senior surgeons used to tell our patients, I have cured you of your heart disease. There is no such thing as a cure for heart disease. It will come back in time. It depends how long the patient is going to live. So I'm going to close with two cases. One is a 30-year-old patient, third pervasive disease. Syntax score for what it's worth was 22. No dysfunction, no diabetes. The recommended strategy here was to do a multivessel PCI using OCT and adjunctive devices, and while using OCT, calculating both minimal luminal area and minimal stent area. Using these, a combination of DES, thin struts, atherectomy devices, IOL if required, and trying to remember that today's angioplasty has to be done with an endpoint of MS numbers. So 8 for the LAD, 6 and 7 for circumflex, and 14 plus for the left main to give good, durable results. And of course, last but not the least, you must follow it up with correction of risk factors, which is lifestyle, statins, and others. I'll just give you another case, just hot off the press in terms of durability. I just did an angio on a patient of mine who came in for a replacement of his third pacemaker. I'd done his PTCA with cipher stents to LEDs, circumflex, and RCA in 2002. And now he's come for his third. So as a routine, I said, I must shoot an angiogram to find out. All 3 stents, ciphers, widely patent, no new disease. So 22 years down the line, stents are patent and open. So first, we don't get to do these angiograms often. So just one number, but it's there to tell you, yes, it can work. So this is a patient of mine. You can see severe LAD, subtotal RCA, and total RCA and subtotal LAD. Circumflex, sorry. Despite my telling him he wanted angioplasty, so we did that. And that's the result. LAD circumflex done in one sitting, the RCA dealt in another sitting. This was 7 years ago. Patient is clinically doing well, no repeat angio, but clinically doing well. So we have some degree of durability as far as stents is concerned. This is another patient, triple vessel disease with left main, complex anatomy, female patients with hypercholesterolemia, with diabetes, strong family history, LV ejection for 30%, and our suggestion to her is to undergo bypass surgery, which she did. She had a Lima Y done as an off-pump surgery, went home. 8 days after going home, was brought to casualty with chest pain, dropped dead. So, to conclude, Mr. Chairman, this is just an angiogram. We should syntax score, for what it's worth, will decide the anatomical complexity. Left main disease earlier used to be a no-no for us, but I think most of us are now happily doing left mains, provided you're using imaging to help. Durability versus invasive, don't have much data on either. Some data coming together for stents on the long term. The age of the patient determines what's going to happen to them, and he's going to be a challenge because he's going to survive most of us who are doing the procedures. And clearly, without any debate, all of them, whether you do an angioplasty or whether you do surgery, you have to aggressively manage this patient's risk factors, or he's going to come back again and again. Thank you very much for your attention.
Thank you very much for finishing well in time. And please welcome Dr. Javli for your
slides. Okay, thank you. Thank you for this invitation, AOC. I'm honored to be here. There are certain dogmatic statements to be made. All of you have huge experience of treating coronary artery disease. And you know that today, you don't do PCI or you don't do CABG unless you decide syntax score at least roughly at a certain red line. So that is, that's a basic premise. CABG is as compared to PCI in multivessel disease has demonstrated a significantly lower incidence of repeat revascularization. And that becomes a very significant in a young man with long life ahead, period. These are the patients, if they don't have bad renal failure, multi-organ disease, then they have a long life ahead. And as we just now learned. In our experience of last maybe a decade, I don't know how many redo CABGs I have done. I can count them on my finger. We live in a very different time of surgery. Presently, across India, there is a significant improvement in the surgical quality of bypass surgery at all my junior partners' hands in my team, as I see. Use of second arterial graft is almost a law. Completeness of revascularization is always compared by the angiography and the ratio of graft that you want to do. The mortality and morbidity outcomes have improved quite a lot. There's a drastic reduction in the incidence of redo CABG. statins, initial DAPT for a year, second arterial graft, better follow-up, and a fantastic medical management that is available today. And if required, then the PCI can keep the ball going. But the PCI done first for multivessel disease and the CABG done later on is a very different dish. This statement by the Guerin Fire Mayo Clinic is an evergreen statement. PCI treats an isolated lesion in the proximal vessel. CABG bypasses the proximal two-thirds of the vessel where the current lesion and the future threatening lesions will occur. This advantage will always persist. In a young patient, there are two issues that are no longer debatable. The first is that the patient wants less invasive treatment, and that used appropriately, PCI can be very effective treatment. But there are important questions that remain. Is the current use of PCI in multivessel disease actually evidence-based? Are the limitations and risk of PCI explained to the patients properly? Does it represent value for money? And so when a cardiologist states patient want less invasive treatment, this is usually predicted on the assumption that both treatments are equally effective. CABG surgery is likely preferred for high-risk patients, such as those with left main, severe triple vessel, or diffuse disease, severe ventricular dysfunction, or diabetes mellitus. Both PCI and CABG provide good symptom relief. Repeat procedures are required more frequently than by PCI. Long-term survival and durability. Central argument is CABG provides superior long-term survival for young patients. And this I have seen time and again with a vast number of patients. An observational study focusing younger patients with severe multivessel CAD reconfirmed a long-term survival benefit CABG over PCI. And there are multiple studies that I could talk about. The NNECDGSG, the long form you can read there, CABG was associated with a better 10-year survival compared with PCI, particularly in the late phase after revascularization. The survival benefit was noted especially in patients with two-vessel disease involving LED and patients with three-vessel disease. Reduced need for repeat revascularization. The same study confirmed that the need for repeat revascularization was more common in PCI cohort. The time to reintervention was shorter for PCI. Pooled meta-analysis data of huge number, CABG superiority in reducing revascularization, suggesting PCI may lead to less favorable clinical results where revascularization is the primary endpoint. Contemporary real-world data from Medicare beneficiaries aged below 65 showed CABG was associated with significantly fewer coronary reinterventions at 3 years compared to multivessel disease. This, again, about the repeat revascularization. I mean, there is really no argument left on that issue. Completeness of revascularization. Again, there are multiple studies, including syntax trial and all these multiple trials that you can eyeball, that completeness of revascularization is much superior, especially when you are dealing with a younger individual, giving more than one arterial graft, doing a complete revascularization. You have a good follow-up. You have a optimal medical management. That is a very different dish. Radial artery 20 years. Unlike what we thought now, the current trials, Godino et al., JAC 2016, but even the recent follow-up by Godino, the radial artery is almost same as the REMA. Major adverse cardiac events. Studies confirm CABG is superior in reducing MI occurrences compared to PCI. A meta-analysis derived an exaggerated value of 2.71 and for MI, highlighting CABG's advantage in substantially reducing post-procedural MI incidences. The mechanical difference is the key. CABG offers more robust permanent revascularization by bypassing damaged segments, lowering the risk of recurrent MI, while PCI may be limited over time, developing residual stenosis and stent restenosis. Stroke risk favors PCI, true, but do you have in literature any class 1 trials of comparing PCI with an aortic Y-graft CABG? There are no trials like that. critical influence of patient anatomy factors. Diabetic status is a major detriment. Patients with diabetes and multivessel CAD benefit more than CABG. All of you know that, you have experienced that, than from PCI, reducing mortality and repeat vacillation. CABG offers a greater long-term survival advantage compared to PCI for diabetics. In a subgroup analysis to contemporary data, greatest survival benefit of CABG over PCI was seen in patients with diabetes. Anatomical complexity of syntax score, you know it very well. LED involvement, especially complex LED involvement, you know very well. The debate implications for 30-year-old patient. Rationale for surgical preference in youth. Heart teams have often favored surgical revasculation in younger patients due to anticipated durability and survival benefit over a long expected lifespan. The CRAG study, a retrospective analysis of younger patients less than 50 years old, found that CABG patients had similar short-term outcomes to PCI patients, but demonstrated significantly reduced major adverse cardiac and cerebrovascular events, including repeat vasculation at 5 years. Implications of 30-year-old patient, risk-benefit timeline. While PCI offers lower index procedural risk, that is, lower intermediate stroke risk, the significant differences in survival and reintervention often become apparent only at the late phase. CABG has a strong long-term investment for a 30-year-old man or a woman. The conclusion from aggregate data, when trying to balance procedural risk and long-term outcomes, the overall long-term outlook generally favors CABG in MVD, which is especially critical for a patient with decades of anticipated longevity. Redo CABG. These are gravely reducing incidence. From 2000 to 2009, redo CABG decreased from 6 to 3.4% of all CABG procedures reported to STS database. In my team, there are a lot of junior partners who are now, of course, well experienced, but including the surgeries done by all of us at a large number, our incidence of redo bypass surgery has become dramatically scarce. Reasons we already know, I already cited it. In this paper in 2011, 894 patients, the conclusion was repeated PCI increased risk for long-term prognosis of subsequent CABG. A CABG done after multivessel stenting is not the same CABG that you do for the first time. The long-term survival in patients who had CABG with or without prior coronary stenting, for the paucity of time, if you scan the literature, you will see it's not the same. If you do the CABG first time, do it well, follow it well, it's a very different story. Steeply reducing incidence of repeat CABGs, I talked to you about it. Summary. Overall efficacy, CABG demonstrates enhanced efficacy in treated MVD, particularly in reducing repeat revasculation MI. Decision focus is the choice requires a personalized strategy based on individual needs, heavily considering anatomical complexity and the presence of comorbidities like diabetes. CABG provides a more lasting and comprehensive solution for revascularization, significantly diminishing the likelihood of future ischemic episodes, making it a preferable option for young individuals who can tolerate the surgery better than the old individuals, and especially when the coronary disease is extensive. From an editorial by David Taggart from Oxford, John Radcliffe in JTCVS, that coronary surgeons, after constant goalpost changing, I have been doing this debate for last 30 years. I don't know how many times I have debated. I am at the stage of my life where I keep myself out of arguments. Even if you tell me 1 + 1 is 5, you are absolutely correct. Enjoy. Thank you. That's my team that operates in 4 Fortis hospitals and is done a huge amount of MICS CABGs. We now routinely do bilateral IMA, 4 grafts, and robotic, we have crossed 150. So thank you very much.
Dr. Vishan, you have 1 minute to offer the rebuttal. Make it count like 5.
Well, thanks, Dr. Chowdhury. You're quite right. Include your slide shows that the data that you're quoting for people at 50 or higher. and we are trying to extrapolate this data to a 30-year-old. We just do not have any follow-up of any measurable for any trial from any country in the world. So we are in a gray area. Clearly, patient preferences matter, and nobody wants to have a scar. Let's be honest about it. You could do minimally invasive. The data on longevity of grafts is also based on on-pump surgery and applies to Lima to LED. We just don't have too much data on what you will do when you are either doing minimal access surgery or you are doing off-pump surgery and you're putting Lima Y, the example I gave you, Lima Y dead in 2 weeks after surgery. So clearly, we are in an evolving, techniques are evolving, and before we jump into applying that, given a chance, most would want to have a PCI. Agreed, if the PCI can't be done and you cannot do equivalent revascularization, and that's important, then there is no debate. Then you ought to go for surgery. But if you can do it, then I think in this day and age, till data is available, we ought to be offering them PCI with the hope that you'll actually get a good 10-year survival. And then maybe later on, things will evolve. But as Dr. Javadi also mentioned, good follow-up anti-platelets, anti-lipid drugs is very important. And the statement that I mentioned, I've cured you for your heart disease, is just a misnomer. It's just a bunch of lies.
Anyway, so in that, if we don't have much evidence, which I agree with, so we fall back on common sense and intuition. Everybody of you are hugely exposed to treatment of CAD. So again, on the same note, imagine a 30 years young man who can tolerate the surgery far better. I'm not talking about MICS at all. Sternotomy, he can tolerate it so much better. I have so many young patients whom I have operated who run marathon. So that is a myth that sternotomy will create a problem, 2 months, and not later on. The CABG done after multi-vessel stenting is not the CABG that is the same as the fresh CABG. If I do a fresh CABG in a man who is going to tolerate it better with at least more than one arterial graft, and in the today's era of superior medical management, I think we will have a very different outlook for that patient. And it is evident, if you ask any surgeon that you know in Bombay or outside India, that last 10-15 years, we are hardly operating any redo CABGs. Today, our vein grafts are doing so much better. And today, patients with more than one arterial graft, they are coming back. They may come back for PCI. We should get going. That PCI will be different. But do PCI first and then do CABG is a very different story. Thank you.
Thank you, Vivek. Two last points. Can I show one slide, please?
While the slide is coming up, I would just conclude by saying that as operatives, a surgical operative is inherently biased towards doing a surgery, and so is an interventional cardiologist who is inherently biased towards doing a PCI. So the common ground would be to have a complete understanding about the coronary anatomy, do a syntax scoring, see whether the patient is a diabetic, whether it's got a proximal LED involvement or a left main involvement, see how the LV function is, and then make a heart team connection with sitting both the doctors across the table, and also take the preference of the relatives into account, and then go forward with the intention in mind that what are the long-term risks of doing either procedure for the long 30 years, because the gentleman is young, 30 years, so you're not looking at 10 or 15 years for which we have got data. We are looking at about 3 decades or 4 decades or 5 decades of life for which we have scarcity of data. So it has to be a team approach, taking into consultation the patient's preferences, and then we can go ahead as a team, individualizing each and every case.
Yeah. So this is a slide of a 12-year-old who required bypass surgery. So this is not a hypothetical situation. So we do get young patients who have severe coronary artery disease, and a Lima Y was done on this patient, and 4 grafts were put. So this is the answer to the question that how young a patient can be operated and Lima Y can be offered. The other point that I want to make is of a patient who underwent one of the first CABGs that was done in Bombay. This was done in 1984 when a team from London came in. Dr. John Wright used to come in. He operated on 8 patients. So this patient had a myocardial infarction at 44. He had 22 years after this first CABG. I reoperated him in 2006, 22 years after his bypass surgery. And he we followed him up to COVID 2019. So from the age of 44 to the age of 79, he was in hospital only for 14 days. So did we not cure cardiac problems? He had an entire lifetime asymptomatic.
Neither syntax
Thank you very
is
much.
done routinely, nor heart team decision is taken routinely.
Thank you,
So
sir.
we'll have
Thank
to
you.
Fall back on our comments.
Yeah, thank you very much to the chairpersons and the speakers. So, well, let's give a big hand to our two debate sessions. They have been really interesting on CT coronary angiography, as well as on the age-old debate of PCI versus CABG. Now, moving on to the next session, which is again a very day-to-day practical problem which we will all face in our clinical practice. The next session is on potassium perils, hyperkalemia, a trigger for SCD. Can we have our chairpersons, Dr. Robin Pinto, Dr. PJ Nathani, and Dr. Pritish Bagul, to chair the session?
We'll start the session. I'll ask Dr. Ponde, who doesn't need any introduction, to give his talk on potassium peril, hyperkalemia, a trigger for SCD.
Thank you very much indeed. This is an out-of-box topic for sudden cardiac death. See, recurrent hyperkalemia is associated with an increased risk of mortality and cardiovascular outcomes in heart failure subgroup of patients with CKD. We all know when CKD is combined with heart failure, it's a very different animal, very, very difficult to manage, very difficult to treat, because we can't optimize our RAS therapy because of several problems of hyperkalemia and progressive reduction in EGFR. And this study has shown that in a retrospective analysis of US claims database, is heart failure subgroup of patients with CKD and recurrent hyperkalemia had 30% higher risk of all-cause mortality, 45% higher risk of MACE, and 85% higher risk of inpatient arrhythmia. And this inpatient arrhythmia were two: one, ventricular tachycardia, and second, atrial fibrillation. In patients with chronic kidney disease, those who have hyperkalemia have again 32% increased incidence of arrhythmias and 59% increased incidence of MACE. Serum potassium levels and risk of sudden cardiac death among patients with CKD and significant coronary artery disease. This is one of the wonderful studies which was published in Kidney International Reports, which said that in patients with established coronary artery disease, hyperkalemia is associated with higher mortality and higher risk of sudden cardiac death. Even in patients with acute enzyme-proven MI, at 30 days, the risk of mortality is higher when your admission potassium values are 4.8 or above. And almost 45% of patients or 45% of deaths that happen in patients on hemodialysis are because of ventricular tachycardia and ventricular malignant arrhythmias produced by hyperkalemia. In fact, we just had 9 days ago, a 59-year-old lady who crashed during dialysis was brought into the ICU after almost 16 minutes of CPR from the dialysis unit and had a very broad QRS, bizarre ventricular arrhythmia. Serum potassium level was 7.8. So this is a unifying link to the SCD. While often remains asymptomatic in its early stages, it is important to diagnose it, and therefore we have started taking a routine potassium measurement just before, on the morning of dialysis, in almost all our patients. Hyperkalemia is just not an electrolyte imbalance, it's a potent arrhythmogenic factor, particularly in patients with underlying structural heart disease. And the mechanisms are very simple: reduced excitability, slowed conduction, and prolonged repolarization. However, though absolute level of potassium matters, it is the rate of rise of potassium which also matters. So if there is a rapid rise of potassium level, it produces a lot of problems than slow rise of potassium. Presence of ECG changes, yes, more arrhythmogenic. Baseline cardiac disease, if you have underlying structural heart disease like left ventricular systolic dysfunction or extensive, probably non-revascularized coronary artery disease, it is an important arrhythmogenic substrate. Concomitant acidosis and digoxin toxicity also produce higher incidence of arrhythmias with given variety of given level of serum potassium. The ECG changes we all know. I will not take you there. But how do you manage the hyperkalemia? As you know, in the emergency situation, we manage hyperkalemia by calcium gluconate, insulin glucose, and beta-2 adrenergic agents like aspirin nebulizations, etc. But all these measures, mind you, just shift the extracellular potassium to intracellular compartment. We just lead to redistribution of potassium. We don't reduce the total potassium burden in the body at all. And then, of course, there are some ancillary measurements which we always follow, low potassium diet, but we land up in discontinuation or abruptly halting the RASI therapy, including ACE inhibitors, ARNI, and mineralocorticoid receptor antagonists. And there are 6 big studies in heart failure showing that discontinuation or abruptly halting RASI therapy for a few weeks to tackle or to adopt hyperkalemia or correct hyperkalemia increases mortality. We have traditional potassium binders, but we know the limitations of them, potassium overload and intestinal side effects. So the common reason of stopping or reducing RASI therapy in heart failure is hyperkalemia, declining renal function, and hypotension. This is a big study done in almost 17,000 patients. So whether you talk about, whether you talk about CKD, whether you talk about heart failure, or just uncomplicated type 2 diabetes, discontinuation of RAS inhibition therapy increases mortality. The mortality increment is highest in heart failure, followed by CKD, and followed by that with type 2 diabetes. For long-term management now, we have a new molecule, sodium zirconium cyclosilicate, which is an inorganic crystalline potassium binder, which is insoluble, highly stable, and is not systemically absorbed. It exchanges the potassium for hydrogen and sodium at the level of intestine, both small and large. Harmonize was the first extension study which studied around 260 patients with hyperkalemia. Correction was done with SZC at the baseline level for around 4 weeks, followed by maintenance therapy, and majority of these patients were able to maintain normal sodium at the end of the study period. Realize Potassium was another phase 4 randomized double-blind placebo-controlled trial in symptomatic heart failure patients with reduced ejection fraction, LVF less than 40%, and who were on low-dose MRA. So the MRA dose were up-titrated, and hyperkalemias simultaneously tackled with Lokelma. So 4.4-fold more patients were able to take full dose of MRA, 63% relative risk reduction in discontinuation of MRA, and 49% relative risk reduction in the first time to hyperkalemia despite being on full dose of MRA and without hemodialysis. Another trial conducted with heart failure patients with reduced ejection fraction with the same molecule, giving patients RAS blocker and MRA together. This showed that the MRAs were able to be given far more frequently, 93% versus 52% when the patient was taking Lokelma. All Fantastic Four, the ability to give all Fantastic Four increased from 32% to 64%, and thereby reducing mortality from 43% to 18% at the end of study period. So there are several such studies. I will not go into details of that, but let me compare Patiromer versus Lokelma. Patiromer is also in the offering and is going to hit Indian markets in another 1.5 years' time. Patiromer acts much slower as compared to Lokelma. Lokelma acts much faster. After a single sachet within 6 hours, you can expect around 1.5 milliequivalents reduction in the serum potassium levels. It's a non-polymer drug, very stable, and does not require special storage conditions. So the only downside of this molecule is the sodium load that it carries, which is much lesser than the K-bind that we are using currently, but tolerable to majority of heart failure patients. So to conclude, hyperkalemia is a critical, often underappreciated trigger for sudden cardiac death, particularly in patients with CKD and heart failure and CKD and concomitant coronary artery disease. Acute management is time sensitive, and chronic management with a acceptable, reproducible and reliable drug is important, and we now have one such drug at our armamentarium. A multidisciplinary approach is usually required, but we should never underestimate the threat for hyperkalemia, particularly in CKD patients with heart failure who are on RASI therapy, and CKD patients with underlying extensive coronary artery disease or left ventricular dysfunction. Thank you.
Thank you, Dr. Ponde. Dr. Ponde, I wanted to ask you, it's a very common clinical problem. How often you check potassium in your patients? You know, you have heart failure patients, you're giving them so many tablets, the creatinine is borderline. I always check, suppose I increase the dose after 2 weeks, 3, I'll check. But then do you go on, keep on checking like every month, ask them to check, or what do you do?
I'll tell you, in the first 2 months of therapy with ARNI and mineralocorticoid receptor antagonist started one after another or together, we check it almost every week. And then at the end of 8 weeks, when you know the potassium is relatively stable, then it can be done for every month for the first 6 months, and then we know the frequency ourselves. So majority of our patients are replying sending our reports on the WhatsApp, what was the potassium, and then we titrate the dosages accordingly.
So one more practical thing what we observe is even when we correct the potassium, lot of time magnesium is also one of the things which needs to be checked. Yes. Because they have a very close association, and yes, especially in heart failure patients, yes, most of them are on antacids and there is a high concentration of magnesium in that. So that is one more thing we need to look in our clinical practice.
Sure.
Yeah.
That's fine.
Any questions from the audience? Praful?
It is on, it is on.
With all these labs doing collection of blood here and there, is hemolyzed sample. And I've had so many patients with hyperkalemia who come with potassiums of 5.8, 6.5, dangerous level, moving around, and you quickly get from your outpatient the potassium done, it's normal.
Spurious
and
hyperkalemia.
Gone are the days when we were taught that doubly checked.
Yes.
Yeah, and sample not hemolyzed to be written on the thing. All these metropolis included to anybody. There is a stamp of a signature is not, meaning not the pathologist, is science for what? So that is what it is. I think we should, as a cardiology community, start writing to these people.
Yep.
And that is the commonest reason I see hyperkalemia, at least.
To be fair, some labs, Hinduja, they phone you up if some report is way out, especially yes, PTNR. They will phone you immediately, doctor, are you expecting this? Were you expecting this?
Yes, yes. Some labs do that. I'm not denying it. They say, come and contact your cardiologist immediately. But I have had such also from private labs doing it.
Yeah, and just like the gaps between guidelines and clinical practice, the gap between labs and clinicians will remain, but I think they are slowly becoming very, very bridged up. Thank you.
The point is that hyperkalemia as such, how often do we see in practice as much as hypokalemia? And there was a nice article, and which is true. Hypokalemia kills more than hyperkalemia. So that's important in heart failure therapy.
Sure. Thank you.
Thank you, everybody.
Thank you very much for the last session on hyperkalemia by Dr. Ponde. Thank you very much, chairpersons. We'll have a very quick and short tea break, and we will all regroup at 6:15 for the next session, It's a case-based session, so please do come back for very interesting discussions with Dr. Shantanu Deshpande and Dr. Sadanand Shetty, and very interesting cases, very practical approach. Thank you very much. Can we have everyone join us for the next sessions? Well, a very warm welcome to everyone for the post-tea session again. Let's move to session 7, which is a panel discussion on case-based dilemmas. And we have two very interesting cases coming up. Let's first have the expert faculty on board. Dr. Kane, sir, Dr. Rajiv Karnik, sir, and Dr. Amit Sangvi, sir, please be on stage. And can we have the moderator, Dr. Shantanu Deshpande? Thank you.
Good evening, everyone. We had very interesting debates, and in continuation with that, this case also is very interesting. And can you show? Yeah, okay. So the case here is a 35-year-old asymptomatic businessman was detected to have Augustin score of 250 on ABCD calcium scoring. And this is a subset of patient. Now, if you see, this is a less than 40-year-old person, asymptomatic, totally asymptomatic, and there are no risk factors which have written over here. So his CT scan was done, which is calcium scoring was done, and it was 250, basically. So this is a very interesting subset of the patient. So what I'll do is I'll ask questions per expert, and we'll have a good discussion, basically. Now, when you assess a risk less than 40 years of age, there are hardly any pooled cohort equations. What pooled cohort equations what we are using is ASCVD score or a prevent score or Q-risk score, which are generally validated in the Western population. They are not validated in South Asians and not validated in less than 40 years of the age. Many times, if less than 40 years of the age, that drop down doesn't show, basically, if you are calculating scores. So we don't know why the CT was done, CAC was done. So my first question is to Dr. Karni. Okay, how to assess risk in a 35-year-old Indian male, as there are no validated pooled cohort equations tested specifically in Indians? Do most of this ASCVD score or Q-risk scores underestimate risk in Asians or Indians? should we add CAC routinely to all patients to assess risk? Because we see young patients with MI, young patients with very severe disease, very aggressive disease commonly, and many times, more than 50% of the times, they don't have any conventional risk factors as such.
Yes, Shantanu, very good question, because 35-year-old businessman, I mean, he would definitely, he has taken a lot of loan before starting his business, lot of EMIs, worried about if he's the sole breadwinner for the family. I mean, he will be interested in knowing what lies ahead in my future, and he has done these studies. He has no risk factors, you said, and then he has done calcium score, which is a little unusual thing, but we do come across such cases. I mean, people doing all kinds of investigation, they come with a wad of investigation and then they show us, these are all my reports and tell me what lies ahead of me. And as you rightly said, the scoring, if you try and see, the Americans go for a pooled cohort, which is 40 plus, applicable for 40 plus. The Europeans go for score, which is again for 40 plus. The prevent, again they ask for zip code of America, which we don't have, which we cannot put. Then what else? In Scott Hart, what score that was used, they also asked for Scottish zip code, which we don't have. So Indian LAI has advised to use QRIS 3.
Yeah.
But again, in this risk scoring, I would say there is a dichotomous division. Diabetes, yes or no? Smoking, yes or no? But how many cigarettes is smoking? Is the diabetes is there for more than 5 years, 10 years, 20 years? So I think we have to individualize, personalize, and then not just go by scoring. By scoring, if we give the medication, we feel that, you know, like in young patient, less than risk score less than 2.5, more than 7.5. We have low risk, intermediate risk, high risk. And we have a false illusion of precision treatment. I mean, we say we are giving precise treatment with as per the score, what is to be given, etc. But this is an illusion because, I mean, there is dichotomous division. So we do need something else. And I think if he has already come out with the calcium score, then I would say yes. I mean, this is a cardiac study which showed that it's almost 5 to 6 times higher, for 5-fold increased chances that we can predict what lies ahead in front of him. Similarly, from MESA also, in 2008, there were 2 demonstrations. Yeah, this was one, Detranos with, again, 6-fold higher incidence. And let alone, even if there are no risk factors, just merely calcium score from 100 to 300, which this patient had, 250. So he immediately goes from, you know, from low risk to high risk, and he becomes eligible for the treatment. What treatment, I think that will discuss in the subsequent.
So the thing is, this is a cardiac cohort study, which was a very important study in which the patients were 18 years to 30 years. This is a cohort of 18 years to 30 years, which are followed up to almost 30 years, and almost more than 70% they could follow up. And they found at 15 years they did a CT as calcium scoring, basically calcium scoring, and whenever even when calcium score was more than 0, they had higher risk, almost 2.6 times if it's 1 to 19, more than 5.8 times if it's below 100, and more than 10 times almost risk if CAC is more than 100. So MESA, 0 CAC, the risk was very low. In fact, major coronary events were almost negligible, major coronary events, no MIs. So it gave a confidence, basically. So what I mean to say is whether calcium CAC scoring should be applied in all young patients in Indians, basically, because Indians have more than 2 to 2.5 times risk. I think.
So the problem with calcium scoring is we get a lot of young patients with ACS in our, and a lot of our young patients would probably have a calcium score of 0. Just because the calcium score is 0 does not mean the patient does not have a plaque. So probably in our scenario, in the Indian scenario, calcium score is one thing, but if you're going to do it, probably it's better to do a CT coronary angio, because we'll come to know whether it's an obstructive plaque or a non-obstructive plaque. And that will completely kind of change the...
So I'll come to you, Amit, next question. What further investigations will you do in these patients? What blood investigations you'll do? Whether you'll do a ischemia testing or you'll go ahead with a CT coronary angiogram in this patient, or you'll just advise medical therapy?
No, so the calcium score is more than 250. So this automatically puts the patient at a high risk. Now we look lot of times we look at ischemia testing. That's one way to go because we have data to show that ischemia testing probably will help us to determine whether this patient requires further intervention. But let's not look at intervention only. So we cardiologists are not only plumbers, so we also need to optimize the patient's medical therapy. And for that, of course, blood investigations, they're looking at the patient's lipid profile, lipo-little-a, HSCRP levels, with looking at the patient's HbA1c, all that. So multiple risk factors should be taken into account. And we should probably go and do a CT coronary angio because, like we were just discussing, we'll get more information. So the data is very clear that whether you have an obstructive plaque or a non-obstructive, means whether the lesion is less than 50% or more than 50%, that completely changes the treatment. Once the patient's calcium score is more than 200, this patient will be eligible for at least moderate to high dose of statins, and we need to get the patient's LDL below 70. But if you find an obstructive plaque, say you have a lesion in the RCA which is 50 or 60%, then we would probably like to get the patient's LDL even below that. So get the LDL below 55. That is what is recommended.
Okay. So you'll go ahead with the CTCA. That's the answer. Okay. So in intermediate risk, very low risk patient, this is like a proper ESC guidelines. This is for chronic coronary syndromes, mostly symptomatic patients. This is not for the symptomatic, but they are recommending 5 to 15% risk CCTA for all patients. So what is important, whether you should test ischemia, I'll come to you, sir. What is more important, ischemia or anatomy? The thing is,
are we discussing it in relation to that patient?
yes. No.
Okay.
No, in general, I am asking what is...
This becomes a general question, yeah. I would love to discuss in relation to that patient, but let's stick to him. Okay. Now, I'm surprised that he does not have any risk factors when he has a calcium score of...
No, we don't know basically. It's not been given in the case scenario. So that's why I asked for a blood test. What blood test?
I would like to discuss something which is basic. For this question, the answer is both are important. Obviously, there is nothing more important one over the other. Both are equally important, I would say. But in this particular patient, since we do not have data, means we don't have any Indian studies, so we have to go by whatever is available, because that's what we have been practicing medicine throughout our undergraduate, postgraduate, and now in practice, because we fall back on whatever. So with that, I feel, first of all, pulled or the risk score, because they give you a lot of information. It is said, and I think the debate also said, that if you can take care of those risk factors, you almost won the game, if you can do that properly. CT scoring, which was done very surprising. So now that it is there, I would look at it as a primary prevention. I'm not interested in going for ischemia or anatomy. And he requires moderate to high intensity statins for whatever it is worth. And then you can take it from there, because I thought this patient is mainly for primary prevention, because he's asymptomatic, he's young, he's a businessman, and he has a calcium score. So obviously he'll have some risk factors. So I think we should be aggressive on those.
So you don't want to do anything further?
I would not at this stage, but routine investigations can be done.
You don't want to go ahead with CTCA or a stress thallium or nothing?
No, I have a different take on that. I agree with him. In today's scenario in India, when we have young infarcts which come left, right and center at any age, the only way to pick up vulnerable plaques without calcium, with or without calcium, is a CTCA.
But
I don't think of any. So I also agree with him. From whatever literature that I learned after going through, because of this case, I have learned a lot, Shantanu, thanks to you. So I feel CTCA is a must for most Indian young people.
Okay. So the thing is, what we are talking about is a FAI, fat attenuation index, but which is not there in India.
I don't want to go into the data and worldwide, because that will take a lot of time. Our people are dying here. So what are we supposed to do with that?
Two interesting slides. One is a Scott Hart, where CT-based approach was supposed to be better, whereas PROMISE study, it showed equal results with the anatomy based, which was tested with CTCA, and functional testing, either stress imaging or stress test, which was done. So equal long-term results basically. And this was similar. Ischemia trial, all patients underwent CTCA before randomization, and left main and non-obstructive plaques were ruled out. But the caveat is asymptomatic patients, guideline recommend only medical therapy. Now, question 4, again coming to you, Dr. Karnik. Does this patient fall in primary prevention or secondary prevention? And what would you advise, only lifestyle or drugs? And what should be the goals if you are giving lipid-lowering therapy, and what's the role of aspirin in this patient?
Yeah, there are 4 questions, rapid fire. I'll try to answer quickly. Primary or secondary prevention, it will be basically secondary prevention because he has subclinical atherosclerosis. Only 2 exceptions. If he has chronic CKD, then there can be medial calcification, calcium score may be high, but still there may not be subintimal plaque. Second, if he has hyperparathyroidism, again he will have ectopic calcium, and which will not be actually subintimal, which will be eligible for the secondary prevention. But yes, I mean he is for subclinical atherosclerosis for secondary prevention. Lifestyle modification, yes. In fact, the lifestyle modification becomes very easy, and implementation of statin becomes very easy if the patient is demonstrated, because patient seeing is believing. When he sees a plaque, he knows he has a problem. If you tell him your LDL cholesterol is 150, he doesn't go for it. And in fact, small increment in moderate activity. Just, I think 13th of January, just 4 days back, there was Lancet article that 5-minute increment in activity reduces in 5 years 10% death rate. That was just 3 days back in Lancet paper. So I think people adhere to all this secondary prevention if they are demonstrated. And then all these 3 things can happen: lifestyle modification, statin, as well as aspirin.
What will be your LDL goal in this patient?
LDL goal will be 70.
Okay.
Because he becomes high risk as per 250 by Lipid Association of India classification.
Will you prescribe aspirin to this patient? Aspirin?
Aspirin, yes, I would, because he has a subintimal plaque. So aspirin, all the 3 I said: lifestyle modification, statin, and aspirin, all the 3.
Amit, you are being a prolific interventional cardiologist. Will you do angiography in this patient?
Difficult. So I think if you have a CT-CAG, then you can just do a CT-CAG and see what happens. Unfortunately, we don't have CT-CAG with FFR because that would probably just solve our problem. There are trials which have shown that if you do that, then you don't do invasive angiogram. So we could have just done it. But suppose if you do a CT-CAG and you see a 70% lesion, then it becomes a problem. Because we know that proximal LAD is something that we all interventional cardiologists worry about. So probably if I have a 70% lesion, probably I would take this patient up for an angio and see what's exactly happening. Because sometimes there will be a discrepancy in the percentage. And if there is a borderline lesion, you can always do an FFR and then decide. Or you can do an OCT and see if there's a vulnerable plaque and then decide whether you want to intervene.
I think I'll come to the last question now. You want to answer this?
No, whatever the last question, let's see.
Now this patient, you have started on statins, you are trying to target this LDL cholesterol. How will you follow up these patients? Will you repeat his CAC after 5 years, 2 years? Or what?
See, first of all, CAC score is to be done only in intermediate risk patients.
Yes.
Because that's where the benefit is maximum. So we don't know where he stands because we don't know the score. Once you've done a CAC score and you start on statins, what happens, which is very interesting according to me, is that the calcification density increases and the plaque regresses. So if you do a repeat CT calcium score, it will always be higher. So many people advise that there is no need to repeat a calcium score if you already started because it's likely to be higher. But there are advices which say that 3 to 5 years down the line, you can always do it. And if it is very high, like you started with 250 and it becomes 500, then you know that something is wrong with his preventive methodology. So that will help. But otherwise, a slight increase in the rate, it is in fact better, they say, because if the calcification becomes harder and the vulnerability decreases, these people are unlikely to have an MI. So it's best way, that way we can look at it. So thank you very much.
Thank you.
Thank you, Dr. Shantanu, for your excellent moderation, and the chairpersons, Dr. Amit, Dr. Rajiv sir, Dr. Kane sir, for a very enlightening discussion. Now we come to the second of these panel discussions. I request Dr. Sadanand Chetty sir, the moderator, and the expert faculty, Dr. Zakia Khan ma'am, Dr. Nagesh and Dr. Girish, please take their places. Very interesting topic. A 32-year-old lady without other risk factors, total cholesterol 320, LDL-C 240, LPA 120. Sir, please.
I would like to thank Dr. Pelagini sir and team AOC for giving this opportunity. When Bhavesh told me to talk on this topic, since I thought I know a little bit about lipidology, but when this particular case was given, I was totally floored. But I'm lucky that I got 3 expert panelists, and I would like to see what next 15 minutes we can discuss on this case. This case is 32 years female in the reproductive in the period, total cholesterol 320, LDL-C 240, LPA 120, and not on oral contraceptives, and there are no other risk factors. So this is a case, what we are discussing. Oh, Dr. Duma is there? Yeah. Oh, I didn't know that, sorry. Yeah. So now what discussion we are making here is essentially this preconception. This particular lady with this reading of 240 and LDL, total cholesterol 340, LPA 120. Jakia, what do you think, like when we see such patients, how to really risk stratify? Basically, the point is, whether she is harboring atherosclerotic cardiovascular disease, because this is quite very high level. Most likely this could be a familial hypercholesterolemia, and she may be having this cholesterol history for a long time. So our idea is to see whether she has got atherosclerotic cardiovascular disease or no atherosclerotic cardiovascular disease so far, something like a subclinical or so. How would you risk stratify this patient?
So basically she comes in a very in the category of probable familial hypercholesterolemia with this level of LDL cholesterol by the Canadian score. We would like to know some more pointers from her history, like is there a family history of premature coronary artery disease? Is there any other comorbidity? Does she have any phenotypic features of familial hypercholesterolemia like xanthomas or arcus enardis? This really puts her into a high risk category. Her risk score will be difficult to calculate by the routine scores because she is less than 40. But her risk of coronary artery disease is 20-fold higher than the normal population. In addition to a LPA which is so high, it makes her still higher
So basically, when we look at this lipid abnormality, we have to stratify, as Rajiv Karnik previously mentioned, is it a high risk or extreme risk category? This particular lady at least come in the very high risk group. If she has no atherosclerotic cardiovascular disease, wherein we have LA target of at least 50 LDL. Now, if there is a atherosclerotic cardiovascular disease, our target may go down further, even up to 30. So therefore, our role is to see any further investigation you like to do.
So maybe we would do exercise stress echo, and also maybe if possible look at the carotid intima media thickness, or even a CTCA to demonstrate if she has any subclinical coronary artery disease.
Yeah. So by common sense, we have to exclude by common investigation. One is the coronary artery calcium scoring. Subclinical atherosclerosis. There are 3 things we do in subclinical atherosclerosis. One is the CAC calcium score. Second is the ankle brachial index is easy to do, and then the great vessel ultrasound, like maybe carotid, maybe the femoral. And then also CTCA, probably there is a strong indication to do CTCA in this case to establish whether this patient has got any disease or not. Now, you diagnosed that she has got FH, most likely heterozygous because she is 30 plus. Homozygous survival beyond 20 years so is not common. So she has an heterozygous familial hypercholesterolemia. Now she wants to become really pregnant. Now the point is, before the conception, how you are going to really approach this case so that by the time she conceived, you try to get her LDL little optimized. See, if she has got some plaque, you have to stabilize the plaque. There are papers also where they say you've got a high LDL, stabilize the plug for a few years, and then they can go for pregnancy and things like that. At least the event, the vulnerability of the plug can go down. Now, so what are the non-pharmacological therapy? Now, Nagesh, you can just, the standard non-pharmacological therapy is always a therapy we recommend for every lipid abnormality.
Sir, it's a very important case discussion is kept here. I know this is not very common, but I'm sure some of us are going to face this scenario of a young lady who is in childbearing age presenting with very high levels of LDL and the LPA level. And we don't know her body mass index, we don't know her waist hip ratio, what it is. We don't need to know because she is falling in probable familial hypercholesterolemia, likely heterozygous as you said. And this cannot be just because of the diet. The patient's diet is haywire and that's the reason the LDL is going to 40. There has to be genetic reason. Now when we consider this angle, so only non-pharmacological therapies are not going to help her. And as madam said, we have to see whether the patient has established atherosclerotic process, and based on that we have to counsel. She is in childbearing age. She needs definitive medical line of therapy along with the non-pharmacological therapy. So in case of non-medical therapy, the patient should start exercising regularly as recommended by ACC-AHA. The patient should try to maintain BMI of 23, not 25. I will be happy if it is 23. The waist hip ratio also I will look into. It should be kept below 0.8.
So essentially what you are saying, Nagesh, is the standard of care, what we do, non-pharmacological, etc., which you are going to adapt here also. And if she's overweight, plus BMI, and then the other non-pharmacological. Now, Girish, now the problem in pregnancy or preconception is the toxicity of the lipid-lowering drug to the mother and the fetus. That's a key issue. And therefore, by the time she gets pregnant, what level you would expect that is okay, or whether you have to continue. See, the problem in lipid lowering is the toxic effect on the pregnancy, particularly the statins. So now you know what are the different drugs available, Girish, yeah.
So again, I'll congratulate the organizers for this excellent case because it's a very relevant scenario and it's been proven that young ladies in the childbearing age often are under-prescribed lipid-lowering therapy and majority of them do not attain the goals that are required. So the first thing when we see a lady, first we should see whether she is interested in a pregnancy and accordingly counsel her that she should consult us 2 months before she plans. And within that time, we should aggressively optimize all the lipid-lowering therapies as we would do for any other patient. Contrary to what most of us would think, statins have the highest support for use in pregnancy, whereas all the other drugs like the fibrates and the bempedoic acids and the antibodies, they do not have any evidence in pregnancy or lactation. Another way to think is they recommend to divide pregnancy into 4 trimesters, where the 3 months after delivery are also where the patient needs to be monitored. So I think we should go through individual
so basically,
drugs,
the safety, what Dr. Girish was mentioning, the safety of the drug, the one which is safest is the bile sequestrants. And that is available to us today, 3.75 gram is the dose, what is recommended, and that is safe all throughout the pregnancy. So all along, for all the lipid abnormalities in the pregnancy, we must use this drug regularly. Statin, whether low dose or high dose, we'll discuss in the next few minutes. And then there are certain drugs like omega-3 fatty acids also reasonably safe. Other drugs have a little problem. PCSK inhibitor, inclisiran, etc. is a limitation, but we will discuss a little later. Now, statin in pregnancy, what Girish was mentioning, always a fear that it is going to give trouble, at least in the first trimester. Beyond first trimester, if there is an indication, we have to use. There are 3 situations where statin is a must in pregnancy. We should not be worried. 1, when the LDL is more than 190 or so. 2nd, in case of FH. And the 3rd is established cardiovascular disease. As shown here, the patient has undergone some PCI, patient has a post-MI situation or undergone surgery or so. This patient comes in that atherosclerotic cardiovascular disease, and there we have to use statin very, sort of a calculative, and that's a more of a shared decision making. Not only for us, even with the family we have to sit, And possibly here I would recommend a little lower dose, and among the statin, hydrophilic statin you have to use. Now hydrophilic statin as against the hydrophilic, that means what we have now is the rosuvastatin. Pravastatin we are not using, unlike the atorvastatin. Lipophilic drugs in pregnancy supposed to be less, is more problematic. So probably the hydrophilic drug is better because they have more selective hepatic action and they don't, really penetrate the placental circulation and so on. So probably that is one indication. And even the ESC 25 mentions class 2B indication. Now, this one case I want to just show to highlight how the inclisiran possibly can be used, and I foresee probably this is a bright future in future. Now, if you see this particular patient, unknowingly, this girl, a lady was receiving 25 weeks earlier to pregnancy inclisiran, and then nearly 3 months before getting pregnant, and pregnancy was not known, and then it was continued. And they have seen the effect, over complete, like no congenital malformation, normal gestational age and anthropometry, and normal and the full-time gestation. So there are some move where you get the LDL to the level maybe 3-4 months before getting conception, and then the entire pregnancy continuing without any without any giving, inclisiran or other drug is possible. How do you think this, each one of you, this particular thing?
I think this is a thought-provoking idea, although the FDA has not given approval for it. But if we have a fair enough time before, she decides to get pregnant and discussing with the patient that this is a possibility, I think in a very severe case, this idea is thought-provoking.
Regarding this particular slide, sir, this is one case report which has come up recently.
But Nagesh, you have been discussing, LA meeting regularly this, in fact, regularly this inclisiran during pregnancy.
The fascinating thing is that, sir, the siRNAs, the inclisiran doesn't stay long. The effect stays for a couple of months.
And supposed to be, it doesn't come in the blood circulation. It just gets stick to the liver and then it is free. That's why, the effect is not there. So that's why, it looks very, stimulating.
Promising. And the point regarding statins, sir, it is not considered teratogenic, so the absolute contraindication is removed, but people say it is pointless to give statin because in pregnancy itself the LDL and other cholesterols goes up because of the effect of hormones. So whether the patient is going to derive the benefits or no, that's a different thing. So we hold the statins for a duration.
Statin with, bile acid sequestrant, maybe for about few months, and then continuing on, maybe statin. At least combo reduces about 35 to 40%, So that's quite a thing. Anything, Zuma, you want to say anything? Yeah. Anything you want to comment about it? Yeah. So basically, when you talk about, I just want to summarize few important points. Key factor in management is the lifestyle, etc. Bile acid sequestrant is the drug of choice at every stage. Small dose of statin, hydrophilic is fine. Emerging therapeutic, particularly inclisiran I mentioned. Controversy surrounding statin use, you should remove. Remember that statin in 3 indication is a must. But use with bile acid sequestrant at least in the initial 3 months. Use very small dose. Use, hydrophilic statin more than the hydrophilic. And we have a lack of data of all these registry we need. And now just to conclude, I would, anything in the audience, anyone want to make a comment? We have half a minute here. Or anything?
Doctor, would you like to discuss about surrogacy, offering surrogacy?
That's always there, but here, patient want to become pregnant, Surrogacy and all are little different topic, yeah. Anyone want to make a comment, yeah, Akshay?
There's a recent 2026 Norwegian nationwide study of 8 lakh women, comparing women on statins and women who have withdrawn statins. First trimester of pregnancy, the incidence of congenital malformations was not higher. So in this 8 lakhs of women, it has not been found to be harmful.
I know, Akshay, basically, as I mentioned, three indications. Yeah, just Gupta 1 minute. Because, of course, Milind behind me, and Milind also helped me in making this presentation. Because I was totally floored, I thought when Bhavesh said you talk on this, I thought I know a lot on lipid. But this talk completely floored me. Yeah, Gupta, just a few seconds. It's over, actually.
Sir,
Yeah.
one comment.
It's over, sorry, yeah.
Your patient
Because-
was 32-year-old
Yeah.
lady. Nowadays, IVF specialists are doing IVF in patients who are 35, even 40 years of age. At that age also, they have desire to become mother. So there are more and more chances of them having hyperlipidemia because of the age and the hormones which the IVF people give. So
Yeah, I think I
very
agree. Yeah, I
important
think we have to cut
to
short
give
the meeting.
statements.
Thank you very much, Milind, Pelajani sir, and all the team AOC. Thank you very much. Thank you all panelists. Yeah.
Thank you, Dr. Sadanand Chetty, sir, for again a very crisp job as a moderator and all the chairpersons. Now, anybody has any thoughts of sneaking to their rooms, please don't do it, because remember we have the quiz section at the end. That's going to be very exciting. So please remain with us. Now, the next section, for the next session, let me call the chairpersons, Dr. Anil Poddar, Dr. Manish Jain, Dr. Surinder Hansra. This is session 8, non-atherosclerotic SCD. So, of course, we have a talk by Dr. Vaideshwar, and we are trying to get the link with Dr. Narasimha. They are telling me it's there, na? Fine, fine. So, the chairpersons, please.
Hello. We are starting with this session of non-atherosclerotic SCD, and Dr. Pradeep Vaideshwar is going to speak on SCD beyond blockage.
Okay, good evening. Once again, I'll present 7 case scenarios, but these will be not affecting the coronary arteries or their ostia. So in other words, it is beyond blockage. Let me start with the case number 1. 33 years female did not get up in the morning. This is once again a serial cross section through the mid portion of the heart, showing both the right as well as the left ventricles. And what we notice here is that there is biventricular hypertrophy, left ventricle more than the right. And you can also see that the interventricular septum is affected more as compared to the free wall. And when we took the sections from the interventricular septum, we not only saw extraordinary amount of hypertrophy of the cardiomyocytes with an increase in loose interstitial connective tissue between the fibers, we also saw presence of classic disarray of fibers, which looks like the traffic jam which we see in Mumbai. So what we basically have here is hypertrophic cardiomyopathy, which is one of the important genetic causes of non-ischemic myocardial disorder. So this was hypertrophic cardiomyopathy in a young patient who died in her sleep. Let us come to another inherited disorder. 32 years male, sudden onset dizziness at the place of work, rushed to a tertiary care center but declared dead on arrival. This is the opened out portion of the right ventricular outflow tract. There is dilatation of the left ventricle, and what is very noticeable is a pearly white thickening of the endocardium. And you can also note that the brown color of the right ventricle is replaced by glistening yellowish tissue. When we took a cross section, we saw that the entire right ventricle, that means the anterior, posterior walls, as well as the outflow tract of the ventricle, was replaced by this adipose tissue, and this fat was also making inroads into the anterior portion of the interventricular septum. A section from the right ventricle showed the presence of adipose tissue infiltration along with the pale pink staining of collagen, which is highlighted by the Masson trichrome stain, which stains the collagen a bright green. So what we basically have here is a fibrofatty replacement of the right ventricle predominantly, along with some kind of replacement even in the left ventricle. So the answer is arrhythmogenic cardiomyopathy, which is right ventricular predominant with subtle involvement of the left ventricle as well, again a genetic disorder. Third scenario, 32 years male, sudden onset shortness of breath and loss of consciousness, declared dead on arrival. And at this point, I must say that because it's a medico-legal autopsy, we do not always receive the entire heart. So here we receive the anterior bisected portion of the heart, but that was enough for us to make some kind of a diagnosis. So what we have here is the right ventricle, the anterior wall of the left ventricle, and anterior half of the interventricular septum. The myocardium is of normal thickness, but there are small foci of congestion. And when we took sections from this anterior free wall, we were astonished to find large amounts of inflammatory cells which have produced destruction of the myocytes along with interstitial edema. And on higher power, we can see an infiltrate of lymphocytes, macrophages, as well as some plasma cells. And you can note that this almost looks like structure of a lymph node rather than the heart. So this was an example of almost an acute fulminant type of lymphocytic myocarditis and acquired non-ischemic myocardial pathology. 19 years female, late night sudden onset shortness of breath and loss of consciousness. And here the entire heart was sent. So these are the serial cross sections of the ventricles from the base to the apical portion. And what we see is the presence of multiple well demarcated to geographic gray-white areas. And you can see that they are mostly present towards the basal aspect. Once again, section from the anterior wall, and you can see that there is fairly well demarcated area which is pale pink as compared to the darker pink of the normal myocardium. And sections from this area showed a florid granulomatous reaction composed of epithelioid cells, giant cells, and once again what came to our rescue was a similar appearance in again the lungs and the liver. So this was an example of a very clinically silent nodular tuberculous myocarditis. And you can see that despite such amount of involvement of the myocardium, the patient had sudden cardiac death. With that, we leave aside the myocardium and come to the other causes. 36 years male, death in a taxi. This image on the left side shows you the end-on view from the left atrial chamber. And what we see here is like sails of a ship. That means the prolapse of the posterior mitral leaflet, which are beautifully seen on the left atrial aspect. And when we cut open the, we saw that this sort of billowing or prolapse was actually accentuated because of rupture of the chordae tendineae. So it is quite possible that this patient had sudden torrential acute mitral regurgitation. So this was an example of mitral valvular prolapse with a mechanical complication rather than an arrhythmogenic complication. We'll go to a 14-year-old female who died while playing. And what we see here is the external aspect of the heart with enlargement of the right-sided chamber, that is both the right atrial appendage as well as the ventricle. But what is striking to see that this enlarged right ventricle looks like a crumpled balloon. And this was as a result of a marked downward displacement of the tricuspid valve, so that you had a very large so-called atrialized portion of the right ventricle, and the tricuspid orifice is present eccentrically facing the right ventricular outflow tract. So this was an example of Epstein's anomaly, which is a congenital valvular deformity producing sudden cardiac death. And the last case, 29 years male, chest pain and breathing difficulty on waking up in the morning. This is the anterior surface of the heart, and you fail to recognize any important landmarks on the anterior surface because there was marked thickening of this pericardium, and the thickening had also produced adherence of the heart to the anterior chest wall, and that is why we have a raw surface on the anterior aspect. And when we took cross sections, we saw that there was obliteration of the pericardial cavity, a very thick icing which was gray-white, extremely firm, and this gray-white tissue was also extending onto the myocardium of the anterior and lateral walls, and also if you see the image on the lower aspect involving the interventricular septum. You can also note some degree of congestion of whatever myocardium which can be seen. To our great surprise, this was nothing but a metastatic carcinoma which had produced replacement of the myocardium with extensive fibrosis, and you can also see the abnormal atypical epithelial cells insinuating between individual myocytes. So this was myoperindocarcinoma in a 29-year-old male patient. And the icing of the cake, if I can use the term little inappropriately, we saw some congestion of the myocardium, and this patient also had acute myocardial infarct. So this metastasis actually camouflaged atherosclerotic coronary artery disease, which would have been the cause for the sudden death as well as the symptoms preceding the sudden death. Thank you very much.
Hello.
Someone is joining us online. Okay. So discussion after.
Okay. Dr. Narsim is going to talk now on hypertrophic cardiomyopathy, arrhythmogenic RV cardiomyopathy, and inflammatory causes.
Thank you very much, chairpersons. Good evening, and I sincerely apologize that I couldn't make it in person. I think all of us are aware that we saw a very nice case shown by Dr. Pradeep. Several sarcomeric variant causes hypercontractile problems leading on to extensive fibrosis and leads on to hypertrophy and fibrosis in the ventricle. And this, we have understood that certain mutations are more arrhythmogenic and the risk of sudden death is high. The common mutations which presents fulminant mutations which are common in Indian population are myosin binding protein C, beta myosin heavy chain 7 and troponin mutation which is very typical. They have lot more myocardial disarray. Even though hypertrophy is not very significant, they have a higher incidence of sudden cardiac death. So what are the questions in terms of risk stratification? Number one, did the patient have syncope or pre-syncope in the past? It becomes more relevant if the patient had an exertional syncope. Second is, paradoxically, atrial arrhythmias lead to ventricular tachycardias and fibrillation in hypertrophic cardiomyopathy. 15 to 20% of HCM patients, before they die suddenly, they have atrial fibrillation for a couple of hours, untreated rapid ventricular response leading on to EF. And we are going to talk a little bit about pacing and genetic testing. So in terms of risk stratification, there are two large groups which have looked at this. This is from American Heart Association. American group looks at patients with family history of sudden cardiac death as an important. This is one genetic condition where family history is highly suggestive and it's considered a risk factor, not in other LQT and other things. Unexplained syncope, multiple NSVTs that you see on Holter, large severe left ventricular hypertrophy. Increasingly, we have found a very significant risk associated with left ventricular apical aneurysm and LGE of more than 10%, and patients when they start developing. Remember, in HCM, the EF comes to less than 55 and 50, it's LV dysfunction. This is considered a risk factor. Formerly, we used to do stress testing several years ago to look at hypotensive response. This is not considered to be a risk factor anymore. Now, the European Society has a neat HCM risk, sudden cardiac death risk calculator, and that incorporates left atrial size, which tells us about chronic LV remodeling and higher filling pressures. And this age, everything is a score which calculates the score as less than, low risk as less than 4% per year of sudden cardiac risk. Generally, we just rely on beta blocker alone here. Whenever the 4% threshold is increased, we consider advising an IC. But it's not, as you know, in clinical practice, it's not clearly in black and white. Especially these scores don't perform very well in pediatric population. There's a very nice work recently from Oregon, which looked at a group of patients and said this scores, while it predicts the problem in adult population, the risk of sudden cardiac death continues to be higher the earlier that at age the diagnosis is made. So when you have a person, even when the ESC score is 3%, but if he has even a tendency for apical aneurysm, that will confer a high sudden cardiac death, and we should give him an ICD in this situation. This is the work that Robin had presented a couple of years ago. What you see is the bar diagram of event rates among patients who have apical aneurysm, and this is HCM without apical aneurysm. So the adverse events are much higher. More importantly, there is almost about 4-fold higher risk of sudden cardiac death in this population compared to those without aneurysm. So apical aneurysm, if you don't see it very well on an echo, you get an MRI on these patients. Now, secondly, we have understood that HCM is an energy deficient heart, have a reduced production of ATP. And so there is an increasing interest, just like in diabetic cardiomyopathy, to use SGLT2 inhibitors in these patients. So there are several reasons why this happens. They tend to have several mechanisms where we felt all of them could be addressed by giving SGLT2 inhibitors for these patients. This we published a couple of years ago in American Journal of Cardiology using SGLT2 inhibitors showing an improvement in functional class as well as exercise capacity and a reduction in NT-proBNP. So what we have realized is we run a clinic every Thursday for this. We try to have a surgeon available, a cardiologist and the person who does MRI sit together. Over the after the COVID, we have seen approximately about 200 odd patients, septal myectomy in X number of patients, alcohol. These are all patients who didn't respond to Norpace or disopyramide. Of late, we have been using mavacamten in affording persons, but these are patients who remain refractory. You need to think of septal reduction. And non-obstructive cardiomyopathy, if they have significant amount of myocardial scarring, we need to think of advanced therapies for these patients. So, moving on to the next entity, cardiac sarcoid. This is very clear that when the patients with cardiac sarcoid have LV dysfunction, less than 35%, all of us agree they need an ICD to be put in. But what if the EF is preserved? This is where program stimulation becomes important. You have a person with 45% EF, comes with non-sustained BT. This is a work which came from Devendra Mehta's group in New York, which said that if a person has a provocable BT, their survival is poor compared to persons where the BT is not inducible. So if you have a person, you are unsure whether to give a device or not, there is a role for, in this particular condition, there is a role for EP study. So in patients with sarcoid, presence of LGE seems to be an important risk factor for future sudden cardiac death. Similarly, presence of LGE, and if they have more than one or two areas, instead of having only one segment of the heart getting involved, if you have multiple segments getting involved with the LGE, there is a higher risk of sudden cardiac death. Similarly, presence of PET versus no uptake on PET seems to stratify abnormal perfusion associated with indicating there is a scar has a worse survival in these patients. So this is a work that we did along with the European group. When you implant an ICD for these patients, we looked at this question, how often does the ICD appropriately give a shock? We realized that approximately over 3 years, 30% of them, more than 30% of them receive appropriate therapies, and the risk factors are syncope, lower ejection fraction, and presence of AV block. So whenever you implant a pacemaker in a middle-aged person, the reason why we insist on ruling out sarcoid is, if it is sarcoid, pacemaker doesn't suffice. You may have to think of giving an ICD. So this is the current guidelines. Sustained VT or a low EF, ICD is recommended. Any person with a conduction system disease in the presence of sarcoid, ICD is useful. In patients in gray areas, we may have to look for additional signs like CMR and PET, and if they have an abnormality, consider program stimulation, and if it's positive, giving an ICD is useful. As you all know, sarcoid will relapse after some time. It will be quiescent for some time. So if you have an uncertain issue in a younger person, these things need to be individualized. If all the criteria are negative and you're not sure what to do, no LGE, then you have to think of doing a program stimulation to think of giving an ICD to these patients. The problem with ICD implantation, both in sarcoid as well as in HCM. In HCM, we upfront recommend all of you to implant a dual chamber ICD for several reasons. Among patients with sarcoid, if you have decided to give an ICD, make sure that they are not on high dose of steroids, because very often the wound erodes and the wound complications, pocket infections are more common. So inappropriate therapy. Sometimes irregular cycle length in sarcoid makes the device miss a therapy and it can be mistaken as atrial fibrillation. These nuances are important when you program the device for appropriate therapy in SARC. In the interest of time, I think I've left out the other cardiomyopathies like ARVC. I think I'll stop here, and if there are any questions, we'll be happy to answer. Thank you.
Anybody wants to? Yeah.
In the recently released cardiology update, I think you have written a chapter on how to predict sudden cardiac death in hypertrophic cardiomyopathy. I am right?
That's right, sir.
And in that you have mentioned the at least ECG changes in the hypertrophic cardiomyopathy which can predict sudden cardiac death. And another paragraph which you have written is why there is a difference in the European society and the American society in predicting the death in hypertrophic cardiomyopathy. What ECG changes we can do repeatedly, but echo may be difficult to do again and again. But why there is difference in the American and European societies?
I really feel overwhelmed that you have just read it so in a granular fashion that every single detail. So fractionation of the QRS can easily be picked up, and what we have realized, it's an evolving substrate. In American setup, they are a little more liberal in giving an ICD for these patients, more because of the medico-legal issues that are involved. Whereas when you have the government sponsoring all the devices like NHS or others, you need to rationalize your therapy, and that is why there is a little bit of discordance. But I think over the next recommendation, they may converge together. You're absolutely right. There is a proprietary AI model for looking at the scar through the ECG by looking at high frequency complexes within the QRS. And right now we don't have it as an indication, but in the next couple of years it may emerge if the evidence comes out.
Yeah.
Yeah, my question is to Dr. Pradeep. Little confounded about your case with Epstein's anomaly with sudden death, because about 42 years back when I used to read Perloff, textbook of Perloff, there was a mention that Epstein can be as asymptomatic. The bullfighter who died at the age of 78, on autopsy he was found out to have Epstein, but he was fighting bullfight and then he never had any physical effort intolerance or something. But as opposed to that, just last week I had a case of Epstein who had aborted sudden death, and then she had documented broad complex tachycardia, which was actually a pre-excited fast ventricular rate at a rate of 250. And Dr. Amay Udayawar, I don't know whether he is there or not, he did septal right posterior septal pathway ablation. So in your case, which died suddenly with Epstein, was there any muscle bundle crossing across the AV groove? Because Epstein, otherwise, why she should die suddenly? Accessory pathway and arrhythmia could be one explanation.
On histopathology, we cannot identify any of the conducting tissue. It has to be electrophysiology in a live patient. Yes. And the oldest patient with Epstein, which we have seen as sudden death, was 55 at autopsy.
One more question to you, sir. Pradeep, sir. One more question to you. How many you find atherosclerotic and how many non-atherosclerotic in young hearts which you receive for autopsy?
Majority.
Especially anomalous origin of coronaries and.
Okay, our main is atherosclerotic coronary artery disease, and maybe once in 2 weeks we get an anomalous origin of the coronary artery.
Okay, so quite frequent. So.
Yes. See, that is because what I feel is that medico-legal tissues are very rich source of cardiological material, but unfortunately, every institute does not follow a particular norm of so it is quite possible that majority of the cases are getting missed.
I have a question. I have seen your slides on autopsies, which is the tissue sample. Have you came across patients who have molecular autopsy and considering the diagnosis of channelopathy?
Yes. See, actually, there are certain institutes like AIMS which are actually doing studies on genetic analysis of the structurally normal hearts with cardiac symptomatology, and they have demonstrated channelopathies. I think there's an institute in Kerala also, not Sri Chitra, some other institute which is doing on channelopathies. And it is very expensive. So we have got lot of material. So almost 1/3 of our cases have got cardiac symptoms, structurally normal, but we do not know whom to give the material to. That's the problem.
Thank you very much, chairpersons and our speakers, Dr. Pradeep and Dr. Narasimhan, for this wonderful session on non-atherosclerotic SCD. Let's move to the next session, which is a sponsored session by Novartis. Let's welcome our chairpersons, Dr. Snehal Kothari, Dr. Vaibhav Dedia, and Dr. Ruchit Shah for this session on understanding the LDL variability. And that is going to be followed by the quiz, which is going to be at 7:30. So please stay tuned for that as well.
So I would like to invite Dr. Anil Dhal to come and start his talk and help us to understand the concept of LDL variability.
Like I said, great to be here, and thank you very much. LDL variability is something that appears to be like glycemic variability, like blood pressure variability, but in every field of preventive cardiology, I normally ask myself this question, because nobody has ever come to me and said, thank you for prescribing preventive medications so that I did not get a heart attack or I did not die. Everybody almost always wants a response to something which happens. Now, if we trace the history of how lipidology has progressed, the Surgeon General of the Russian army was Nikolai Anichkov, almost 120 years ago. He fed a lot of rabbits, egg yellow, raised their cholesterol to supranormal levels, harvested them, and found their arteries choked with aromatase substances, started the lipid hypothesis. Paul Dudley White actually started identifying risk factors, but it was this guy, because till that time, almost all the therapies which had been tried were looking at the absorption of fats because of what Nikolai Anichkov started with. But there was something beyond that, and that is where, number one, Akiro Endo decided to tell us what was the rate-limiting step of cholesterol biosynthesis, cyclopentanoperhydrophenanthine ring, and it was HMG coenzyme A reductase, and he found that out, and it was to these two gentlemen, Goldstein and Brown, who in 1984 were awarded the Nobel Prize for elucidating the structure of the LDL receptor. And if we really look at why this LDL receptor is important, it is not because the life cycle of an atherosclerotic plaque, which starts much early, but it is to make sure that you are aware of this particular very simple cartoon, which tells us that less than 25% of your cholesterol actually comes from your diet. Medicine is a highly patronizing subject. We tell our patients that you've got heart attack because you ate too much. Or you ate red meats, or you ate chana bhatura or something. But the dietary influences are limited. Secondly, you must all be wondering why we do a glucose tolerance test, or we do a fasting and PP for sugar, but we don't do it for lipids, because the lipid obviously gets absorbed later in the intestine. And this may be a very confusing kind of a cartoon, but you look at it that we can either handle cholesterol biosynthesis, which happens through using statins or bempedoic acid, or we can actually look at how do we handle this LDL receptor. Because this LDL receptor has a life cycle of its own, and it is broken down by an enzyme called PCSK9. And if we inhibit this PCSK9, there will be more LDL receptors. Otherwise, if we give, say, bile acid sequestrants, what will happen is that although the absorbed cholesterol will be less, the receptors will downregulate. And if we give a lot of feeding, then although the absorbed cholesterol may be higher, the receptors will upregulate. So as to get out of this downregulation and upregulation, you have to increase the number of receptors. And that can only be done through pathways involving PCSK9, because this will then increase the number of receptors. You can obviously handle the absorption by looking at the Niemann-Pick type C receptor, which is in the intestinal brush border. You can use ezetimibe. Or you can actually have a look at some of these therapies which are increasing in every day, and we are understanding them better. PCSK9 inhibitors are here. We can inhibit them either through a monoclonal antibody, which is what is evolocumab or aliricomab or any of the other MABs, or we can use a small interfering RNA, which is inclisiran, which acts through the GalNAc pathway, and although its actual circulation is limited, but the effect lasts for 6 months. Incidentally, a similar drug is coming for high blood pressure called zilebesiran, and therefore this pathway is very important to know if, as a cardiologist, we need to understand a little bit of molecular biology. Now, among these, we also had the introduction of ensiletide, which is an oral PCSK9 inhibitor this year, and then came this company called Verve Therapeutics. Verve Therapeutics was led by an Indian origin guy called Sekhar Kathiresan, who actually used the CRISPR technology. In 2020, Charpentier and Doudna got the Nobel Prize for chemistry for telling us what is CRISPR technology. These are actually molecular and genetic scissors which can be used, and by this technology they came up with 2 drugs, in fact now 3 drugs, Verve 101, Verve 201 and Verve 301. And this Verve 101, one injection can change the lifetime LDL by 50 to 70%. The first in man study was authorized by the government of New Zealand. It is in progress. Verve 201 looked at something beyond this pathway, which was to look at another source, which was the angiopoietin source, the angiopoietin also would act through the ApoC3 pathway, and therefore it will also decrease the triglycerides, and they felt that it would have a greater utilization in acute coronary syndromes, and because this was available, and this is being tried, incidentally, Verve Therapeutics was bought this year in the most blockbuster deal last year by Eli Lilly. So we might have more introduction of these molecules in the years to come. And by looking at the ApoC3, we can have drugs like olezarsen, which can act on triglycerides. So sorry to confuse you with a lot of biology. And in this, we also had lipoprotein little a, which is important. So PCSK9 targeting therapies can either be, like I said, small interfering RNA, and there are 3 things which have a lot of ApoB. They are LDL, lipoprotein little a, as well as number 3 being triglyceride-rich lipoproteins. Point to be noted, triglyceride-rich lipoproteins are not synonymous with triglycerides. So there are many pathways which can actually be used, but the angiopoietin pathway is important. Targeting lipoprotein little a, we might have the introduction of pelacarsen in a year or 2. So all these are various pathways which can be addressed. Absorption, synthesis, rate limiting step, LDL receptors, either by PCSK9 monoclonal antibodies, small interfering RNA, ApoC3, lipoprotein little a, angiopoietin, and the CETP inhibitors with obicetrapib have made a comeback this year with limited data. The original CETP inhibitors came with a lot of promise, but by off-target effects fell out of the window. So if we look at a patient who's got familial hypercholesterolemia, we can either target LDL receptors or we can target ApoB or ApoC3 or lipoprotein little a. And that can be done by PCSK9, angiopoietin. And if we are to see this, this is the landscape available to us. And here we have a patient who has an LDL which is reasonably controlled, but his disease continues to progress. And this gentleman has a high lipoprotein little a. Statins were tried, and then evolocumab was given. But evolocumab, as you know, has an effect, and it is to be given an injection every 2 weeks. So there was a wide variability and fluctuation in the LDL levels. Now we want to know whether this fluctuation was important, and this is referred to as LDL variability. It can be measured by some common matrices, and it matters even beyond the mean LDL, because even when the average LDL are on target, it is the yo-yo effect of high and low, and we'll find out why this is important, because it can lead to more endothelial stress, it will affect the plaque biology, the inflammation and oxidative stress, and a stable, consistently low LDL is biologically safer than an oscillating LDL. We have enough data that sustained LDL reduction is good. Percentage LDL reduction by various therapies is known. The lower the better. We have Professor Eugene Grunwald, who actually said LDL life years, gram years, and said lower the LDL for the longer time is better. But even despite having mean LDLs which are low, you will find that a lot of patients have differing LDLs when they come to see you. Even if they come to see you once in 3 months, once in 6 months. Number one reason is non-adherence. Number two reason, and this leads to increased risk of MACE, and there are inconsistent diet patterns, variable statin dosing, and variable fasting status. So if two patients who have an LDL of 65 are not equivalent, if one fluctuates between 40 and 100 and other between 55 and 100. So you should check it periodically. Diet could have some relevance, but not great. Fasting is essential only if triglycerides are high. But what are the strategies to overcome this? You can either improve adherence or use long-acting potent agents which have remarkably low LDL variability. Simplify the regimes and have a lifestyle consistency. And in this, I have pointed out the Verve Therapeutics, but what is available to us today is actually just inclisiran. Because this is, like I said, a small interfering RNA, twice yearly dose, and it is a convenient dosing. It offers a high treatment adherence. And if you look at this paper by Kaushik Ray, he actually shows us that if you give ezetimibe treatment, then consistently the LDL receptors are going to be high. So the same patient was placed on inclisiran, and not only were the LDL levels sustained low, but also they were consistently low. There was no yo-yo effect. Angiopoietin 3 therapies can be used, and this actually is thought to be like a brake, and it is a stabilizer of lipid exposure, but we don't have the drugs right now, so I'm not going to really discuss it because it's a master regulator of that flux. Likewise, CRISPR is a paradigm shift, not just another drug, and we will probably have this. So as of now, what we need is some drug like inclisiran to decrease this LDL variability. In the future, we can have angiopoietin therapies, and which will mark stabilization of LDL generation, especially for LDL swings, and this can be used. So I'm just going to come to the last slide. So and especially if the LPA is high, we need to have even more stable LDL levels. Diet is only going to help us to some extent, not to a great extent. And this is something which is very clear that as of now, if we have to do something, a small interfering RNA therapy will be the current mainstay. Thank you.
Excellent talk, sir. Your slide of those two molecular mechanisms was amazing, and the way you explained it was fantastic.
Thank you very much. I am sorry for the brevity of time. It doesn't allow you to explain a lot of molecular mechanisms, but I hope you will carry the message.
Thank you very much for the wonderful session on LDL variability, and thank you, Dr. Anil Dhal, for coming all the way from Delhi for this. Here. Okay, well, everyone, we are now going to the Medtronic-sponsored cardiac quiz. We are going to call this the AOC cardiac quiz, and I want to start by calling our quiz experts, Dr. Ajit Desai sir, Dr. Milind Phadke sir, and Dr. Saurabh Deshpande. These are our experts who have taken a lot of efforts to create all these questions. I am just going to conduct the quiz for y'all. Sir, can you all come on stage, sir, please? Yeah. Well, and I want to thank the 8 different hospitals who have sent over their residents to have this quiz. We have residents from various hospitals. I'm going to introduce you all to the residents and have them come and take their seats as we have 4 teams. And since we have very little time, I will quickly say their names, and please come and take your seats. In team A, we have a team with 2 residents from Jaslok and 1 from Saifi, Dr. Yash, Dr. Anamika, and Dr. Kunal. Can they please come to team A on the far left? The second team is from Bombay Hospital, HN, and the Railways, Dr. Somesh, Dr. Advait, Dr. Akkarapaka Rinita Ajay. The third team is from KEM, that is Dr. Dipesh, Dr. Praveen, and Dr. Pooja. And the fourth is from Sayan, that's Dr. Parth, Dr. Priyanka, and Dr. Shivaji. Can we have you all take your places, please? Perfect. Okay, and with that, I want to wish you all the best of luck for the quiz. We are going to have this quiz in 3 very short rounds because we have only 30 minutes to cover the quiz questions. Now remember, the idea of this quiz is to teach everybody here, y'all and the audience, about certain aspects of SCD and CAD in the young. So let's start. I wish you all the best. Can we have the slides on, please? So we are going to have 3 sections. One is on arrhythmias, one is on coronary artery disease, and one is a mixed bag of, let's say, a zoo of cases. Okay. So we're going to start with Dr. Saurabh Deshpande. Saurabh, please take the mic. So the rules of the quiz are that there are multiple choices for some, and there are descriptive answers required for some. 20 points for the correct answer and 10 points for the passed on answer. The multiple choice will only get passed once. And let's make sure that our audience who knows many of these answers in excitement, please don't prompt so that they can actually get a chance to tickle their own brains and give the answers. So can we have absolute silence from the audience? Please, nobody for the next 30 minutes, please keep your phones in your pockets. Okay, no Googling answers, please. Most of the questions are not Googleable. So, okay. Let's start with the arrhythmia section. Saurabh, this is for team A. Name the procedure: cardiac resynchronization therapy, implantable cardioverter defibrillator, left bundle and cardiac resynchronization therapy, or none of these. Can we have you all each have a mic, right? Okay. So you all want to give us the answer? There are no negative marks, so you all can safely guess.
Option C, left bundle plus CRT.
Okay.
Yeah, so that is correct. So as you can see, if you can freeze the last frame, you can see 4 leads there. So the 3 of the leads are routine CRT leads. You have atrial lead, RV defibrillator lead, and another lead in RV, which is put in the left bundle branch, maybe posterior fascicular area, and you have a coronary sinus lead. So this is called LOT CRT or left bundle optimized CRT. So how the physiological pacing has evolved. Earlier, the physiological pacing was based on the epicardial pacing in the optimal area. Then we started putting the lead endocardially in coronary sinus. Then we started using other algorithms, and now we have come to conduction system pacing and the combination of conduction system pacing with coronary sinus. So why LOT CRT concept came up was because whenever you see a left bundle branch block, we don't know where the block is exactly. It can be proximal, it can be distal, it can be a combination of two. So sometimes you do one thing and your QRS does not get narrowed. That is how the concept of LOT CRT, which we saw earlier, came up. And we have some guidelines. Can you go to the next slide? So there are some, this is not it's just an expert consensus of how to choose a device. So there are scenarios where you can directly go for HOT or LOT CRT where you have IVCD because you don't have any guidelines if there is no left bundle branch block. But even in left bundle branch block, if the correction is not very good. So this particular slide was at the time of his bundle pacing. Now we go for left bundle pacing and then HOT LOT CRT.
Okay, give a very big hand to Team A for securing 20 points. Okay, Team B. This is a 38-year-old male with syncope during lunch. What is the specific pharmacological agent indicated and the procedure to be planned? Is it quinidine and an ICD, quinidine and a PPI, flecainide and an ICD, or flecainide and a PPI?
A, quinidine and ICD.
So what is the diagnosis?
The Brugada type A.
Okay. So, and considering patient had syncope.
Yes.
So if you go to the next slide, we have.
Okay, everyone give them a big hand. I mean, we can get a bit excited. Just don't shout the answers.
So this was the evaluation done. On Holter we found PVCs, and on TMT patient had polymorphic VT kind of a picture. So we were certain that patient has whatever syncope must be arrhythmogenic. So the most specific thing is ICD obviously. Why quinidine? It is not for any quiz. I am just asking why quinidine. So even if these patients are having some PVCs or VTs, ICD will not stop them, right? So you have to stop those. So for that, you have to have add-on quinidine. It's not like ICD done. Patient will keep getting shocks. So we don't want the shocks, appropriate or inappropriate. So quinidine is better to be on board with quinidine and ICD both. And then EPS RFA if nothing works.
Fantastic. Okay, let's move to the next question. To Team C, a 16-year-old male, athlete, routine checkup, ECG diagnosis, and type of pacemaker indicated. Single chamber, dual chamber, leadless, and none of the above.
Sir, the diagnosis is likely 6 sinus syndrome, sir. And so the pacemaker indicator would be a dual chamber pacemaker.
Saurabh?
Okay, so what is the ECG
should we, if they are not correct, then we'll pass it on.
Okay.
Okay, that's not the correct answer. So it's not a dual chamber. Teams D?
I would like to go with answer D because the escape is narrow, complex, so none of the...
So what is the ECG diagnosis?
It's a junctional escape.
Sorry?
It's a junctional escape.
Can you go to the rhythm strip?
See the rhythm strip. That's what Saurabh is saying.
So the
You can
PR
just
is
describe
extremely
what you
short.
mean. Sorry?
The PR is extremely short.
Is the first PR?
Okay, so we can safely give marks to nobody. And let's go to the answer.
So athlete, it is young guy, so most probably it is not 6 sinus, it is hypervagotonia which has caused the sinus node suppression. What is seen in the rhythm strip is P and QRS are not aligning with each other, right? So that is called as isorhythmic AV dissociation. The P is marching. We cannot say like a complete heart block. Why? Because the P rate and QRS rate are same. So this is isorhythmic AV dissociation. Sinus node suppression, not 6 sinus syndrome. So it is hypervagotonia, and generally we don't do anything for these people. We just watch full expectancy. And there is a procedure which is come into picture nowadays where so the cause of hypervagotonia is the vagal nerve and the vagal plexus around the heart. So you can just ablate those parts. That is called a GPA. You can go to the last slide if there is anything. Yeah. So that is called GPA. We find out those areas and ablate those. So, but it is not very commonly done.
Okay, everyone give us a hand to Saurabh Deshpande, please. Okay.
Okay, I had one slide there, but I thought it is very high for them, so I did not put that slide.
Okay, well, let's move to the next question. This is a 37-year-old male with palpitations on exercise. What is the diagnosis? SVT with aberrancy, a papillary muscle VT, a scar VT, or atrial fibrillation? Team D.
Papillary muscle VT, so.
I can't.
Papillary muscle VT.
Okay, very good.
Okay, correct. Okay.
So
Why do you say so?
it's a very good answer. You want to explain?
Can you explain? Your points won't be cut, don't worry.
So a capture beat is also being seen, so that automatically rules out SVT with aberrancy.
Why not scar?
AFib also ruled out.
Why not scar VT?
See the history.
27-year-old. So actually, so first thing which
Okay,
actually.
I think we just had cardiomyopathy session, right? So you can have age is never a bar.
Anything from the ECG itself?
Anybody? And anybody can answer. You'll all have mics. Okay, Saurabh, go ahead.
So as you can say, it is a VT, correct? So it is capture beat, so there is no doubt about SVT or VT. Now, what is the morphology of this particular VT, so-called? You have RBBB with left axis, so which is more commonly seen with the fascicular type of VT or papillary muscle related VT, whatever, because papillary muscle has some fascicle there. Another thing which is very peculiar for automatic, so these are automatic tachycardias or micro re-entry, whatever you want to say. These come in crops. So it has come in crops. In between there is sinus beat, then few beats are there, and then there is a capture beat, so-called. So it is very common. Repetitive small crops are very common with focal VTs than scar VTs. Scar VT is a micro re-entrant, like they are big circuits, they form VTs.
Okay, the next, can we go ahead?
It is medical or RFA.
Okay, now the next question is a buzzer round. Okay, so everyone put your mics. Be ready. As soon as you know the answer, you have to yell. And Dr. Ajit Desai will be the buzzer master. He will decide who will answer. Okay. So the next question, oh, sorry, before we go there. For this round, there are minus 10 marks if you answer wrong. Okay. And plus 20 if you answer correct. Okay, the next question, which is the buzzer question, is name the arrhythmia being ablated and the newer energy source available for the procedure. No, yell, please.
Yes.
Who yelled first? Sir, team B? Okay, wait, let me read out the question before you answer. Ventricular tachycardia and pulsed field ablation, atrial fibrillation and pulsed field ablation, ventricular tachycardia and laser, or atrial fibrillation and laser. Okay, team B, go for it.
Atrial fibrillation and pulse field ablation.
So minus 10 or plus 10?
I didn't hear the answer, sorry.
Sir, atrial fibrillation and pulse field ablation.
Yeah, correct. So this is
Very good. A big hand to him, please. Okay.
Typical procedure done for atrial fibrillation. It is called pulmonary vein isolation. Okay. Yes, so that is the procedure, and the newer energy which is going to come next year, this year, maybe it is pulse field energy.
Excellent. So let's move to the, give a big hand to the teams. At the end of round 1, team A has 20 points, team B has 40 points, team C has yet to score, and team D has 20 points. So we're still very close. We have 2 more rounds, so all the best. Okay, now this is everyone's, well, bread and butter, but let's see. So, Desai sir? Okay, question 1. This is for team B. We'll start with team B. A 49-year-old perimenopausal lady, no risk factors, chest pain, NSTEMI, started on medical management. The next day, symptoms were better, hemodynamically stable, and this is the angiogram which is in front of you. So the options of management is what you have to tell us. Number 1, this is a normal angiogram, stop all medications. Number 2, continue the exact same medicines. Number 3, do an angioplasty to the RCA with 2 long drug-eluting stents. Or 4, do a minimally invasive CABG?
Sir, we will go with option 2 because most likely she is having a SCAD, spontaneous coronary artery dissection. And if you go for stenting, the chances of prolonging the dissection is high. So our answer will be continued medical management.
Correct.
Very good.
Absolutely, very good.
Okay, so there are, sir?
The various types of SCAD, as you can see, type 1, which is the most classic one. The second is the most common one, wherein you see a long segment of the coronary artery having the third is the tubular stenosis, and the last is complete occlusion. So this is the first type of this thing. Usually, most of the time, the conservative treatment is the treatment of choice for these patients. Unless the patient has ongoing symptoms, has got ECG changes, then you would like to contemplate doing an PTC in these patients. But by and large, conservative.
So here the answer was more in the history, because based on that, the conservative treatment is a better option here. Okay, team C, question 2. A 41-year-old male with no comorbidities. There was a doubt of polycythemia vera because of his hemoglobin, and after an inferior wall STEMI, patient is hemodynamically stable, loaded with aspirin, ticagrelor and heparin, started on NTG in the emergency, but the pain is going on, persistent STT changes, and he was taken for an angiogram. And this is what the angiogram shows. Now, your options are, see the question carefully. What are the options when doing angioplasty? A direct stenting without balloon dilatation, use penumbra, Catarex and SOS stenting, give intracoronary thrombolysis and then restudy, meaning do a re-angiogram, or use a covered stent to plaster the thrombus to the ectatic segment. Ongoing chest pain, ECG changes.
Chest pain, patient is symptomatic, and this is the angiogram.
Okay, team C.
So we'll go for direct stenting without balloon dilatation, sir.
Direct stenting without balloon dilatation. Okay, so can we pass it on to team D? That is unfortunately not the correct answer.
So, intracoronary thrombolysis and restudy.
Okay, so also not the correct answer, sir. Should you want to?
Yeah, I'm sure Anil will not agree to the answers. Yeah.
Okay, so, sir?
Medical management or intervention is typically very challenging in this patient because he's got a huge thrombus burden. It's an ectatic artery basically, in which cases going in with stenting and intervention is a challenge in this particular patient. So medical management with heparin and then restudying them, and you see how it happens that after restudying, or medical management includes whether you can give the antiplatelet, the GB2B3A, or sometimes you give intracoronary thrombolysis for these patients, as long as the patient is clinically stable. And then you restudy them after 48 hours and you see the angio is completely resolved. Yeah.
ELCA would work well.
Yes. Yes, because there are two answers to it. Absolutely. Absolutely.
Right.
So I think he's right. We can give a benefit. No negative answer.
No, there are no negative marks, but
there are no negative points here.
But sir, if you all agree, we'll give them 10 points rather than
Yes.
20, because intracoronary was a very close answer. Intracoronary thrombolysis.
10 and each. Yeah. Okay.
All right. So let's go to the next question to team D. The question 3 is, please look at the 3 OCT pictures and tell us which is unlikely to be an acute coronary syndrome picture.
4 of them are there.
That's A, B, C, D. Which is less likely to have a picture of an acute coronary syndrome?
It's a D.
Very good. So you want to give us the
D.
reason for
You
that?
said D?
Very good. Well done.
Okay. Yeah, tell us what is it? The T?
It's unruptured plaque, sir.
Sorry?
It's Staple plaque which
What?
Just describe the image D, what you're saying.
Just tell
and
us
give
from
diagnosis.
A, what is A, what is B, okay, what is C and what is D.
C is mostly
You're given the
recanaliced.
correct answer.
What is A?
What is A?
is ruptured plaque.
Sorry?
No, what is that within the lumen?
Within the lumen, no, it is.
Thrombus.
Yeah, what side of thrombus is this? The red thrombus or a
White.
white thrombus? How do you differentiate between these two?
So there is no acoustic shadow.
That's
behind.
right. In the red thrombus, you will not see the posterior, whereas in the white thrombus, you will be able to see beyond the thrombus also. So that is how you differentiate between these two. Yeah. And the third one is the lotus root appearance, which is a recanalized thrombus, as you can see that. Yeah, very good.
What is D?
And what is D?
It's just a plaque.
No, it's a
calcified plaque.
What is D? You can see most of these
calcium.
on the
Calcium.
top. This is a calcium. Yeah.
No,
a
for that
nodule.
answer, 5 points should ideally be taken away from you. It is so obvious a calcium, but okay, it's okay.
Good,
I am
good.
a home this thing, so I can.
Calcium, okay. No full points for them.
Okay, well done. Okay, let's come to Team A's question. This is a picture of an IVIS image, post-angioplasty IVIS, which is showing this picture. Question, what would you do? Number one, fantastic result, well-opposed stent. Number two, it's a stent edge dissection, deploy another stent at the distal part. Number three, it's an under-expanded stent, take an open NC balloon. Number four, it's tissue protrusion, do nothing. Team A.
Option 3, it's an under expanded stent.
Very good, give them a
Yeah,
big hand.
Very good. Very
So,
good. You can see the stent is not fully expanded. So you would like to optimize the stent expansion in this by maybe an NC balloon or an OPN NC balloon, whichever. You
So
can
just-
see all of these types of the stent, which are a well-opposed stent. You can see a mal-opposed stent where there is a gap between the stent and the adventitia, the intima. The under-expanded stent, as you saw in this particular dissection, which you can see, intramural hematoma, and last is the thrombus within the head. Yeah.
okay, very good. Let's go to the buzzer round again. So let's come to the next question. Everyone, mics ready? Okay, and are you ready for the question? It's a long question. So this is a 44-year-old obese man, no diabetes, hypertension, not a smoker. He has chest pain since 3 weeks, taking antacids. He came to the emergency, and in the emergency room, he had a VT, which was reverted with cardioversion. His ECG shows a QS pattern in V1 to V4. Echo shows a 25% EF with an akinetic LED territory. And his angiography is in front of you, which shows a 100% occluded LED. The question is not, should we revascularize? This is the MRI picture of this person.
This particular patient, yeah.
After his angio, he underwent an MRI. I will run this twice for you, and then I will show you some stills as well. So this is the MRI picture. The question is not ready yet, but please keep your mics ready, okay? Okay, and this is some stills of the MRI for your benefit. And this is the last picture of the MRI, which is the laid gadolinium picture. Now, these are the questions, the options. You do angioplasty to LAD, medical management for a few days, then angioplasty. It's non-viable, only do GDMT, non-viable, GDMT, and implant an AICD.
Sir,
Team D or C or?
D.
Okay, go team D.
Sir, non-viable myocardium. The answer C, we would like to go with answer C, sir. Non-viable myocardium, no revasculation, only GDMT. And
Why
then
do you
follow
say
up.
it is a non-viable myocardium? What made you think that it's a non-viable?
Any MRI findings?
Why
so the
MRI?
MRI shows scarring. And,
Sorry?
The MRI shows scarring, so there's LG, and there's the
You
segment
see
is akinetic.
what is being shown by the late gadolinium picture?
What does it represent?
What does it represent? The gadolinium is taken up by what?
Sir, ischemia, so
Yeah, or
or the
non-viable myocardium. It has been taken up by the non-viable, so you know that it is, yeah.
So can I just one minute go back to the history? You missed the history of the ventricular tachycardia.
Tachycardia. So you...
So...
Sir, but we would like to wait for...
wait for how many? Post-MI?
Post-MI 40 days, so, or else 90...
Yeah, anywhere up to 3 weeks.
But that's
or so you would
after,
like
that's
to wait.
after
But here he has been having
revascularization.
Symptoms for more than 3 weeks.
So that's after revascularization. So a survivor of a cardiac arrest, Saurabh, do you think you should put an AICD for this patient?
GDMT plus implanter ICD? Yeah.
So the answer is D. That is, you have to put an AICD, 3 week symptoms, card myocardium.
With the, yes.
Okay, so let's go to the third part. Now the third part is Dr. Milind Phadke's. So, you know, it's a mixed bag and here there are no options. Okay, so we'll start with team C. But so that has, let's continue, yeah.
What
Okay.
are the scores now?
So, yeah, I'll tell you the scores. So team A is on 40, team B is on 60, team C is on 10, and team D is also on 40. So a big hand to them. Team B is still in the lead, but just by a very narrow margin. So we still have a few rounds. So all set? Yes. All right, team C, let's start with you all. Question 1. 42-year-old lady with sudden onset chest pain, dyspnea, hypotension, BP is 70 systolic. Figure 1 represents the ECG and the presenting ECG, and figure 2 is 2 hours after presentation. So I'm going next. The question is still not ready. We'll show you all something more. Okay, this is the echo. I'm going to let it run because it's very, very important. Please pick up the findings here. What is the diagnosis and what are the treatment options? See the whole angio film running. The clue is the entire film. See the end as well.
Put everything together, whatever you have seen from till now. Echo and the angio, the ECG, both the ECGs.
And see the end of the angio film.
And
so I'm
no
giving them a clue,
clues.
sir.
You should,
Yeah.
yeah, no further clues.
Sir, the echocardiogram, it showed that the presence of color flow across the interventricular septum. That was a VSR, sir. And this coronary angiogram is showing dilated coronary arteries and possibly an aneurysm in the LV.
Okay,
No,
wait, sir. We'll pass it on.
Yeah. This passes.
Yeah.
So the angiogram shows really ectatic RCA. So go, and after that, if we in the at the end of we see, so there's it's continuation into pulmonary. So it goes into favor of Al-Kappa syndrome.
Absolutely.
Very good. Give him a big hand.
Beautiful.
And what are the treatment options?
So surgery will be reimplantation of the coronary would.
Yeah, I mean there are many options, but I would like you to go back. I mean just play that angio. This is
Angio or the echo, sir?
First the echo. See, this echo is very, very remarkable because like you, we also initially thought that there was a defect across the ventricular septum. And when we went back and when we saw the Al-Kappa angio, we realized that these were actually septal collaterals from the RCA to the LAD. So this is very interesting. This is very difficult to pick up on echo. And now you can go and you must always see, before you even pick up the origin of the left artery from the pulmonary artery, there are certain indirect echo clues, which are LV dysfunction, regional wall motion abnormalities, hyperintense papillary muscles, and hugely dilated RCA. This RCA was the giveaway. So even if you had not spotted the pulmonary artery at the end, that ischemic presentation and RCA should have given you the diagnosis. But you can see the pulmonary artery filling at the end through the LAD.
Big hand to them and some really fantastic images. Okay, this is for team D. 35-year-old male presented with multiple episodes of syncope. Quite a dramatic echo. Look at it carefully. The histopath is here. What is the diagnosis and management? Do you want to see the echo again?
Yes.
Basically, it is right-sided.
Right
Concentrate on the right side. Yeah.
And the histology, that is also important.
Should I show you the histology again? Yeah, go ahead.
Myxoma versus...
No, you have to give
No,
one
no,
answer.
one answer.
One answer. You have to place your money on one answer. Otherwise, we'll have to pass it quick.
See, we have only 2 minutes left. Huh? So,
Does the histology tell you what it is
Histology
likely
helps
to be?
you.
It's a myxoma.
Okay. Fine.
very good. Again, give them a big hand.
Yeah. So this was a case, again, a very rare case of multiple right-sided masses we had. And we were also in doubt because this was not a typical site for a myxoma, especially not the right ventricle and not multiple masses. So it was a post-surgical diagnosis, post-histopathology. And you can see the typical HP picture of a myxoma. So you have a hypocellular stroma. You see there are very few cells, a few spindle-shaped cells, and this typical blue highline color in the background. So that is very characteristic of a myxoma, but a very, very unusual site. We
You
have
can show
published
the
this
echo
case
again,
actually.
which shows a stump going to
Yeah,
the
you can see
septum
that.
also, if you can see.
Yeah.
Can you see that being attached to the septum?
There are multiple on this. We have published it now.
Okay. All right. Should we go to team A? Okay. Team A, this is your question. A 50-year-old woman presented to the emergency with sudden onset chest pain associated with sweating. She was hypotensive with blood pressure of 80, and this is her ECG. Okay? The angio was unremarkable, normal coronaries. This is the LV angio. Now you have to answer both these questions right to get your points. What is the diagnosis? And what are these two images and how are they related? The first part is not tough, we know that. And they are both related to cardiology.
Yes, team A.
Okay, at least give us the first answer.
First answer?
Takatsubo,
Yeah.
cardiomyopathy.
Very good. So
Takatsubo,
can you
yes.
explain what you see on the angio, the LV angio?
There's a apical ballooning that can be seen.
So I don't think we should give them marks just
He
for
said
this.
something.
No,
Ah,
he
bol, bol.
just said something.
Okay, what about that?
No, what is the second
What is the second picture?
Yes, Takatsubo means octopus. It means a Japanese octopus instrument, for fishing vessel. What is-
Perfectly right. So, but what is the second? What is that? Say that loudly.
Clamp for catching the octopus.
The second thing is a clamp to catch the octopus.
Clamp for the octopus.
That's not related to
the
cardio.
angio is too
Come
easy.
on,
You have to
you're
give
half
both
right.
answers.
Come on. Sir, please don't answer, sir.
No,
Come
no,
on,
no.
yaar.
Yeah.
Okay,
you
come
can
on.
Pass it on to others.
No, I
Nihal,
think
does
half the
anybody
answer
know-
is- no, the answer is given by the audience, so we
Yeah.
cannot pass.
So, well, Takotsubo is correct, sir. By
No, I would say, everybody knows about this, but I think they should get half the points at least, even if they have not yet.
All right. So, sir, you want to explain? Arun Mehra, sir, please
Arun
explain
Mehra,
the octopus clamp to them.
Octopus clamp.
Just give sir your mic, no, please. Mic. No, yes, sir. Sir.
Yeah, this is one of the clamps that we use for beating heart surgery. I wish I had a pointer, then I could say how it went.
You tell us,
Yeah.
Arun, which is the part which is attached to the
So this part is
heart? Attached to the heart?
Just 1 minute.
No, You can show it.
Sir,
Nihar,
I'll do
can
it for you.
can
Hold on.
Mark it.
Yeah.
The attachment to the heart and the attachment to the.
Yeah, so this is the portion that goes onto the heart. Those 4 are the suction cups.
That's these here. 1, 2,
Yeah.
3, 4.
Yeah, so 4 suction cups on each side. Yeah, that's it. This is a little tube that goes to the main suction device. So we apply a pressure of a vacuum of about 200 or so, and this is how it is held. This goes onto the clamp, the chest clamp, and it fixes to the chest clamp. And this is what tightens this cable, which holds the heart in place.
Thank you, sir. So it just shows that our residents don't go to the OT enough. But a big hand to Team
You
A.
must not be sending them, Nihar.
But they do go to Japan and catch octopuses, sir. Okay, Team B, ready for your question? A 25-year-old male presented with chest discomfort and history of fever and rash in childhood. What is the diagnosis? And what does the picture show? That is the picture on your right. Please switch on the mic.
How low? Mic.
Okay, you answer, we'll hear.
Strawberry.
So
Excellent.
Kawasaki disease and strawberry tongue.
Excellent.
Give them a big hand, please.
Very good.
So a lot of coronary and cardiac manifestations of Kawasaki disease.
So the point here is keep so many of the ectatic coronaries that we see in adult angiographies may actually be residue from childhood Kawasaki's. That is what we are now, arrested Kawasaki's. That is what now we are recognizing.
All right, very good. So now we are coming to the last question of the quiz, which is the buzzer round. So everyone, mics get your mics ready.
Provided there is, even if there is a tie, it's okay, I think. We will give first prize to the...
First
We have
prize?
less time. No, what I meant...
Last question. Yeah. This is a good question, sir. So,
Sir.
okay, all right. We have already got a team A, but wait, let's just go through the question. A 20-year-old male in the ICU with septic shock. What is the sign called, and what is the relation between both pictures? Okay, go Team A.
It's called as a Pickelhoff sign. It can be, it's all, because it resembles the helmet, the spike on the helmet that's seen. And it's most critical care patients who are suffering from septic shock in ICU settings, we can see this.
Fantastic. Please give her a big hand.
1 minute. Where else do you see this sign in cardiology?
Malignant mitral valve prolapse and
Fantastic.
tissue Doppler.
Very good.
Good. Okay, so I will read out the scores. So Team A has 70 points. Team D has 70 points as well. Team C has 30 points, sorry. And Team B is the winner with 80 points. So please stand and just introduce yourselves and the hospital you all are from. It was very close. We have 2 teams at 70. So a big hand to all the residents. And can we have Satyavan Sharma sir and Pehlajani sir just to give the prizes, sir, please? Please introduce yourselves.
Well fought quiz. Congratulations, everyone.
Somesh Nagre, DM resident from Bombay Hospital.
I am Dr. Advait Mulgekar, DRMD Cardiology from HN Reliance Hospital.
I am Dr. Anita, DRMD Cardiology from Jagjeevan Private Hospital.
So the gift that you all are getting is a book called Dallin Alpert. Satyavan Sharma sir and Pehlajani sir, please sir. Okay, come please. So Dallin Alpert, as you all know, is not easy to get, and it took us a lot to get this book, but it will help them in their studies. So congratulations to all 3 of you all.
यार और पढ़ने को लगाएगा उनको.
A big thank you to Ajit Desai sir, Milind sir and Saurabh. They've really come up with these fantastic pictures and images. And, it just took our discussion on SCD and CAD in the young to another level. Thank you so much. We also have certificates for all of you all who've participated. So just please come and collect them from me. Yeah. Well, thank you very much, everyone, for a wonderful day of some fantastic academic lectures, talks, debates, case-based presentations, and to top it all, a quiz. Please join us tomorrow at 9 o'clock sharp, back right here. Well, good night and see you all tomorrow. Please join us for dinner as well.
Yeah, I think the fellowship starts in the same hall after 15 minutes. So please hang around, and the dinner is already served. So those who want to start with dinner can go to the launch for the dinner, and the fellowship starts in about 15 minutes in the same hall. Thank you.
No, I have this question for all seniors. Every meeting we say ki fellowship. What is this fellowship? I have still not understood.
Meeting friends. The executive committee meeting, the EC meeting will be in the faculty lounge, please.